الرئة المفروض يكون ضغطه واطي عشان القلب لما يتدفق الدم داخل الرئة تستطيع الرئة أن تستوعب كل تدفق الدم من القلب.
جميل. أبرز المراكز لدينا في المملكة لمعالجة هذا المرض؟
بفضل الله المملكة متقدمة جدا في تشخيص وعلاج المرض. هناك 4 أو 5 مراكز كبيرة. مستشفى الملك فيصل التخصصي على سبيل المثال ربما هو الأكبر والأكمل من ناحية التدخلات الجراحية والعلاجية والتشخيصية، لكن مركز الأمير سلطان لأمراض القلب في المستشفى العسكري، المدينة الطبية، منظومة الحرس الوطني عندهم مركزين، في الغربية عندنا تقريبا مركزين أيضا، في الحرس الوطني في وزارة الصحة متخصصي مدينة جدة. فهناك بفضل الله مراكز في المملكة ويديرها مجموعة من الزملاء متخصصين في هذا المرض وقديرين، والعلاجات بفضل الله أيضا متوفرة. يعني حكومة بفضل الله ما لم تقصر في هذا الموضوع.
أغلب المراكز تعالج كل الأنواع التي ذكرتها قبل قليل لمرض ارتفاع ضغط الشريان الرئوي.
نعم ولا، طبعا لأن هي عديدة وتدخلاتها كثيرة.
نعم.
لكن بالعموم الأدوية متوفرة للعلاج الشائع للمرض. هناك تدخلات دقيقة تستوجب أن يتعالج المريض في مراكز متخصصة مثل الملك فيصل والعسكري والمدينة الطبية، وهناك تدخلات جراحية لواحد من أنواع ارتفاع ضغط الشريان الرئوي. هذا موجود في مستشفى الملك فيصل التخصصي، وله موجود في المنطقة يعني في العربية كلها بفضل الله. وهناك تبني أيضا لمثل هذه المراكز في بعض المراكز الأخرى في المملكة. مختصر الحديث هذا مرض نادر.
نعم.
وعلاجه صعب وتشخيصه دقيق، ويستوجب أن يكون في أماكن معددة محدودة في المملكة يعني أو حتى في أماكن أخرى، لأن الإشراف على العلاج والتشخيص بدقته وتفاصيله يستوجب أن يكون هناك متخصصين في هذا الموضوع وعندهم خبرة في هذا الموضوع.
جميل. نعم. تقدمنا في مسألة العلاج، المراكز المتخصصة في هذا الجانب كيف تقيم يعني وصولهم إلى يعني مستويات متقدمة من علاج هذا المرض؟
هو يعتمد على 3 أشياء رئيسية. الأول هو تخصص المشرفين على هالبرامج هذه في هذا المرض، بمعنى أنهم اكتساب الخبرة العالمية. والأمر الثاني توفر الأدوية، لأن أدوية يعني بشكل أو بآخر غالية. والأمر الثالث توفر بيئة العمل من ناحية التشخيصية، القدرة على التشخيص والقدرة على أداء بعض التدخلات مثل قسطرة القلب مثل الجراحة إلى آخره، لأنها منظومة وما ما يعتمد على الطبيب واحد، منظومة متكاملة من الأداء. فإذا توفرت هذه في مكان ما، كل هذه الأشياء في مكان ما، عادة يعني يكون هذا من المراكز المتقدمة المتخصصة في علاج هذا المرض، وهذه موجودة بفضل الله بالمملكة. ونحن في المملكة بالمناسبة متقدمين كثيرا على دول الشرق الأوسط في هذا المجال بالخصوص. والمملكة الآن لها بفضل الله سمعة في يعني في المراكز العلمية المتخصصة في ضغط الشريان الرئوي العالمية، وكثير من الزملاء يعني يشاركون في أبحاث علمية عالمية في هذا الموضوع، تلقى كلمات علمية وأوراق علمية في مؤتمرات علمية أيضا خارج المملكة. فالمملكة بفضل الله
وهذا بفضل التقدم الذي يحدث في
وهذا بفضل التقدم اللي يحدث.
هل ممكن دكتور أن يحصل يعني إصابة بهذا المرض ثم لا يتم اكتشافها إلا متأخرا؟
نعم، وهذا سؤال جدا ممتاز، لأن هنا المشكلة. شوف، خلال العقدين الماضيين من الزمن صار في ثورة تقريبا في علاج المرض وتشخيصه. قبل كذا ما كان في حتى علاج له يعني، لكن ما زال في نقص معلومة في كثير من الأماكن الطبية خارج المراكز المتخصصة في الموضوع هذا. ولأن المرض أعراض المرض شائعة ممكن تتشارك مع أمراض أخرى مثل الربو أو التهاب الرئوي أو غيره، فيتأخر التشخيص. وهذا بالمناسبة ما هو في المملكة بس، في دراسات عالمية. دراسة مؤخرا من أستراليا نشرت، يأخذ المريض عشان يوصل لنتيجة تشخيصية دقيقة 2 تقريبا، معدل 2. وهذا للأسف الشديد يعتبر متأخر، لأن المرض أصلا لما تبدأ أعراض المرض هو أصلا متأخر، فما بالك إذا يأخذ 1 أو 2 حتى يوصل التشخيص الدقيق.
ولهذا أتت الحملة التي تقوم بها.
ولهذا أتت الحملة لتوعية الأطباء والمرضى في الموضوع.
جميل. أشكرك رئيس الجمعية السعودية لمرض ضغط الشريان الرئوي الدكتور عبد الله الضلعان، شكرا جزيلا لك. شكرا.
Assalamu alaikum wa rahmatullahi wa barakatuh. On behalf of my colleagues and SAPH members, I welcome you to the 13th annual very extensive 3 days. Thank you all and have a safe trip back home. Assalamu alaikum wa rahmatullahi wa barakatuh. On behalf of my colleagues and SAPH members, I welcome you to the 13th annual meeting.
Welcome to our 11th SAPH meeting. SAPH is the Saudi Association for Pulmonary, specialized group of elite physicians in Saudi Arabia and including some of the Gulf region.
Part of the Saudi Association for Pulmonary Hypertension meeting, SAPH 2018, that was just held here in Dubai in April 2018. It's been actually a great meeting. I've had a chance to interact with some of the leaders in the field.
Every year this Congress is providing the best possible knowledge and evidence for the different treatments in any area, including drugs, including interventional procedures, and including also surgical procedures.
Pathogenesis, prevalence of PAH and connective tissue disease, diagnosis, prognostic and risk factor differences between idiopathic and connective tissue disease lately.
As I'm part of the SAPH family for many years now, I like to come to this conference year by year. The organization, as usual, is perfect, and the quality of the scientific program is outstanding.
We have more than 500 patients included in this different trial, meaning a lot of small trials, and we have the AIR study that are nicely showed in the previous meeting.
We're grouping many people from different countries, and from Europe, from the US, and from Saudi Arabia, and Dubai, and many other countries.
Many colleagues that really worked very well. From the international, I really need to say that the PBRI had a great role in SAPH success, so I'd like to have a basically special thanks.
All the experts in the field, get all the updates, and get to know your colleagues and mingle with them. SAPH is an amazing team, which we are really proud of, and I hope it will continue for years and years to come.
ارتفاع ضغط الدم داخل شرايين الرئة وليس الضغط العام. وبما أن يرتفع ضغط الدم داخل شرايين الرئة والقلب تدفق الدم من الجهة اليمنى من القلب يدخل الرئة. فإذا كان هناك ضغط عالي في شرايين الرئة يأثر على عضلات القلب بالذات الجهة اليمنى مع الوقت.
نعم ممتاز. طيب هل هو يعتبر مثل ما ذكرت في البداية أنه هل هو مرض نادر وهل تشخيصه سهل؟ وبرضه يا دكتور يعني كيف تشوف طريقة علاجه؟
هو طبعا نادر لكن لها أسباب كثيرة، بعضها شائع وبعضها نادر، وهو يصنف إلى عدة مجاميع. هناك ما تسمى المجموعة الأولى وهذه هي اللي نادرة، وعادة يعني بالطروحات والنشرات العلمية تقريبا بين 50 إلى 100 كل مليون يصابون في هذا المرض. وهو طبعا بحكم أنه نادر وبالتالي يكون تشخيصه في العادة صعب شوية، وعادة التشخيص يعني يتولى عملية فرز أسباب المرض، لأنه هو صحيح المحصلة هو ارتفاع ضغط الشرايين الرئوي المحصلة النهائية، ولكن لها عدة أسباب. دقة التشخيص تكمن في فرز هذه الأسباب، وبالتالي وصول التشخيص الدقيق، وبالتالي أيضا العلاج الدقيق، لأن لكل مرض لكل سبب من هالأسباب علاج خاص. Assalamu alaikum wa rahmatullahi wa barakatuh. Sabah al khair everyone, and thank you all for coming this morning for the first morning session of the last day of this conference. This session is going to be a case, real life cases that have been taken care of by different teams, and I truly encourage every one of you to ask questions. This is meant to be an interactive session, so you can stop the speaker anytime. You can ask any questions. If you want to ask after history, or you want to ask after a clinical exam, or you ask after differential diagnosis, anytime you are all welcome to ask questions. There will be microphones distributed by our colleagues from the audiovisuals for questions. The time allocated for each case is about 30 minutes, but I think we can do it much shorter than that. We waited for half an hour just to make sure that everybody attends. The first case is going to be presented by my colleague and my fellow, Dr. Abdullah Al-Faris. He is a pulmonary fellow at King Faisal Specialist Hospital in Riyadh. And he is going to present a case where PAH in pregnancy. There was a question yesterday about pregnancy and pulmonary hypertension, and this is a true representation, real life representation of pulmonary hypertension in pregnant lady. تفضل عبد الله.
Thank you so much, Dr. Dal'an. Please spare me a couple of minutes. I would like to send my gratitude as all thanks to Dr. Dal'an and Dr. Faiz for their continuity of mentorship and guidance. I'm truly honored and privileged to present this case. أنا محمل بأمانة من والدي العزيز لإرسال سلامه الخاص إلى شعب مصر. أتمنى أنه وصل السلام من قلبه إلى قلوبكم. حب مصر ورثته من والدي، إن شاء الله أنه أورثه لي ابني بإذن الله. Okay, so I will present inshallah the idiopathic pulmonary hypertension pregnancy. These are my objectives. I will talk about the physiological changes during pregnancy. I will go through the literature review and pregnancy. Then I will present my case scenario. I have none to disclose. So the first section, the physiology of pulmonary arterial hypertension and pregnancy. So pregnancy with pulmonary arterial hypertension is associated with a high maternal mortality. Current guidelines strongly discourage pregnancy and recommend an effective method of contraception in women of childbearing age with pulmonary arterial hypertension. However, if this fails, early pregnancy termination is advised. One of the earliest studies in 1979 by Glacier et al. Reported a mortality of 52% in a series of 70 pregnancies in patients with Esminger syndrome, with perinatal mortality of infants of 28%. Also a growth retardation in almost 1/3 of these neonates. So in terms of the right ventricular, the function of the RV is the major determinant of symptoms and survival. Treatment goal of pulmonary hypertension is obviously to preserve the RV function. Any decompensation of the RV can lead to death. So this is the normal physiological changes in the blood volume, the plasma volume, and the RBC volume in a normal patient in a normal pregnancy. So as we can see here, there is an increase. Yes. So there is an increase in the total blood volume and the plasma volume and the RBC. However, in the total blood volume and the plasma volume, they can take up to 40%, and later in the pregnancy, they can increase 100% in their volume. The RBC can increase to 25% in their volume, and that's the phenomena what we call the physiological anemia, which is normally can happen in pregnancy. In regards to the heart itself, the cardiac output obviously will increase to accommodate the increase in the plasma volume. The physiological changes of the body has to adapt this massive increase in the blood volume and the cardiac output by decreasing the systemic VR. The mean blood pressure, however, will stay the same or almost the same. What happened during labor? So during contraction, the cardiac output increased dramatically during labor, and it reaches maximum during delivery. Then after that, it decreases postpartum. And this is all normal in a normal patient. So imagine all these, the increase in the cardiac output, the increase in the plasma volume, the RBC, the contractility in a normal patient can happen in a pulmonary hypertension where there is an obstruction from the right side. Imagine that, think about the outcome, keep it in your mind. We'll discuss it inshallah in the case scenario while I'll go quickly through the literature review. So in the literature review that was published in the Journal of the American College of Cardiology, the outcome of pulmonary vascular disease in pregnancy in 1996, the mortality was showing 36% in patients with Esminger syndrome, 30% with primary pulmonary hypertension, and up to 56% in secondary pulmonary hypertension. So in summary, pulmonary hypertension is a killer disease in pregnancy, regardless of the cause. So in severe pulmonary hypertension during pregnancy, also, this is a case series of total of 14 patients with 4 primary pulmonary hypertension and 6 of congenital heart disease. It was published in 2005, and the American Society of Anesthesiologists reported an overall mortality of 36%. A glance on the is there an improvement in the outcome of pregnant ladies with pulmonary hypertension? This is a systematic review of 73 patients, case reports and case series from the 1997 to 2007. It showed there is somehow declining in the mortality. It has to be on therapy. However, still it's very high. There is a slight declining comparing to the previous era. However, still very high mortality. As it shows, there is 78% of this in the first postpartum month. This is a study also for the improved survival in pregnancy and pulmonary hypertension using an active therapy during pregnancy. However, it is a single center retrospective of 9 patients. All patients were put on therapy, including nebulization, prostacyclin. 4 of them were converted to IV. Only it showed 1 death 4 weeks postpartum. However, that patient who died stopped the therapy on her own. So what is the effect of anesthesia on the body? So significant decrease in systemic vascular resistance from sympathetic blockade from anesthesia agents can produce severe decompensation because the cardiovascular system may be unable to compensate for the decline in the afterload. Right ventricular contractility is marginal, and the addition of anesthetic agent can lead to marked depression in cardiac function. So I will start with my case. I hope that was clear for everyone in the previous two sections. So this is our patient. She is a 27 years old female. She was completely healthy. She presented to her local hospital with a complaint of exertional dyspnea. She reported 1 year history of progressive exertional dyspnea. She had an MMRC scale of 3. She denied any history of wheezing, cough, sputum production, stridor, fever, or any other upper respiratory tract infection symptoms. Also, she denied history of orthopnea, PND, or any history of lower limb swelling. Other cardiac history was negative, including chest pain, palpitation, syncope. No history of previous TB or infection suggestive of TB infection. Other systematic review were unremarkable, and she was not on any medications, including OCP. She denied any OCP use OCP previously. She denied any history of connective tissue disease, any previous history of venothrombotic events, any previous history of lung diseases, and cardiac diseases. So obviously the patient was completely healthy, coming with one complaint, which is the exertional dyspnea. So on physical examination that was reported in the referring report, she was vitally stable, a temperature of 36, at slightly tachycardic with a heart rate of 102. She was saturating well on room air, and she was maintaining her blood pressure. She was conscious, alert. She was not in respiratory distress. Chest auscultation revealed bilateral vesicular breath sounds with no added sounds. Cardiovascular system was unremarkable on examination, and there was no lower limb edema. And that was her chest X-ray when she presented to her local hospital. Completely okay, with some congested of the right pulmonary trunk. ECG, it was sinus rhythm. It was compatible with RV hypertrophy. She underwent blood workup, including and all of the workup came back negative, including the CBC, renal and hepatic profiles. Her proBNP was at that time 301. She had normal coagulation profile. Cardiac enzymes were negative. She had a negative HIV, negative hepatitis B and C serologies. Her autoimmune workup was negative as well. Inflammatory markers as well as schistosoma antibodies were negative. So all these were done in the local hospital. So they had to investigate her exertional dyspnea that was progressive. So she underwent CTPE, CT pulmonary embolism study, which is CT angiography, and was negative for any pulmonary embolism and lung parenchymal changes. She underwent pulmonary function test. She had a normal FEV1, FEC, and the ratio. However, she had an isolated reduced of the DLCO. VQ scan was carried out and showed no mismatched perfusion defects. So she underwent echo with these findings. The pulmonary artery systolic pressure of 70 with a tricuspid regurg velocity of 3. She had a severely dilated RV and RA with a normal LV function. Keep in mind, all these investigations were done at the local hospital. So based on this echo, the referring hospital, they proceeded with the right heart cath. So which was done and showed the mean pulmonary artery pressure of 40 with a wedge pressure of 15 and a PVR of more than 3 Wood unit. So this is compatible with the diagnosis of pulmonary arterial hypertension. She was started on sildenafil and warfarin, she reported improvement in her dyspnea on exertion. She was on functional class 3, that was improved to functional class 2. So there is some improvement when she was started on targeted therapy. Any questions? We'll come to that.
Okay, thank you.
We'll come to that.
So basically, this is a young lady who was diagnosed in her local hospital. She's from Jeddah, and she presented with 1 year history of shortness of breath. She had a full investigations done, and the diagnosis at that time, idiopathic pulmonary arterial hypertension. She was started on sildenafil. I don't know why they started her on warfarin, but they did, and she had some improvement. Any questions?
Actually, I would like to ask why you added warfarin. I don't think it's a
local hospital. We didn't know why.
Oh, okay.
Yes.
So,
what about the immunological marker for this patient? Some cases with idiopathic pulmonary hypertension diagnosed retrograde to be antiphospholipid or autoimmune connective tissue disease.
All her workup were negative, including the autoimmune and the immunological workup from the referring hospitals. Yes, Doctor.
Excuse me, just comment about the systolic pressure gradient by the echo. It was 70.
Yes.
The systolic pressure or diastolic pressure, you mean?
Systolic, pulmonary artery systolic pressure.
This means that there is pulmonary.
There is what?
It's not the gradient. This is the system. This is the
pulmonary artery systolic pressure.
Yes.
I'm not.
Yes.
Okay.
this is one of the problems that we face. We don't need a comment on pulmonary artery. We need the tricuspid valve, regauge velocity, and the other armamentarium of diagnostics for right ventricular strain.
So I will proceed. She was diagnosed with idiopathic pulmonary arterial hypertension. She was started on sildenafil and warfarin, and she was referred to King Faisal Specialist Hospital, however, in Jeddah. So she was accepted there. When she was seen in the clinic, she complained of dizziness. However, she denied any syncopal attacks. Another echo was done at King Faisal in Jeddah, which showed pulmonary arterial systolic pressure of 70 with a velocity 3.1 and severely dilated RV and RA, ejection fraction with 50%, normal LV and LA sizes.
Abdullah, how long after the initial diagnosis she was referred there with these findings? 1 year or 2 years?
I think 1 year. She was 1 year. She was kept in, yes.
Yes. So 1 year later, she had, I think 2 years actually. I think 1 year.
I only need.
Okay. So 1 year later, she was referred to King Faisal, by the way, is a healthcare system. The main campus in Riyadh, there are 2 branches, one in Jeddah and one in Medina Munawwara. So because she's from Jeddah, she was referred to the branch of King Faisal in Jeddah. Now with these findings, after 1 year of treatment with monotherapy.
Yes. So when she was seen in King Faisal, sildenafil was continued, bosentan and prostacyclin inhalation were added. At that time, obviously, she was strongly advised not to get pregnant. However, the patient, she was insisting on pregnancy. So in April 2013, the patient became pregnant. She presented to her primary pulmonologist in Jeddah. She was 8 weeks of gestation. So bosentan was stopped as it was teratogenic. So sildenafil and alloprost were continued. Warfarin was changed to enoxaparin. Echo at that time showed systolic pressure of pulmonary artery 80 to 90. Miraculously, in December 2013, the patient underwent an eventful elective C-section at 37 weeks of gestation under GA. Echo at that time, the pulmonary artery pressure, systolic pressure was 110. The period from 2014 to 2017, she had a regular follow-up in the clinic, had been stable from pulmonary hypertension point of view. Bosentan was changed to macitentan. February 2017, she became pregnant again. She was 9 weeks of gestation. However, the patient was wise enough to agree to terminate her pregnancy. In February 2018, the patient became pregnant again. She was gravida 3, para 1 plus 1. She was 25 weeks of gestation. So the patient insisted to continue her pregnancy. So macitentan was stopped, sildenafil, iloprost, and enoxaparin were continued. In March 2018, she was referred to our center. So we saw her in March 2018. She was 36 weeks of gestation.
So she was referred to us at King Faisal in Riyadh.
Yes.
Already 36 weeks of pregnancy. So she is at the time of delivery, basically.
Yeah.
I don't want to disturb the clinic, but can you go back one slide?
Sure.
So she was, this last pregnancy, she was on macitentan until she was 25 weeks in her pregnancy. And you know, macitentan is very teratogenic. Because she got pregnant, she did not talk to her doctors in Jeddah. So she kept even the macitentan on board.
Yeah.
Okay.
So when we received her, the vital signs, she was afebrile, a little bit tachycardic with the oxygen saturation acceptable on room air, blood pressure is maintaining. She was conscious, alert, not in respiratory distress. So basically, it was negative physical examination. There was no positive findings. So this is in summary, chronologically, as of April, when we saw her 2018. So her first pregnancy, it was delivered through C-section in 2013. She was having a pulmonary artery systolic pressure of 105. Second pregnancy in 2017, that was terminated. And this last pregnancy in 2018, when we saw her with 36 weeks of gestation. She was having function class of 2, negative examination, apart of course the positive findings of the pulmonary hypertension, loud P2. She was on sildenafil, iloprost, and enoxaparin. So macitentan was stopped. Echo at that time, it showed ejection fraction more than 55%. It was she was having moderately dilated RV and RA. Pulmonary artery systolic pressure showed severe pulmonary hypertension with a TR velocity of 2.9, no significant valvular disease, and no pericardial effusion and no shunt. So obviously, the patient, she's approaching to delivery, high risk patient. So an urgent MDT discussion was arranged, including pulmonary team, our team, obstetric and gynecology, ICU, and anesthesiology. And the final consensus that the patient was very high risk and agreed to proceed with an elective C-section, however, with a spinal anesthesia, not under GA. So now starts the interesting part. So on the day of operation, in the OR, during the induction of epidural anesthesia,
if you allow me, Abdullah, just a minute. So in the MD multidisciplinary meeting, all these specialties should be around, including, by the way, ECMO team. So the pulmonary hypertension team, the OBGYN team, the anesthesia team, ICU team, and the ECMO team, because it's very high risk pregnancy. And the only part you haven't mentioned, Abdullah, that we all gave her medications because she's already late. She's 36. So we on call to OR delivery room. We gave her the sildenafil. We gave her the iloprost. Yeah, and she was taken there.
So in the OR, during the induction of epidural anesthesia, the patient arrested. So a CPR was initiated. So she achieved ROSC. The delivery of the baby was done successfully. Patient required intubation, anaerobic support. Cardiac surgery were called for ECMO cannulation, and she was started on VA ECMO. So sildenafil, macitentan, and parenteral therapy were resumed. Echo during this event showed ejection fraction of 20% with global hypokinesia. So imagine how many teams they were working on that patient during the arrest. One team, they are delivering the baby. Another team, they are inserting the ECMO cannula, and we are inserting her parenteral therapy from our side to start her own targeted therapy. So it was a very busy scene and very busy OR. So the patient was shifted to the ICU. This is her chest X-ray with all the cannulas and the central lines. She was intubated at the time on an inotropic support. So day 2 post-op, patient was still intubated. However, inotropic support was turned off. She was maintaining blood pressure and her MAP was normal. Day 3 post-op, echo showed some improvement of the LV function, and her ejection fraction from 20% became more than 60%. So complete normalization. Day 4 post-op, she had some hypotension. Her hemoglobin dropped. She underwent ultrasound abdomen, which showed hematoma at the site of the C-section. Do we blame the OB-GYN? Of course not. It was a hectic situation. So she was found to have a hematoma at the surgical site. She was rushed back to the operating room, and 3 liters of blood was evacuated. Day 5 post-op, she was decannulated from ECMO, and later patient was extubated. Day 6, this is the some turning of events. Day 6, the patient developed another arrest, PA. Alhamdulillah, she survived without any tropic support or intubation, and she was revived only after 2 minutes of CPR.
If you allow me, Abdullah.
Yes, go ahead. Yes.
لازم تخرجها إخراج exciting. تحط مؤثرات صوتية وخليني أنا أعمل هذا الدور. So this is a patient who came already late. She was ready for delivery. It was too late for us to start any IV prostacyclin infusion, which is the standard care for these patients. The standard care, whenever there is a patient who is insisting for, of course, the standard care is to prevent pregnancy completely and equivocally. But of course, this lady has different ideas. Now, if you are in a situation when a patient insisted or came to you already more than 12 weeks of pregnancy and she wants to keep the pregnancy, then the standard of care is to start her on IV prostacyclin, because this is the only potentially saving drug for her. Besides sildenafil, obviously, no ERAs, no bosentan or macitentan, because they are very highly teratogenic, and no reyesiguat, because it's also highly teratogenic. So at least dual combination therapy, one of them should be prostacyclin, because that's allowed. And you build it up, you up titrate this as she goes into pregnancy. By the time the delivery time comes, which is by the way, recommended between 32 to 34 of weeks, maximum 36, if the patient is doing well. But earlier is better, because patient at the end of the pregnancy, they really worsen. Now, and by the time they reach the time for delivery, a patient should be already on a very good dose of prostacyclin IV. Let's say 20, 25, or 30 nanogram per kilogram per minute. And then you can take them to the OR for cesarean section. But this patient came at week 36, no time to start up titration. You cannot reach 70 weeks of pregnancy. So the only way at that time is to put her on inhaled prostacyclin. The iloprost is an inhaled prostacyclin. You give her the sildenafil, and you do your best. But here is the situation. In academic institutions, when you have all good teams, everyone in each own specialty, you have very good ECMO team, you have very good anesthetic team, you have very good surgeons, you have very good intensivists, and so on and so forth. So the patient was in arrest. There was one team who was doing CPR and intubating, one team delivering the baby, one team putting the ECMO, and Hamdiya and the team is preparing the prostacyclin. The ICU team was around. So by the time the patient was revived and the baby was out, it's probably 15 minutes or so. And because of the stunned heart, because of the CPR, her ejection fraction was only 20, and she was already in pulmonary edema. But by that time, she was in ECMO also. So she is relatively safe. And once she was in ICU in 15 minutes, Hamdiya was ready with her prostacyclin infusion pump. And because she's intubated and sedated, so we went very high, rapid rate in up titrating the prostacyclin. So the second day, 24 hours later, she was already on 25 nanogram of treprostinil, if I am correct, Hamdi. So she was already getting the maximum dose in 24 hours. And that's why the second day, she was hemodynamically stable. The heart is getting relieved now. She was off inotrope second day.
Yes.
And alhamdulillah, that's what happened. One would ask why she developed another cardiac arrest 6 days later. She was extubated. She was actually doing fine, hemodynamically stable, but her husband visited her and she arrested. Seriously. Emotionally, she was excited and very big surge of sympathetic drive in a very sick heart. Imagine these patients cannot even tolerate emotions. And she arrested. She saw him, she was happy that she's alive, and she arrested. But because it's, you know, just sympathetic drive, she had only 2 minutes of CPR and she revived.
She revived.
I think that Abdullah will continue, of course, but the message from this clinical scenario that pregnancy is a killer. Patients should not be allowed to get pregnant. 2, when you are faced with these patients, you have to have a multidisciplinary approach.
Yes, absolutely.
I want to ask you about this is an excellent and marvelous multidisciplinary treatment, and I am astonished that she will survive.
She's a fighter.
What about the liver enzymes and renal function at the 2 arrest and the hematoma collection and the collection of 3 liters of blood? What about the other organ at that time?
Yeah, so she had some acute changes, obviously, acute rise in her liver profile and renal profile. However, it was declined and it was normalized afterwards. Yes. So she had, yes, absolutely.
Yeah.
Okay. So this is her
There is
chest. Yes.
2 questions there.
Sure.
I'm asking if there is electrolyte disturbance between day 4 and day 6 can contribute to the arrhythmia and arrest, apart from husband emotion and this thing?
She was not in severely electrolyte disturbances, no.
Sorry, I am asking about the baby, condition of the baby.
It was completely healthy.
There is no congenital anomaly because of using
completely healthy.
Yeah.
So that was her chest X-ray when she was shifted to the ICU. She developed pulmonary edema, severe pulmonary edema, and ECMO was there already. So days later, this patient was actually discharged from the ICU. We were following her on the floor. She had significant improvements, and she was hemodynamically stable. So she survived 2 arrests. She was doing excellent clinically and vitally stable. So we kept her for a couple of weeks, and then she was discharged home. Of course, an intrauterine device was inserted as a method of contraception prior to discharge. So so we saw her 1 week.
مؤثرات لا تنسى ارجع شوي.
Okay, sure.
So we brought her baby. Remember? She had her baby. We brought her in the room after like day number 7.
Yes.
Her baby name is Turkey. And remember when we call? You don't remember because you were not with me at that time. But she had her baby. She was actually not breastfeeding her baby. No, was actually. But she spent the last few days in the hospital with her baby, who was completely normal, young boy.
Yeah. So she was discharged clinically and vitally stable. So a 1 week follow-up after discharge, she was discharged on sildenafil, macitentan, and treprostinil pump. She was having functioning class of 1. Her proBNP during the events of during inpatient, she was having 10,000 of proBNP. That was decreased to 135. 6-minute walk test improved from 207 to 529.
طيب, stop there, Abdullah. Now this is a patient who came on the follow-up. Completely normal function class, completely normal proBNP, and completely normal 6-minute walk test. 529, maybe half of the room will not walk for half a kilo. Now, at that time, she was on sildenafil. She was on IV subcutaneous treprostinil infusion, and she was on macitentan. So triple combination therapy, and the patient is doing well. Would you stop there? I think this is the main, another message from this case scenario. How many people will stop there and continue, and how many people will do other things? لو تشيل السلايد هذه.
Okay.
How many people will stop there? Because what you need to achieve, you already achieved. Normal person now on triple combination therapy, doing very well. Her baby is doing well. You just continue, right? Or you do something else. Let's just vote. How many will do something? Or first, how many will continue? Just 1, 2. And how many will do something else? Just. What? حطينا IUCD hoping إن طبعا قلنا tubal ligation. Yeah, tubal ligation زي ما قالت الدكتورة. بس during the rush of the CPR there was no time to do any tubal ligation. Then we discussed that with her. Yes. Anybody else? خلينا أقرب لكم السؤال أكثر. تفضل دكتور.
السلام عليكم. هو احنا معانا الكلينيكال بارامتر تبع الريسك ستراتيفيكيشن. احنا الجول تبعنا ان احنا نحافظ عليها على اليلو على الجري زون.
صح.
فاحنا في معانا some invasive procedure like الكارديك اندكس والرايت ارتيريال بريشر لازم نعرف وضعه ايه، لكن احنا معانا كلينيكالي ولابراتوري العيانه نوعا ما افضل.
Yes, that's one reason, but there is another reason.
Well, I'm looking for something. Did this patient has during her right heart cath doing vasoreactivity?
يلا خرب علينا التست الدكتور. ليش تخرب علينا؟ Anyhow, I think that's one of the it is the main reason why we repeat it. So we decided to repeat our right heart cath. Remember, this patient came 30 weeks of pregnancy. She was only a few days from delivery. There was no time to repeat any investigation that was done previously. And we tend at our center to repeat everything actually, because we had some patients who were not investigated well, so properly. So we had a plan, and any patient who has been worked up outside, even from United States, we will still repeat our own workup. So that was the main reason. And then when we looked at the previous cath, زي ما قال دكتور أيمن, there was no vasoreactivity test done, at least not written in the report. We didn't know it was done or not done.
Yeah.
So proceed, Abdullah.
So,
Doctor, I want to ask you, what about the role of diuretic post-delivery?
She had.
And is there any role of anticoagulation for this patient later on or not?
She was not having any VTEs. So we stopped the anticoagulation, obviously. The workup for VQ scan CTP was negative totally. And she was not having high risk for antiphospholipid syndrome. So we stopped the anticoagulation. We put her on prophylactic only during the inpatient, and she was discharged only on triple therapies.
And she was given diuretics, of course.
Yes. Of course.
So Adeli, actually anticoagulation is debatable. Some centers give, some others don't give. I mean, in the idiopathic. Well, there is no benefit out of this, but if you have doubt that this patient, for example, is post-operative, and so you can give prophylactic treatment. So it's debatable, even in the guidelines.
So 3 months later, when we caught our breath and the patient caught her breath, so we arranged for a right heart cath. So I hope it's clear. So she underwent a right heart cath with a mean pulmonary pressure of 53, capillary wedge pressure of 15, cardiac index of 2.3, PVR almost 3 with units. So typical idiopathic pulmonary arterial hypertension. This is the vasoreactivity test. So the mean pulmonary artery pressure of 32, the capillary wedge dropped from 15 to 8, with increase in the cardiac index and the further decrease in the PVR. So that's the most important test to determine a multi-hundred of thousands of dollars for of therapy versus only like $10 of therapy. So just one slide of the definition of acute and long-term response. Acute pulmonary vasoreactivity for patients with idiopathic, hereditary and drug-induced pulmonary hypertension. If there is a reduction of mean pulmonary artery pressure more than 10, and the mean pulmonary artery pressure less than 40, is there increase or unchanged cardiac output? Long-term response to calcium channel blockers defined as function class 1 or 2 with sustained hemodynamic improvement after at least 1 year on calcium channel blocker only. So a follow-up, patients in April, obviously we stopped the targeted therapy. She was started on calcium channel blocker. She was started on nifedipine, 30 milligram. She was doing well, no hypotension, no tachycardia, and the dose of the nifedipine was gradually increased to 60, 90, and later on she was on 120 milligram, of course, with at the same time titrating down her prostacyclin IV. She was admitted because she needed to be under supervision when we started on calcium channel blocker, along with titration down of the prostacyclin. So she was discharged on nifedipine along with Lasix of 20 and spironolactone of 25 milligram daily. So 2 months later, we saw her in the clinic after discharge. She was function class 1. She was totally asymptomatic, hemodynamically stable, 6-minute walk test of 552. Remember, she's only on calcium channel blocker, proBNP of 113, and she had a normal renal profile. Another follow-up in February 2020, same function class of 1, hemodynamically stable, 6-minute walk test actually increased to 630, no desaturation during the workup, during the test. The proBNP of 46, renal profile was normal, and she denied any chest pain, dizziness, or palpitations. So patients who had 2 cardiac arrests survived them with a healthy outcome. She was on triple therapy, including the IV pump, and the very happy ending that she was vasoreactive. So the take-home messages: MDT is a must in these patients. She's a very high-risk patient. We have to consider an elite group of physicians to treat this patient when she comes at the end of the pregnancy. And this is my conclusion. If there is any question, I'll be happy to receive them.
Very, very nice. In fact, it's a fascinating case, and actually it's very good work. At the same time, it carries a lot of messages. I will start from what Professor Abdullah asked about.
Yes.
Would anybody escalate the treatment before we know the vasoreactivity? The answer is no.
Yes.
We don't escalate treatment if it is non-vasoreactive. That's why I asked for the vasoreactivity, because I never found this benign scenario if it is not a vasoreactive. Correct me if I'm wrong. So actually, we don't have in our literature much cases of pregnancy that lived and they are not non-vasoreactive. The only they passed and they got the pregnancy and succeeded, they were the non-vasoreactive. Although we don't have a recommendation up till now to let these patients get pregnant. So pregnancy is absolutely contraindicated. The issue here is this is a completely different phenotype. What happens in the vessels is so different. It is a kind of vasoreactivity and vasodilatation after you give the treatment. But what happens in the non-vasoreactive phenotype is it is a remodeling. There is fibrosis, intimal fibrosis, and the adventitia is very thickened. It is a different phenotype. Thank you very much for this scenario and for the success. And actually, it carries a lot of messages. Thank you very much for this.
Thank you for listening. Thank you very much.
Any more questions from the audience, Doctora?
more specific for pulmonary hypertension.
عيد السؤال دكتور عشان يسمعك الدكتور. أعطيه الميكروفون لو سمحت. أعطيه الميكروفون.
I want to ask you why you use nifedipine as a calcium channel blocker. Most of the study altiazem or deltiazem is more specific for pulmonary hypertension. Particularly, there no side effect as edema and tachycardia.
Actually, all the calcium channel blockers can be used for vasoreactive pulmonary hypertension. There is no clear difference in literature between any one of them. Actually, our preference is in fact nifedipine, and we thought it probably worked better. But there is no difference in literature between any calcium channel blocker. The aim of calcium channel, the dose of calcium channel blocker, however, should be higher than those we use for other indications, especially cardiovascular indications.
And finally, I congratulate you for this excellent case.
Thank you so much.
May I add something, Dr. Abdullah? Actually, this is a good notion, and usually we give both treatments. You look at the pulse rate of the patient. If the patient tachycardiac, it's better to give altiazem. If the reverse, it's better to give the nifedipine. So you can adjust the kind of treatment according to the pulse rate of the patient.
And AMLOR, of course. I think the message from this case is clear. The earlier messages I mentioned, but the last message I just want to reiterate on is the fact that if you don't complete your workup, remember the first talk yesterday was about diagnosis. If you do the diagnosis based on the algorithm, you will not miss anything. This patient had no vasoreactivity done originally. And then now instead of keeping her on very expensive medications, we only kept her on $10 cost medications because we repeated her CAT. This is very important. This is when it comes to diagnosis, please complete the diagnostic algorithm. And by the way, the fact that she survived زي ما قال دكتور أيمن from 2012 till 2018 when she came to us, it gives you an idea that this patient did not have severe idiopathic pulmonary arterial hypertension of the non-reactive type, because other than that, she would not have survived that long until she came to us in 2018. So this is by itself is an indication that you have to repeat your workup, make sure that she is not or is vasoreactive.
In fact, Dr. Abdullah, I have an inquiry here. I have few patients with vasoreactivity, and one of them, and almost all of them, they took empirically bosentan and sildenafil, and they were not doing well.
Yes.
Until we do the right heart cath, and then they discovered the vasoreactivity, and we shifted them to calcium channel blockers. They come to function class 1. Sometimes they go to no exercise, and I'm trying to adjust the kind of exercise they are doing. So the notion I found here that when I have a vasoreactive patient who is in big trouble and in emergency, I'm asking actually. So iloprost and the IV prostacyclin would be our result in such cases. I mean, vasoreactive phenotype who is in emergency, is in shock, for example, or okay.
Yeah, they still work for this, like her, for instance, if she came at week 26 or 28, I would still have started her on IV prostacyclin to get her through the pregnancy. Of course, with calcium channel blocker.
So yes, the prostacyclin is a magic bullet, I think, for our treatment.
Yes. Yeah, the last comment we don't want, I think we are already beyond our time, is that you have to be careful in interpreting the vasoreactivity test in a patient already on target therapy, already in vasodilator therapy. So this patient was on actually triple vasodilator therapy, on treprostinil IV, on macitentan and sildenafil, and we did the vasoreactivity test. Sometime if it's borderline, if the decrease is like still more than 10 according to the criteria, but to 39, for instance, or something like this, maybe you have to be careful. You don't stop the IV. But this patient was significant, dropped from 53 to 32. That's more than nearly 20 or so. So again, you have to be careful in interpretation this one. Okay, I think Dr. Adeli will present the other speaker, introduce us, or Dr. Ayman. Okay.
Actually, it's my pleasure to introduce Dr. Faisal Albays, Dr. Faisal Base is a pulmonary fellow, King Faisal Specialized Hospital and Research Center, Riyadh, Saudi Arabia.
Okay, good morning, everyone. Thank you for the introduction. So before I start, I would like to thank Dr. Abdullah Darhan and Dr. Faiz Al-Hamdi for arranging this conference and giving me the opportunity to present. I would like to also thank all the organizers who made this happen. So I'll start first with this case. Now, in contrast to my colleague Abdullah, I'll cut to the chase and start with the case, and at the end, I'll speak briefly on PVOD. So let's start. This is a 23-year-old lady. She is from Jeddah, which is the western province of Saudi Arabia. She's married and only has one child. Now, her initial presentation started in her local hospital rather than in our hospital. She initially presented with progressive exertional dyspnea for around 1 year after she gave birth to her first child. She had significant exertional dyspnea with the WHO functional class of 3. And she decided to seek medical attention after 1 year when she noted that her exertional dyspnea has been affecting her daily life activities. She had no history of dyspnea at rest, no orthopnea, syncope, chest pain, palpitations, or any signs of right-sided heart failure at that time. She had no history to suggest connective tissue disease, no history of cardiac disease, lung disease, any hematological diseases, VTEs, or any use of illicit drugs. And she had no history of miscarriages or family history of pulmonary hypertension. Now, on examination in her local hospital, she had an oxygen saturation of 85% while breathing ambient air, and she was requiring oxygen for around 2 to 4 liters, depending on her exertion. She had a elevated JVP, she had a loud P2, but the rest of cardiovascular examination was unremarkable. Her chest exam was unremarkable as well, and she had mild bilateral pitting lower lymphedema. Now, her labs at that time, relatively, they were normal. She had normal hemoglobin and normal renal function and hepatic profile. However, her proPMP was elevated only about 500 picogram per ml. Now, her echo at that time in local hospital showed an ejection fraction of 55%, a right ventricular systolic pressure of 85 millimeter mercury, and a dilated right ventricle, a moderately reduced right ventricle function, a moderately dilated right atrium, normal left atrium, and a moderate tricuspid regard. And she had some small pericardial effusion and a non-significant small PFO. Now, looking at her echo, clearly, this echo explains the patient's presentation with exertional dyspnea, that most likely she has pulmonary hypertension based on echo. So she was started straight away on the pulmonary hypertension workup before they proceeded with right heart cath. And the workup showed that she had a normal VBG, normal infectious screen, including hepatitis, HIV, and schistosomiasis, and normal autoimmune workup as well, and normal thyroid profile. Now, this was her chest X-ray initially on presentation. As you can see, relatively, the chest X-ray looks normal, apart from a prominent pulmonary artery. Now, since clearly what she had is pulmonary hypertension, which is also evident on the chest X-ray showing prominent pulmonary artery, further work was done for the pulmonary hypertension, which included a VQ scan, which ruled out SAPH, and abdominal ultrasound, which also ruled out presence of liver cirrhosis or portal hypertension. Now, then she proceeded with right heart cath. Now, right heart cath showed a mean pulmonary artery pressure of 53, so it showed a severe pulmonary hypertension, a mean right atrial pressure of 8, which is borderline normal, and a capillary wedge pressure of 6, which is normal, and a pulmonary vascular resistance of 17 Wood unit. Her cardiac output was relatively normal. Unfortunately, at that time, vasoreactivity testing was not done. So overall, what we had initially was a pre-capillary severe pulmonary hypertension. Now, the interesting part here is, as part of the workup, we proceeded with CT chest just to look for any clear lung diseases to explain her pulmonary hypertension. Now, as you can see with this first cut of the CT, it showed clear peribronchovascular ground glass opacities, diffuse and bilateral, with small septal thickening. And if we look at the pulmonary artery, although not the best image to show it, it showed an enlarged pulmonary trunk. And the third image, when looking at the mediastinal window, showed mediastinal lymphadenopathy. So we have all these three triad of presentation. So looking at it overall, she had a hemodynamic evidence of pre-capillary pulmonary hypertension without clear secondary cause. Particularly, there is no signs of left-sided heart disease. And she had radiological features of pulmonary hypertension, radiologically, signs of venous congestion, and mediastinal lymphadenopathy. So looking at the overall features and everything.
Can you stop here?
Yeah. So.
Anyone will suggest the diagnosis? If somebody did not read the title of the talk, because it was already on the title of the talk. So we have a pulmonary hypertension, a young patient with pulmonary hypertension and radiological changes suggestive of something. Okay, proceed.
Okay, so the most likely diagnosis based on clinical and radiological features is pulmonary veno-occlusive disease. And looking at how typical her presentation was, this most likely we will not proceed with any lung biopsy since this is almost diagnostic. So the final diagnosis, as we mentioned, is a PVOD with severe pulmonary arterial hypertension. And at her local hospital, she was initially managed with Lasix, and they decided to give her a trial of sildenafil. Now, when we followed her up after starting sildenafil.
Excuse me, at this stage, before we reach the final diagnosis, I will go back to the question of Professor Abdallah. What else would jump to our minds? Of course, sarcoidosis can be one of the probabilities. Hypersensitivity pneumonitis, if this patient has exposure to something. So I believe we need to go through these things and think. Of course, I'm talking theoretical. Of course, I'm with the diagnosis. In such cases, I would think of the sarcoidosis as, in most cases, it's a benign disease, and usually with extensive fibrosis, usually we don't find the patient hypoxic, as you illustrated. Also, I think the pulmonary function would add something in this stage. Again, the patient has bilateral glands. However, the lungs are congested, and there is centrilobular GGOs, which is characteristic for PVOD and not common in sarcoidosis. Then we go to the HP, hypersensitivity pneumonitis. So I would ask this patient if he is exposed to something like birds, for example, or paints and so on. Although we know that there are some exposures that can lead to PVOD. So PVOD can be found, it's a secondary disease to, the acrylic substances. So I think this is a stage that we need to ask about these things at this stage before we are happy that we have the devastating disease of PVOD.
Yeah, thank you for the comment.
The same thing is of Dr. Ayman. I was thinking about the possibility of sarcoidosis. Why you didn't do a screening for other lymph node, generalized lymphadenopathy, and the inflammatory marker CR and CRB to exclude other causes of lymphadenopathy, mediastinal lymphadenopathy?
So inflammatory markers at that time was normal. However, all these workup and images were done in a local hospital. So patient presented to us later. So this is just looking at it retrospectively. However, to further support the diagnosis of PVOD, the following finding will show you that after she started sildenafil, the patient did not improve. Actually, she began to get gradually worse over the next 1 month of starting a treatment. And her symptom was associated with orthopnea, and she had worsening lower lymphedema and increasing pro-BNP. It was 500 and now around 1,000. So in the local hospital, when they saw that this happened to the patient, they stopped sildenafil straight away. They admitted her in the hospital for intravenous diuresis. But despite stopping sildenafil and treating her supportively with diuresis, she still continued to progress, and she deteriorated even further, requiring non-rebreathal mask to at least reach a saturation of more than 90%. So looking at her overall condition, they knew that most likely she had PVOD. Only treatment available would be lung transplant. So they sent the patient to us. And this was done through Medivac from Jeddah to our hospital, King Faisal Specialist Hospital at Research Center in Riyadh. So upon arrival, she landed straight away to the ICU. When she arrived to us, we reassessed her condition, and we most likely thought she had PVOD as well based on the findings we had. And at that time, we sent the genetic testing as well, but at that time, we were waiting for the results. When we assessed her, she had a dyspnea at rest with a functional class of 4. She was hypoxic and requiring around 10 to 12 liters of oxygen through non-rebreather mask. Her JVP was distended. She had bilateral clear signs of right heart failure and pulmonary edema on examination. And the ProPMP upon arrival was around 2,600, up from 1,000 when she came from there. Now we repeated the echo and we compared it to the echo that was done outside. So ejection fraction remained the same. Right ventricular systolic pressure has gotten worse. Right ventricle size became more dilated. Function has gotten worse. Right atrium became more dilated as well. Left atrium remains normal. A tricuspid valve has gotten worse from moderate to severe tricuspid regurg. And her pericardial effusion initially she had has gotten worse as well. So overall, clinically and radiologically, she's getting worse. So looking at her condition and that she had PVOD, we straight away on admission, lung transplant team were involved. Looking at how critical her condition is, they did some essential workup and they listed her for lung transplant. But despite all what we had to offer, she continued to deteriorate, required initially high flow nasal cannula, then intubation and mechanical ventilation. And unfortunately, later on, she developed cardiac shock, required multiple inotropic support, and a refractory hypoxemia. So what do we do now? Looking at the variables we had, she's a young patient diagnosed with PVOD and advanced pulmonary arterial hypertension. She's currently in cardiogenic shock with refractory hypoxemia despite inotropic support and mechanical ventilation, and she's on lung transplant list.
Can you stop here? So thank you, Faisal, but برضو محتاجين مؤثرات.
Sure.
So this patient came to us, immediately admitted to ICU. She was on 10 liters of oxygen. She was short of breath at rest, not at rest, lying down actually. She was on the bed. I still remember seeing her. She was really sick. We immediately reviewed her workup that has been done in her local hospital because there was no even time, or she was sick not to be sent to CT scans or right heart cath or anything. And after reviewing her CT scan from local hospital, looking at her data, cardiac cath, echo and everything, we agreed with the diagnosis that she has pulmonary veno-occlusive disease. And she was already functional class 3. And by the way, in her local team and her local hospital, when they gave her the sildenafil, the vasodilator, she went into pulmonary edema. And that's confirmed the diagnosis of pulmonary veno-occlusive disease. So there should be no wasting of time here. In the same day, we called the transplant team. We said this patient should go for lung transplant. And patient, we did, of course, the echo. The echo, I remember seeing her with Dr. Ali Al-Hazmi, and her RV is like this. It's not even contracting. It's only doing like this, severely dilated, severely. We did some. Would you do anything? I think that's the main of your slide, right? You're asking about what to do next.
Yes.
Yes. So what to do next now? We have a patient who has already in the stage pulmonary hypertension, PVOD, refractory hypoxemia, and becoming hemodynamically unstable as well, requiring inotrope. While waiting for transplant, of course, transplant can happen today or can happen after 1 month. We don't know. So what will you do? Anybody can suggest? ECMO, yes.
So yeah, as we did, we started her on via ECMO to bridge to lung transplant. Now, luckily, she only required ECMO for almost 4 days via ECMO. And thankfully, a lung donor was found within 5 days of putting into ECMO. So this is not something we see usually. She was put on a priority list, and we had to contact lung transplant for urgent lung transplantation. So what happened? She underwent double lung transplantation. And after they removed the lung, of course, this is not her lung, but this is a gross stock photo of a gross lung with someone who has POD. And you might see here in the this area is some clear septal thickening as well. Apart from that, the other findings are all non-specific and nothing would suggest PVOD. Histopathologically, on the other hand, the left side is from actually our patient. It showed severe muscular hypertrophy with pulmonary arterioles and intimal fibrosis. And on the left, it showed signs of pulmonary hypertension. On the right, you can see here at the arrow site, there was some interstitial fibrosis and lymphocytic infiltration of the alveolar wall surrounding an obliterated vein. So histopathologically was also suggesting a PVOD. And luckily, when we sent the genetic testing on admission, it came back And it actually was positive for EIF2AK gene on chromosome 15. So everything clinically, radiologically, pathologically, and genetic as well, everything was suggestive PVOD. So now let's go back to our patient. So initial post-operative course was not easy for her. Intraoperatively, there was no specific complications apart from her coming back with an ECMO and inotropes. But initially when she came to the ICU, she had severe primary graft dysfunction. And even her course was complicated by another ventilator-associated pneumonia with Acinetobacter. Unfortunately, she continued to get worse even after lung transplant, despite giving her antimicrobial therapy, diuresis, strong immunosuppressive therapy, including initial pulse steroid. She continued to require VA ECMO and mechanical ventilation. As part of the lung transplant surveillance, she underwent bronchoscopy with transbronchial biopsy and showed findings diffuse alveolar damage. So what you saw on the chest X-ray showed primary gut dysfunction and with picture of acute respiratory distress syndrome, ARDS. Now, after 10 days of lung transplant, we managed to wean her off from VA ECMO to VV ECMO. However, she's still on ECMO with high settings, and she required tracheostomy because we were unable to wean off ventilation. So now we're facing a big issue and dilemma. We put her on lung transplant, although at a high risk setting when she was having a severe PVOD. We were hoping that she would improve her survival on lung transplant. However, we almost made everything worse. So right now, you can see she has refractory hypoxemia on VV ECMO, unable to wean her off, and mechanical ventilation, and she has overall poor prognosis. So the questions we were discussing at that time is one, should we just surrender and treat her palliatively with end-of-life care and wean off VV ECMO and mechanical ventilation, or should we consider retransplantation? So I would like to open this question to the audience as well. What was the
so basically, thank you, Faisal. Outstanding, of course, presentation. So basically, this is an end-stage pulmonary hypertension with PVOD who came already late. She was lucky enough to have a lung transplantation in 5 days, which is surprising, but she was unlucky enough because she developed the primary graft failure. Primary graft failure means when you put the new lungs, there will be some sort of super acute or hyper acute rejection, and it can lead to primary graft failure. Now, if you look at the pathology, because they did a lung biopsy of the new lung a few days later, it shows diffuse alveolar damage, DAD. When you have a DAD in a patient like this, the recovery to a normal lung is almost impossible. So it's already diffused. The whole normal structure, interstitium, alveoli, and everything is already distorted. So now we have a patient who has originally very bad disease, who has now a graft failure, a new lung failure, despite being treated on everything, who is still requiring VV ECMO, not VA ECMO, because the heart now is recovering the RV function. And she was already wasted, but she was young. So we had to reinvest in this lady. So would you retransplant? And remember, retransplantation is normally not as easy as the first transplant. Putting all the other circumstances together, she was already having a very bad disease in ICU for many days, already having some muscle wasting, and of course tracheostomized and on VV ECMO.
Doctor, sometimes in case of acute rejection, we can give a strong immunosuppressive high dose of methylprednisolone and even plasmapheresis in case of alveolar hemorrhage. Is this patient can...
Yeah, she received all of these protocols, yes, but it's already DAD done. Would you, I will ask Dr. Ayman later, would you retransplant or you will just give up? يعني السؤال واضح صراحة، الجواب واضح صح. Dr. Ayman, would you do that? Yes. Okay.
So before answering this question, we have to look at the evidence. Does the retransplant work in such cases? So let's look at some of the data on retransplantation for primary graft dysfunction specifically. Now we know retransplantation for chronic allograft dysfunction works, although not as good as the first transplant. But how about severe primary graft dysfunction? So overall, what we know right now that it is actually associated with poor outcome when you retransplant for severe PGD. And this is based on a case series that done from 2002 to 2008, which showed from the organ recruitment transplantation network, showed that 1 year survival is only 31%. So when you look at these numbers, you would think, why would I waste and go for retransplantation? However, with the improved experience and data we have based on the last study done in 2016, it showed that actually survival has improved 1 year to 61%. So actually looking at this and looking how young the patient is and her condition, we had to give her a chance. So the final decision was to list her for a second lung transplant. And she was listed for a second lung transplant, and she was kept on VV ECMO as a bridge for lung transplant rather than treatment, which she was on before. Now, the first lung transplant, we had the lung within 4 days. But putting a patient on second lung transplant will not have the priority over some of the first lung transplant patients. So it took this patient months and months to receive another lung. And about 4 months, she's been on VV ECMO, tracheostomies, on mechanical ventilation, until we finally managed to get another lung. She underwent another second double lung transplant that was a bit long and complicated initially, with around 12 hours of surgery and 7 hours of ischemic time. Her initial post-operative course was uneventful. She was shifted to ICU initially with inotropic support and ECMO. But thankfully, this time around, after 4 days, we managed to wean off ECMO altogether. So imagine she's been on ECMO for the past 4 months, and finally we managed to remove the ECMO. And even mechanical ventilation, after 2 weeks from removing ECMO, we managed to wean her off mechanical ventilation altogether, and even decannulate the tracheostomy. And this is 5 months of being on mechanical ventilation. So now we wanted to look at the echo now post-lung transplant. Since she has been improving, let's look at what happened to her echo. So ejection fraction remains the same pre-lung and post-lung. Right ventricular systolic pressure now has normalized completely, and this is almost 2 weeks after a second lung transplant. Right ventricle size normalized, L function has returned to normal, right atrium normalized, left atrium has been normal. A tricuspid regard only she had trace, which is almost normal, and pericardial effusion also completely subsided. So she's almost a normal patient looking at this echo. So as you know, she's been on almost 5 months bedridden, on ECMO, intubated. So definitely to improve her outcomes, you need to put her on significant and intensive physical rehabilitation. She required almost 3 weeks of physical rehabilitation during her hospitalization, as well as swallowing exercises. And she has actually gradually gained her strength and began to mobilize with assistance. And we managed to discharge her with an oxygen saturation of 98% of room air. And this is after almost 5 to 6 months of hospitalization from when she came to the second lung transplant. So what I want to say is that, as John Doe has mentioned, that no man is an island. By that we mean everything that happened to this patient is not done by one person. It's actually a whole team, including lung transplant surgeons, lung transplant physicians, coordinated nurses, respiratory therapists, physical therapists, critical care. So if any of the ECMO team as well. So any of these team, a significant part of the team is missing, this patient would not have survived. So now we've concluding the case. I'll just speak briefly on PVOD. PVOD or pulmonary veno-occlusive disease or pulmonary capillary hemangiomatosis is a rare cause of pulmonary hypertension. So keep in mind that PVOD and PCH is now considered one entity and they are the same disease. Pathologically, we have some extensive and diffuse occlusion pulmonary veins. And as we know, and as I have shown you already, that PVOD progresses rapidly, and they need early detection and early treatment with early lung transplant referral. And it has been associated with poor prognosis. Now, how common it is? The true incidence is unknown. However, when we look at the pooled analysis of multiple cases, which included 470 patients, it showed that PVOD may represent 10% of cases of pulmonary arterial hypertension. And the annual incidence is around 0.1 to 0.2 case per 1 million. The main issue of PVOD is that a lot of them are misdiagnosed as case of idiopathic and some of them as case of CTEPH. Now, as you know, the ESC and ERS has subdivided pulmonary hypertension into multiple groups, and they have even subdivided PVOD into multiple groups. And we know that PVOD can be idiopathic, can be heritable, which is secondary to EIF2 AK2 mutation, as we had in our patient. It can be related to drugs, toxins, or radiation-induced, some cases of chemotherapy as well. It's associated in some cases with connective tissue disease and HIV infection. Now, the commonest gene detected is, I've mentioned, the eukaryotic translation initiation factor 2 alpha kinase 4, which is its presence is enough to actually diagnose patients. Some cases of PVOD we have that does not have a typical clinical features, and you want to go for having this gene mutation is enough to diagnose it, and you can forego the biopsy. And the reason why this gene is important because it actually regulates angiogenesis and response to cellular stress. So as I've mentioned that idiopathic pulmonary arterial hypertension and PVOD, sometimes they are misdiagnosed. So it's important to differentiate between the two. So as you can see, PVOD has this common mutation as mentioned. It's mainly autosomal recessive compared to the genetic transmission of pulmonary idiopathic familial pulmonary arterial hypertension. It is less common. The pulmonary arterial hypertension has more female predominance, while PVOD does not. Specific drugs has been associated with PVOD, which is different than pulmonary arterial hypertension. Other findings and clinically and hemodynamically, they are all the same. Imaging-wise, I've mentioned they have classical centrolobular ground glass opacities with smooth septal thickening, mediastinal lymph nodes, and in some cases even pleural effusion. Now, bronchoscopy is not really that helpful to differentiate between the two, but PVOD, sometimes they have some occult pulmonary hemorrhage. So they might have some hemosiderin-laden macrophages on BL. And another way to differentiate is their response to vasodilator therapy, where the pulmonary arterial hypertension, they would improve, however, PVOD, they would not. Now, the response to vasodilator therapy is much worse when you use prostacyclins compared to sildenafil and macitentan. And when you start sildenafil gradually, more than 50% of the patient will develop pulmonary edema. Now, what's the natural history of PVOD? How do they progress? So it is definitely, as we know, it's a progressive disease. Mortality can be as high as 72% within 1 year. So that's why it's important to diagnose them early. And that's why it's important to refer them to lung transplant as well. And you can see clearly that when we diagnose the patient, the mean time to death or lung transplant is about 1 year. However, when you look back retrospectively, when the symptoms started, the mean time to death to lung transplant from the first symptoms was around 2 years. There is no clear guidelines on how to manage PVOD, but we do know that lung transplant is the main treatment. So any patient with PVOD should be referred to lung transplant outright. However, this algorithm has been created by the ERJ in 2009, just to give an idea on what to do and how to approach them. But to summarize it, lung transplant, regardless of the functional class, and if the functional class is low, you might give a trial of sildenafil, but you have to monitor closely. In our patient, local hospital, they put in sildenafil for a month, but she should be at least closely monitored within days or weeks to make sure if she's responsive or not. So to summarize, PVOD is a rare and progressive disease. Diagnosis can be made without any histopathological diagnosis if we have clear clinical, radiological, and hemodynamic changes. Family history of PVOD and the mutation of EIF AK4 gene is strongly supportive of diagnosis and can forego any further diagnostic testing. Early recognition and management is key. So it's important to keep other physicians aware of this entity to make sure they refer this patient early to us. And management is supportive and mainly lung transplant referral. Thank you everyone for listening. If there's any question, I'll be happy to take it. Thank you.
Outstanding, Faisal. Any questions?
البلمونري بينو اوكلوسيف يعني هل هو بيحتاج ان احنا لو عملنا ترانسبرونكيال لانج بايوبسي اصل نوعا ما سنترال شويه حوالين الهايلم، لو عملنا ترانسبرونكيال لانج بايوبسي وي كان دايجنوز قبل ما نخش في الدايليما ان احنا نجرب ندي سنجل دراج وبعد كده العيان يخش بالمر، اصل هو العيان جود ديتيريوريتد اول ما ادينا سنجل دراج ودخل في فلوريد بالمونري اديما، فهي نفس الفكره يعني. طب ما احنا كنا خدنا بايوبسي من الاول طالما احنا شايفين العيان احتمال يطلع PVOD.
Transbronchial biopsy is contraindicated in patient with PVOD and pulmonary hypertension. So please Although it is a gold standard, but the only way to confirm 100% is biopsy, but it is absolutely contraindicated because these patients can bleed to death if you take a biopsy because they are PVOD with pulmonary hypertension, so you cannot do biopsy. But if you have radiological finding, a triad of radiological finding, centrilobular ground glass changes, diffuse, bilateral, septal thickening, lymphadenopathy in a patient with pulmonary hypertension, that's enough to make a diagnosis of pulmonary hypertension, of PVOD. And I like the statement that Abdullah put in his summary. Right diagnosis and made بعد فضل الله طبعا what made everything is going well except for the primary graft failure is making the decision, the right diagnosis on the day of referral and making the right decision on that day, which is lung transplant, because she was already very sick and the clinical picture was very suggestive. So of course the clinical scenario of giving the sildenafil and pulmonary edema confirmed that diagnosis. So back to your question. Yes, theoretically, yes, that's a diagnostic tool, but it is contraindicated. You cannot do it. Sometimes, if you ever do a bronchoscopy for any other reason, not for a biopsy, and you did a BAL, alveolar lavage, and if you can find alveolar laden macrophages, and another tool to confirm the diagnosis, but you should not attempt doing even a bronchoscopy for these patients. Thank you.
I would like to stress upon this point. Whenever you have an interstitial disease, please do an echo before you do transbronchial lung biopsy. I'm talking to my colleagues of pulmonology. I never do transbronchial lung biopsy without echo. If the patient has pulmonary hypertension, you will have a devastating bleeding. So even in other kind of interstitial lung disease, be careful.
And also, I would like to stress on the transbronchial biopsy. It's not a diagnostic for PVOD. You need a good tissue. You need a big one. The surgical biopsies. So bronchoscopy by itself, even if the echocardiogram is like fine, it's okay, it's just mild pH, and you would think that the risk the result you are expecting from bronchoscopy is low. So you shouldn't even think about diagnose PVOD by bronchoscopic biopsies.
You know why? Because what Dr. Shah is saying, you need a good tissue biopsy to have the interstitium and the veins, so you can actually look at the changes of the PVOD.
Usually.
And normally, it's very difficult to get many good bites that represent everything in the lung: arteries, bronchioles, venules, interstitium. So open lung biopsy sometimes.
Nowadays we do it with the cryo, so
you can get the punch. Yes.
We get the punch, which carries more mortality. You know?
Yes. So, Doctor, beside you, and then we'll go there. Sorry, Doctor.
The preferred operation and transplantation in this PVOD patient, is it double lung transplantation or heart lung transplantation?
It's actually double lung. We don't do heart transplantation anymore now for pulmonary hypertension because the RV normally normalize after up to 3 weeks after the surgery. But this is a good point because the RV management right after transplant is very hard. So the ICU care the first couple of weeks after the lung transplant in a patient with pulmonary hypertension is very meticulous because all of a sudden you are putting a new lung with normal pulmonary vascular resistance, but the heart is still dilated and weak. So the contractility needs some time to adapt to the low pressure. So it's really very good ICU care right after the transplant. But we don't do heart transplantation. The only scenario when you do heart and lung, when you have either heart failure, like left heart failure, or you have complex congenital heart disease that cannot be corrected surgically. I think the message from this case is that timing of reaching the right diagnosis is very important. Timing of the right decision is also very important. And more importantly is the investment in these patients. Don't lose hope. So this young lady had very aggressive, very eventful courses after the admission. She had a transplant, primary graft failure, 4 months on ECMO. And yet, when she was retransplanted, she is at home now. I mean, I think investment, doing the right thing for patient, and يعني is very important. بعد التوكل على الله, of course.
Actually, Dr. Faisal, the whole work is fascinating, but I need to stress upon and ask you about the period from her first transplantation to the second transplantation. I believe this is the most marvelous work, how you kept this patient fit for transplantation during this time. So can you give an idea? Because I have many colleagues of respiratory therapists here who are, it's their task mainly. How you kept this? What kind of physiotherapy was do? Can you tell us about this? Do you have some details about this? I mean, she was mobile. She would. They were doing physiotherapy, or she was in bed all the time. Because I know ECMO can mobilize the patient with ECMO and do all of this stuff. Because sarcopenia and all this other stuff can be a contraindication for retransplantation.
I can answer this question because Faisal was not around here at that time. In fact, when she was on VV ECMO, yes, she was actually mobilized to be sitting on a chair. Very good nutrition, very good ICU care. Of course, she was tracheostomized at that time. She has to be connected to the ventilator as well, beside the ECMO. So the mobility was actually limited. Most of the time, however, not mobilizing on a chair, but putting her sitting on her own bed, doing some physical exercise. ICU care is very important. This patient did not even have a bed sore, which is very important. Yes, nutrition is also important. I think she received an outstanding ICU care as well. As Faisal mentioned, it's a multidisciplinary team effort. Yes. Doctora.
Avoid the rejection because in experience in renal transplant, once the rejection, there is high possibility of second rejection.
What was the original question? Because there was no
the protocol of immune suppression to avoid the rejection. The second transplant.
Yes,
if possible,
I remember I put the first protocol for the lung transplant 15, 16 years ago. So nowadays I didn't know what they are using, but obviously they use the right protocol. They use steroids, they used FK506, tacrolimus, and they use the third one is actually
mycophenolate.
Mycophenolate, Silsat, yes. But for the acute rejection, initially after you put the new organ, you get actually a massive dose of methylprednisone. And sometimes ATG, if I remember correctly, from all these days. But nowadays, I'm sure the protocols are much more advanced. I don't think we have a colleague from lung transplant here, but obviously they use the right thing. I think we should really proceed because we have another fascinating cases coming, and I think Dr. Shah will be introduced by Dr. Dalia Ana.
First of all, I wanted to show myself. I am Dr. Dalia Faiz, Professor of Internal Medicine and Rheumatology in Shams University. I am so honored I am so glad to share this well-organized and highly scientific meeting. I would like to thank Dr. Ayman, Dr. Abdullah, Dr. Jihan for inviting me to present with you and sharing the experience of this scientific activity. Third, doctors, I am honored to present Dr. Shaya Shaya. Dr. Shaya is a consultant adult pulmonary hypertension. He is a consultant in King Fahd Medical City.
other cases as well. So flip it from the some outcomes mentioned there to another cases that we are all seeing during our life, especially in pulmonary hypertension clinic. So we'll talk about connective tissue disease, progressive diseases, pH therapies, long-term, something like that. So I have nothing to disclose in this presentation. So I have two cases. I will start with the first one. The first case, she's a 42 years old lady. She's diagnosed like recently before visiting us in our center with systemic sclerosis. She has rhinoids for years, like 9 years. She has a GERD. Initially, at time of diagnosis, she has intervention. She's referred to us, admitted for rectal pulmonary, and this she was referred to us while admitted there. So prior visiting us to our center, she has 7 months history of fatigability, weight loss, GERD symptoms, shortness of breath and exertion. And 30th of October, she has rectal mass, and the local hospital was investigating her for this reason. She has bilateral pleural effusion and pericardial effusion. She underwent pericardiocentesis as well. Rectal prolapse later on was shown normal tissues and underwent surgical intervention that time. And a local hospital rheumatologist started her on methotrexate and diltiazem. So when she's visiting us and our center, we revisit her diagnosis and symptoms. So we agreed that she has significant shortness of breath. She came with wheelchair with her family. So it looks like WHO function class 4. She is also has symptoms suggesting of pre-syncopal events, but there is no syncope per se. She has also no joint pain, no joint ulcers, and so on. So overall, WHO function class 4. An examinations, clearly she is hypotensive with 88/54 blood pressure. She is hypoxic room airs 90%, and she is underweight with weight of 38 kilogram. Significant symptoms suggesting of scleroderma. She has sclerodactyly, hand stiffness, and fish mouth. GVB is raised, bilateral decreased air entry in the chest exam, and she has sign of right heart failure up to knee lower limb edema. We did all the required workup. Kidney function, electrolyte was remarkable. Hemoglobin is 12.8. Hepatitis, HIV, hepatitis B and C, and HIV, thyroid function test is normal. BNP is 1,240, and her immune marker came positive for ANA and antisentumor, and the other immune marker was negative. Her chest X-ray at time of presentation shows bilateral pleural effusion, some consolidation in right lower lobe, and also there is a cardiomegaly with enlargement of right or prominent right pulmonary artery. A chest CT scan doesn't show. We are looking for all the causes and complication of scleroderma. So there is ground glass diffused bilaterally. There is pleural effusion, cardiomegaly. We cannot assess fully for interstitial lung disease because of presence of all these features, especially pleural effusion. So this is a cut of her CT scan. We can see this is diffuse bilateral ground glass opacities. We cannot do VQ scan. We requested multiple times. Unfortunately, this is a kind of patient who is not following your instructions, so VQ scan hasn't been done for her, as well as she requested multiple times PFTs and 6-minute walk test. She's all the time she's in the wheelchair, and she's always has shortness of breath just from sitting or walking from the door to the waiting area. So it's clear she has shortness of breath, WHO function class 4, but we cannot do a full test and to determine exactly what she has with regard to 6-minute walk test. Echocardiogram has been done, and right ventricle is severely dilated with mild right ventricular dysfunction. Right atrium is severely dilated. There is moderate tricuspid regurgitation, flattening symptoms. Pulmonary artery is measured 3.7 centimeter. Left ventricle is okay, and there is no pericardial effusion. And this is here echocardiogram. You can see here all the feature of pulmonary hypertension with dilated right ventricle and shifting of the symptom to the other side, which looks like D-shaped septum. We have tricuspid regurgitation, dilated of right ventricle and right atrium, and there is no collapsibility of the IVC, which indicate right heart failure. So we are following the guidelines. This is a high-risk PH with TRV more than 3.4 and also signs of pulmonary hypertension. Right heart cath has been done for her and shows of mean pulmonary artery of 56 millimeter mercury with pre-capillary picture. Cardiac index is 1.9, which indicates severe pulmonary hypertension, or pre-capillary pulmonary hypertension. Mixed venous saturation is 55%. Do we need to do vasoreactivity test in this stage? I don't think so. We are dealing with connective tissue disease picture. So vasoreactivity test at this stage is, even if it came positive, we will not go ahead and start calcium channel blocker in these cases. So this is a pre-capillary picture, and WHO group 1. We stratified this patient. She has all the red signs in this stage. So we are thinking this is a high-risk patient, high risk of mortality, more than 10%. So we diagnosed her with severe connective tissue disease, pulmonary arterial hypertension, pre-capillary picture. She's a high-risk patient. Upfront combination therapy has been started. We think whether this is a limited or diffuse pulmonary systemic sclerosis. So we involve our rheumatologist in this condition. Also, we have to look for the other contributing factor, like do we have a connective tissue disease, interstitial lung disease, pulmonary arterial hypertension as well, because the mortality and survival is different between these groups. So CT scan has been done later on and shows there is no interstitial lung disease. However, the problem with these patients, sometimes they are not listening to you and not following the instructions. She has multiple admissions in the local hospital because of recurrent heart failure, recurrent pleural effusion, recurrent pulmonary edema, and she was received a lot of doses of diuresis. Even we admit her twice to the hospital just to re-stratify the medications and reintroduce the medication. She discharged with double therapies, upfront combination therapy. She came back with one. So we asked her, why wouldn't you use these two medications? I admitted twice, and unfortunately, she came always either not using this medication or use it for a month, and she just stopped it. This is what the problem with such cases. So CTPA, just to rule out ILD, and there is no significant ILD, we can see there's improvement after starting pulmonary hypertension targeted therapy in terms of PMB, like 1,248 to 379, and still we are not fitting the criteria of red group. So I think Dr. Abdullah, I think I told him I need some mu'athirat. So I have another case. Then you can give me some mu'athirat.
Let's discuss the first case.
I have two cases.
For the management, what's about the co-management with the rheumatologist? What's the type of biologic you received for this patient?
Yeah, she received initially with the methotrexate for scleroderma by itself. Then we add by our rheumatologist rituximab. She received 2 doses, and she not showed off that time. So we have significant incompliant patient in this condition. So we are talking about systemic sclerosis. She is not following the guideline or the treatment. Pulmonary hypertension, she is using for a month or 2 and she stopped it. So she came with heart failure multiple times. So, and this is maybe a real life patient when we have something like that. So second case, I don't have much information even to talk about this patient. So I think I have to flip the coin from Dr. Abdullah, 2 fascinating cases, to this case. She's 63 years old with diagnosis of scleroderma. She has severe pulmonary hypertension. By the way, this is a referral form from other hospital to our hospital. Told us, please help us to do something for this. So severe pulmonary hypertension, WHO function class 4. She has recurrent hypotension, and this is, I'm just reading what they said. And she has rhinoid. She has admitted to the ICU with the right heart failure. She was staying there for 3 months. She has arrest. She has GI bleeding. And they said, please just help us try to do something. So they approached me one day and we accept the case to come to our hospital. So she came at that time, she was unstable, chest X-ray shows dilated, or cardiomegaly, dilated pulmonary trunks. Echocardiogram is showing severe right ventricular dysfunction, also right ventricular severely dilated, severe tricuspid regurgitation, there is pericardial effusion. Interestingly, and I'd like to ask you a question, what does mean? We have right ventricular systolic pressure as 50 to 55. So can we consider this case as a mild pulmonary hypertension, moderate pulmonary hypertension, or severe pulmonary hypertension? What do you think? Mild, okay. Moderate. So we are talking about right ventricular systolic pressure. This is not a mean pulmonary artery pressure. So in the right heart cath, we are looking to mean pulmonary artery pressure of 20 and above. This is a systolic pressure, so this is not a mean. So the cut limit in the echocardiogram 35 to 40. So above this limit, we are considering this is pulmonary hypertension. So we have only 15 millimeter mercury or 10 millimeter mercury above the cut limit. So do you think this is just a mild? So when you see this case, severe patient, she has clinical findings suggesting right heart failure with severe right ventricular dysfunction and severe dilated right ventricle, severe tricuspid regurgitation, what? And there is pericardial effusion. So you have all the signs of severe pulmonary hypertension to start with. Seeing right ventricular systolic pressure is just mild is a scary feature. You have always to keep it in your mind, because when we have a patient with pulmonary hypertension, we have to know exactly where are they. Are they in the compensated pre-symptomatic area, symptomatic deconditioning, or declining and decompensating? Because the pulmonary hypertension, at time of decompensating and declining, the pulmonary artery pressure goes down. So it is increasing to the certain point where the pulmonary artery pressure goes down, it's not goes up. So when you see a patient with all these features, with severe pulmonary hypertension, right ventricular dysfunction, and low pulmonary pressure, this is a scary point. You have to know this patient is at like an end stage or severe declining pulmonary hypertension, and this is what happened to our patient. You can see it's almost kissing right ventricle, and there is no way you can see from this clip. The right ventricle is almost small. The right ventricle, the left ventricle, and the right ventricle is pushing everything to the other side. It's ballooning shape. So CT scan has been done, shows bilateral pleural effusion. There is no sign of ILD, and we kept the patient on baseline. She's already in combination therapy. We kept in the beginning when we saw her, she's already in two combination therapy. She was in sildenafil and bosentan, and we aggressively diurese her, and kidney function goes down. She was unstable. We tried to plan right heart catheterization. Even we cannot do it for her because of her condition. She was unstable hemodynamic, unstable vital signs, admitted to ICU. Actually, the admission of ICU was the day of planning for right heart catheterization. Inotropic support started. We start on epinephrine, dobutamine, and also vasopressin, intubated. Evaprostinol has been also started. Cardiac enzyme is elevated, cardiac function is failed. She was anuric, right ventricular failure, ischemia, and she's passed away. So I'm flipping the coin to the other side. Sometimes we see these cases. So the question, why? Why we are reaching to always in these conditions? So we have a connective tissue disease. I showed two cases with the patient with scleroderma. She has long-standing scleroderma, and I'm sure she has long-standing pulmonary hypertension. She just came late with all these pictures. The same happened for this lady. She just came at time of RV failure, but there is no way to help them much at this stage. And this is my goal in this lecture, to detect them early. Scleroderma should be detected early. Pulmonary hypertension is not, we shouldn't play with pulmonary hypertension, systemic sclerosis. So I have to highlight about the importance of things and how we can detect them early. What is the risk factors? What is the screening method in systemic sclerosis pulmonary hypertension? So the old definition of pulmonary hypertension is more than 25 mean pulmonary artery pressure, and when we need to diagnose them with pulmonary arterial hypertension, it's supposed to be the mean more than 25, which is less than 15, and PVR more than 3. And in the sixth symposium, pulmonary hypertension, the mean pulmonary artery pressure is down to 20 instead of 25. And one of the important factors for this is a scleroderma. To detect them early, to catch them early, to treat them early aggressively. So systemic sclerosis has multiple shape or multiple forms. One of them is limited as cutaneous scleroderma or diffuse cutaneous scleroderma. The difference between them is rhinoid for the first group is for years. The other one is maybe just recently introduced or started. They have a skin involvement, including the face, the hands, and forearms, while the other one is including the trunk. And there is no significant renal disease in the limited cutaneous and diffuse. Yes, there is a significant renal involvement. Pulmonary hypertension is more with the limited cutaneous compared to the diffuse cutaneous. And sometimes we have overlap condition with this leak, scleroderma, dermatomyositis scleroderma, and so on. The other important thing you have to keep it in your mind, the form of pulmonary hypertension is scleroderma. Scleroderma can present with the group 1 pulmonary arterial hypertension associated condition, or like PVOD, or can present with left ventricular dysfunction in group 2, or can present with interstitial lung disease related pulmonary hypertension, or sometimes because of its increasing the risk of chronic thromboembolic pulmonary embolism, increased risk of CTEPH. So it can present with one of these groups. So when you diagnose or see patient with pulmonary hypertension, you have to understand with scleroderma, you have to understand which group you are belonging to. So what is the prevalence of pulmonary hypertension scleroderma? And the review registry in 2010, the connective tissue disease PAHs account for around 25% of all pulmonary hypertension cases. Idiopathic was 46%. Multiple studies looking into how many scleroderma develop pulmonary hypertension. In 2003, it is estimated around 7.8%. Another study in 2003 estimated by around 12% of all scleroderma can develop pulmonary hypertension. Another important study was published by the Australian Scleroderma Interest Group, estimated around 8.4%. Another study looking to 13% of pulmonary hypertension. Another study as well is looking for pulmonary hypertension and scleroderma. They are including 1,100 patients. 206 of them has suspected pulmonary hypertension and underwent right heart catheterization. The prevalence around 7%, and they are stratifying their patient to 3 groups. The first group is isolated pulmonary arterial hypertension, so scleroderma. Group 1 pulmonary hypertension around 4% from this group, and the other group is also included here. With 2%, they have post-capillary pulmonary hypertension, 1% for ILD, scleroderma, PAH, and 1% PVOD. And this already I have mentioned, so I will skip these. So what about the other group? So if we have scleroderma pulmonary hypertension, how much of them, let's say we have 100 patients with scleroderma pulmonary hypertension. So we have a group 2, it's account for around 10%, and group 3 ILD picture, and scleroderma's account around 21%. And the remaining group is associated group 1 pulmonary hypertension, and this was published in FARS study. So what about the survival? So before prior pulmonary arterial hypertension specific therapy has been published or started, this is studied in 2003 when there is only ibuprostanol and around to start Posentin. So 5-year survival rate was 10% for scleroderma PAH compared to 80% for scleroderma without PAH. We are talking about serious disease, so we have to treat them early. So in the review registry, they are comparing connective tissue disease to idiopathic pulmonary arterial hypertension, and shows that the survival is lower in patients with connective tissue disease associated pulmonary hypertension, and also they have higher risk for hospitalization compared to idiopathic pulmonary arterial hypertension. When the subgroup analysis for this connective tissue disease, the scleroderma they have lower survival compared to the SLE, lower survival to compare with connective tissue disease, as well as for rheumatoid arthritis. Another registry is from UK in 2010. The scleroderma account for around 300 15 cases, 74% of all connective tissue disease. So the most common connective tissue disease causing pulmonary hypertension is scleroderma, then mixed connective tissue disease, SLE, and so on. Also in that study showing that the survival rate is better in SLE compared to the scleroderma. And also when we have a scleroderma, interstitial lung disease, pulmonary hypertension, the survival is lower compared to the scleroderma, connective pulmonary arterial hypertension. So always we have to keep in our mind what is the other contributing factor in pulmonary hypertension. If we have group 1, function class 1, 2, or 3, each one of them has different survival. If we have lower mixed venous saturation is lower survival. And in this registry, the 1 and 3 years survival is 78 compared to 47% after 3 years. When we add an interstitial lung disease to scleroderma, the survival rate goes down to 28%. What about the risk factor? So how we can catch these cases earlier? So we have to keep in our mind a couple of things that how we can know these cases. So the risk factor to develop pulmonary hypertension, or let's say, what is the feature of pulmonary hypertension and scleroderma? So we have to know that scleroderma is a vascular disease as well. So this most common risk factor has been published in different study. The longest standing disease, more than 5 years. Limited cutaneous is higher risk for pulmonary hypertension than diffuse. Presence of telangiectasia, DLCO less than 60%, FVC DLCO more than 1.6, presence of anticentromer, ANA, anti-RMB, and absence of anti-SL70, older age at onset of scleroderma, and elevated of PMB. All these things has been collected from different studies regarding pulmonary hypertension or the feature of developing pulmonary hypertension compared to the others. So we can see in this VARS study, the older age, the longer of the duration of the disease, the risk of pulmonary hypertension. And also here we can see this about the duration and the age of the patient. High risk for limited cutaneous patient. And also when we compare limited cutaneous to diffuse, we have 55% with pulmonary hypertension and limited group. And also presence of anticentromer compared to the others is higher in PH patient. So also scleroderma limited disease in other study, the time of diagnosis. We can see here also the age, the older age, the higher risk. This is another study looking for the antibodies. So anticentromer, the RMBs is higher compared to SL70 in this study. And also presence of rhinoid, digital betting, and gangrenes increasing the risk or as a feature of pulmonary hypertension. In this condition, or this article talking about the DLCO, the lower DLCO, the risk of pulmonary hypertension. So if you have a patient with scleroderma with normal DLCO or just a borderline, different from patient with severe DLCO. So we have to keep in your mind, this is maybe an early signs of pulmonary hypertension. Also, if there is increase in PMB or deteriorating in PMB, this indicates of pulmonary hypertension in patient with scleroderma compared to the patient with normal PMB. And this is also published in multiple studies. So the older age, late onset of scleroderma, presence of telangiectasia, matted square-like appearance, or pseudotumoral more than 5 millimeter in diameter. History of digital ulcers also increase the risk of pulmonary hypertension or the feature of pulmonary hypertension. So compared to patient with non-pulmonary hypertension, scleroderma, to scleroderma pulmonary arterial hypertension, they are older, male, higher functional class, mean worsening functional class or NIHA functional class. They have mostly limited cutaneous in compared to other forms. They have positive anticentromer. They have telangiectasia. They are worsening gas exchange and the LCO. They have higher urate and pro-PMB, and also they have right ventricular strain, right axis deviation, and a large ARV area and higher TR velocity. So now we understand, we know the feature of scleroderma, that people who's at risk to develop pulmonary hypertension. How we can collect all these together and put it in a form? There's 3 forms has been published as a screening algorithm specifically for scleroderma patients. There is European Society of Cardiology, ASC, ARS, and this is based on the echocardiogram. So if you have a scleroderma, do echocardiogram, and this is for the first screening. The second one is the Australian Scleroderma Interest Group. They are based on BMB and pulmonary function test, then go ahead with right heart catheterization. The third one is a detect score or detect algorithm. This is 62 centers throughout the North America, Europe, and Asia looking into this. They are based on multiple factor variables. I will mention it later on. The entry point is if the patient has 3 years duration of the disease of scleroderma, and if the DLCO less than 60. So if yes, we'll go ahead with this score. So the ASC-ARS guideline based on the TRV jet velocity, it's similar to ASC's ARS guideline in pulmonary hypertension, less than 2.8, more than 3.4, or in between. So if yes, go ahead with right heart catheterization. If not, you didn't need to do right heart catheterization. The Australian group, they have 2 components. The first component BMB, the second component DLCO less than 70, and FVC DLCO more than 1.8. If one of them is positive, go ahead directly with right heart catheterization. If both of them is negative, you don't need to do right heart catheterization, do just a screening after 6 to 12 months. The detect score has 2-step algorithm or 2-step features and workup. The first one is non-echocardiographic variables, including multiple things like DLCO, FVC, telangiectasia, antisynthomer, presence of BMB, urate, right axis deviation. If yes, go ahead with the second step. If like it's more than 300, go ahead to the next step, doing echocardiogram. Echocardiogram step is based on right atrium area and tricuspid velocity. If more than, there's a point. If more than 35, go ahead with the right heart catheterization. So we have 2 steps and scleroderma detect score. And this is like nomogram for detect score. And there is an application, you can upload it in your phone and you can put all these variables and it will tell you to do an echocardiogram or to do right heart catheterization. So based on this, we are missing cases with scleroderma pulmonary hypertension, even with all these scores. So the detector score, they found that the 20% of PAH, the detector score, they are doing this algorithm, and at the same time they are doing a right heart catheterization to validate the score. So they found that even with doing echocardiogram, there's 20% of patients have TRV less than 2.5. So you can see still patient with pulmonary hypertension, scleroderma with normal echocardiogram or TRV at least less than 2.5 and so on. So 36 patients, they have TRV less than 2.5 to 2.8. So there is another comparison study between all these algorithms by Detect, ASC, and Australian group, and the sensitivity almost 100%, but the specificity is more with the Australian group and so on. So what is the issue with screening algorithm? It's time consuming. You know, every country, they have their own facilities and the work they can do that cannot be done, and sensitivity, accuracy for all these algorithms. Echocardiogram variables, still if you have an echocardiogram, you might also miss some cases. The entry data sometimes is also another issue. The FARS study, they are including all patients with pulmonary hypertension, is irrespective to like detect a score. They need to have 3 years of disease. They have also less than 60. In the FARS study, they are including everybody in their study, irrespective to this entry data. So we have multiple things. We have multiple data here. Okay. So we have to keep in our mind, despite all limitation of these detects Australian or ASC guidelines or algorithms, to be evaluated. Each of them perform reasonably to detect scleroderma pulmonary arterial hypertension, echoing the many of experts that any reasonable screening algorithm apply for early detection of pulmonary hypertension is better than usual care. So we have to screen them early, try to do something for them early, not to reach to, I have shown you that previous two cases. The accuracy and accessibility is always limited in this cases. This is just a 2 slide about the screening recommendation for screening. All patients with scleroderma should be screened. All connective tissue disease, mixed connective tissue disease with symptoms should be screened at least with echo. All scleroderma spectrum diseases, positive non-invasive testing should go to the right heart catheterization for diagnostic purposes. Right heart catheterization is mandatory to diagnose pulmonary arterial hypertension. Another important things we have to tell you about, the BFT is important, echocardiogram is important, BMB is important. All these things should be told you this is a progression of underlying disease and developing pulmonary hypertension. Echocardiogram by itself can miss some cases. So if you have a dropping in the DLCO, BMB, and so on, you have to go ahead with right heart catheterization. So the home message, PH and scleroderma is a leading cause of death in scleroderma. Significant proportion of patients with scleroderma PH is asymptomatic at time of diagnosis. The high prevalence rate, poor survival, lack of symptoms, combined with observation that early treatment of milder disease improves the symptoms and may prolong the survival, provide a rationale for screening for PH patients with scleroderma. And at the end, I would like to remind you about yesterday we mentioned about the SAPH 2020. We are inviting everyone to attend. And thank you.
Thank you, Dr. Shaya. I wanted to focus on some points as regard the most important in the management of pulmonary hypertension with connective tissue disease is a prevention of pulmonary hypertension by follow-up and proper management of the scleroderma in the acute stage, because in the early it is reversible, and in the late stage after the development of pulmonary hypertension, scleroderma management will be very difficult because it is irreversible. Aggressive treatment of scleroderma by immunosuppressive, by biologic, cyclophosphamide, interleukin-6 antagonist, co-stimulation blockade اللي هو الاباتاسيبت, and even by rituximab. And in 2021, interleukin-6 approved in the management of connective tissue disease with interstitial lung disease. Any question? We have 2 questions because of the short of time.
Thank you. There is a test called forced vital capacity over DLCO. What is DLCO?
Diffusion capacity of carbon monoxide. It is done by during the pulmonary function test.
Thank you, Dr. Shaya. As regards the echo, I'm echocardiologist, but usually in the echo we see high probability, low probability, intermediate probability of pulmonary hypertension.
Yes.
How the echo finding as regards the right ventricular systolic pressure coordinate with the right heart cath? As example, if above 50, is it mild or moderate? If above 70, is it mild, moderate, or severe like this?
Yeah, I think there is 2 things important to stress on in your question. The first one is for scleroderma by itself. All these scores or algorithm has been done to catch them earlier. Although with normal right ventricular systolic pressure, we have to consider this is maybe pulmonary hypertension. And this is the answer for the second question. The second question is, let's say we have a normal right ventricular systolic pressure in the echocardiogram. Can we miss cases? The answer is yes. There's multiple studies looking into the differences between a right heart catheterization and the echocardiogram. And sometimes you can miss 10 to 15 millimeter mercury in the same day of the right heart catheterization. Let's say we have right ventricular systolic pressure of 30, maybe it's 50. And last week, I have a case like this. I did echocardiogram, the echocardiogram for a patient like 31. When I did like a right heart catheterization, it's 51 systolic pressure. So we can miss some cases. Because of that, we have to stratify and we have to stress on the early screening for pulmonary hypertension scleroderma. Even with the normal echocardiogram, if you have another feature like DLCO, if you have a higher PMB, so you have to consider maybe you are missing this case. Let's go ahead, especially in symptomatic patient. With regard to the echocardiogram criteria, whether it is mild or moderate or severe, there is a debate. I would say there is increase in pulmonary hypertension by 10 from the 40. We are talking about systolic pressure. We can by 10 to 15, you said mild, moderate, and severe. However, I think it's supposed to be based on the right heart catheterization than just echocardiogram. How many times I'm seeing like patient with 80 to 90 right ventricular systolic pressure and mention the report severe pulmonary hypertension. The right ventricle is fine. The size is fine. The right atrium is okay. Doing right heart catheterization is re-stratify this to mild. So looking to echo per se, you cannot say this is just a severe. The pressure is severe, but doesn't mean this is a severe pulmonary hypertension. Severe pressure, but not severe pH.
I just want to highlight some points. When you have a patient with pulmonary hypertension, the first thing you have to ask yourself, is your patient connective tissue or not? Because not all connective tissue disease are the same as you have mentioned. However, in the WHO functional class, they are put in the one group, which are connective tissue associated PAH, but I think maybe in the upcoming symposia, they would be sub-classified into being scleroderma associated, lupus associated, or other connective tissue disease associated, because scleroderma have much more worsening survival than other types of connective tissue disease. The second point is that we have to clarify the cause of pulmonary hypertension in such patient, because he may be BAH, connective tissue associated, he may have left ventricular heart disease, and in such situation, we will not give a targeted vasodilator therapy. SAPH may be present, especially in patients with antiphospholipid or lupus diseases, maybe associated with the group 3 due to chronic lung disease and interstitial affection. So the second point, we have to clarify the cause of pulmonary hypertension. And the last point, to clarify what kind of connective tissue disease, because management will be different. Patient with lupus associated BAH may respond well on just cyclophosphamide and corticosteroid, which is not the situation in scleroderma.
Thank you.
I think we will satisfy the floor. So
السلام عليكم ورحمة الله. سعدت صباحا. أحمد البوسيفي من طرابلس ليبيا. على أي حال, where we are from the worldwide. Okay, thank you for Shaya and Abdullah and Ayman for this gathering. And we think deeply. Screening database, we are lost in our Arab world. So it's very important because we are missing a lot in certain area in Arab world. Some of screening database and also diagnosis, sometimes drugs. Many patients we are lost, many patients they are suffering in a certain area. We discussed last night, of course, with Dr. Abdullah regarding even what's we going with the body in our port, زي الرابطة العربية للpulmonary hypertension in pediatric and adult, and training for our generation. So it's a very important issue for our future to be coming in a stage for worldwide, and even to be interacting between our society or our group in our port with others, and to be facilitate, of course, what we need from database screening up to the treatment. So by the end, we can do something for our patients. It's a very important issue from this outcome points from this meeting, because it's a very important. نشكركم فعلا على التعاونية هذه اللي من من الجمعية السعودية للضغط الشرياني الرئوي، وهذه طبعا ممكن فعلا نخلق فيها تدريب بشكل كبير جدا. وموضوع الكونكتيف تيشو والother issues even in pediatric, because now we are think a lot about adult, but we are little bit in this meeting don't talking deeply about pediatric pulmonary hypertension, because it start earlier. Something start earlier because we have a certain problems in pediatric age group with this issue. It's a very important. We're missing a lot of children regarding pulmonary hypertension. So we think deeply about this issue. I'm raising these points, and this is to be discussed between the group. Thank you.
Actually, I would like to assure you that yesterday there were illustration for the Saudi registry, also for the Egyptian registry, which is getting much bigger. And I think in the near future, we will have other registries from other countries. I'm sure in Oman, in UAE, there is registries. I hope in the near future, we hear from Libya and other countries. And I believe we are getting much better in our practice. And this will imply on the way we treat our patients. Dr. Faisal, Dr. Faiz. Dr. Faiz has a question. Okay, no problem.
Okay. Assalamu alaikum, Dr. Hanan Bugagis in Benghazi. First, I would like to thank you and compliment you on this very informative meeting. And actually, it gives us hope that the collaboration between different parts of the Arab world is going to move forward. And I pray that for us cardiologists as well, we start doing with our sister societies different similar meetings. Now to my question. Sometimes you get these patients, especially young to middle-aged females with really limiting symptoms. But when you investigate them, like you do a CT chest, CT pulmonary angio, and also by doing an echo, there isn't really any features that are going to suggest that this is pulmonary hypertension. Now, what do we do with these patients? Because do we send them to a right heart cath? There's nothing really there on echo, maybe a TR velocity of 2.9, but does not exceed that. What is the step? Because really they are symptomatic and there's no explanation to their symptoms when we complete their investigations. Thank you.
Thank you for your question. So the diagnostic algorithm for the shortness of breath per se is different from pulmonary hypertension. It's one of the causes of shortness of breath is pulmonary hypertension. So there's multiple features for pulmonary hypertension other than just echocardiogram. Let's say we have significant normal pulmonary function test except DLCO. So to give you a hint, there's something else going on. Sometimes it's just a shortness of breath secondary to PE. Acute event. It's maybe because of chronic thromboembolic disease, it's not SAPH. So let's say we have a patient with risk for pulmonary embolism and they have recurrent pulmonary embolism. You are doing echocardiogram looking for pH, and then you would like to think this is a SAPH. Maybe the echocardiogram is normal. So, and the patient is symptomatic, especially with exertion. So it doesn't mean this is like there's nothing else going on. We need to do VQ scan to look for this entity. So that the shortness of breath per se has multiple ways to work up. One of the other important things is cardiopulmonary exercising test. So is it just a lack of fitness? Is it a cardiac? It is a pulmonary diseases. So you have to look for all these things. So there's multiple work you need to look into it. Then if you have a high risk patient with the risk features suggesting pulmonary hypertension, low DLCO, worsening cardiopulmonary exercising test, positive maybe VQ scan, even with normal echocardiogram, maybe this is a pH because you can miss some cases. Maybe you are today and yesterday we are talking about pH, but there's multiple other diseases you have to look for the causes of shortness of breath, as long as you are cardiologist, as I hear. So coronary artery disease can present even with normal echocardiogram. Yes.
Still, this is what I'm saying is that first of all, unfortunately, we don't have VQ scanners. So this is one big gap in our algorithm, diagnostic algorithm. So we always usually the next step is right heart cath, because of once we do a CT pulmonary angio and all of the first parts of the algorithm. But one major problem is that we don't really have a VQ scan. But I'm saying that this lady had these tests, the first tests were done, and she has no risk factors for left, like for coronary artery disease, or I think she's a 38 female lady. So this is what I mean. Sometimes you are, due to limitations also in, this we have to consider, we are not, a lot of the Arab countries, we're not in an ideal situation where you have all these tests that are written in the algorithm. So I think sometimes we need to adapt. We need to come with the different ways. And this is probably, again, a role for our scientific societies to try to adapt according to your situation. And that's my question. Do we go for a right heart cath in these situations?
This young lady with shortness of breath, you don't have much facility to do, like look for workup, and you have the right heart catheterization is just an easy, no sedations, no intubations. It's just a matter of 5, 10, 15 minutes procedure, and you have a high risk or you have a high suspicious. I will just close this chapter and do it and say, okay, this is not a pH. At least we can sit down and think for other causes for shortness of breath.
Maybe the last question, Dr. Faiz.
Actually, I have a comment just to add regarding the severity of the pressure in the echocardiogram. Always remember that echocardiogram, it's an operator dependent. So if you don't have a really clear and beautiful jet velocity, so your readings can be underestimated or overestimated. So it's a really operator dependent. As Dr. Shaya said, you have to look for not just for the pressure, you have to look for the RV size and RA size and the left side. So this is why they put right heart cath is the gold standard for the diagnosis of pulmonary hypertension.
May I have a last comment, actually, for this very hot discussions. My dear colleague from Libya, do you have thallium scan in your center? You don't do no scans at all? Well, because if you have thallium or you do kind of scans, this is a problem that we faced in our practice. We didn't have VQ scan at first. Then I tried to struggle, and we could prove the ampoules of albumin microaggregate technetium. It's very cheap. And then we started to build the experience with the radiologist and the to interpret. And now it's fine, and it's very cheap. So you can start step by step. This is the first point. Second point, I do believe in DETECT study. Actually, when you go deep in the study and how the number of patients, the multi-center attitude, the equation, the parameters they have, more than 112 parameters, and then they started to elect the parameters until they found the last 6 one. So I think the DETECT study, you should reevaluate it. And actually, we have a study to do some accreditation for this, or not accreditation, of course, but to study and to adapt it to our patient. I have my colleague, Mohammed, he has his MD thesis on 30 cases of scleroderma, and actually it was very helpful. So I do believe in DETECT study in order to elect patients who are going to echo and then going to right heart cath. So maybe you have a second look for this. Thank you very much for the marvelous illustration and the hot discussion, of course. And I think we come to close this session. Dr. Abdullah, you would like to add anything?
Thank you very much, شايع, for your very, very, very fascinating cases without مؤثرات صوتية okay. Three messages from Shai's case, quick ones, because Egyptians have to go to Jum'ah prayer. Those who are travelers, they can stay and we can discuss things. One is that association between connective tissue disease and pulmonary hypertension is a killer. Number two, you have to detect the patient as early as much you can. Number three, early intervention can make a difference in outcome, and that has been proven in the society. His second case came already late with severely dilated RV, admitted to ICU and passed away. If she would have been detected 2 years earlier, she would have been surviving. So these are the messages from your two good cases. Thank you so much. We have two other fascinating cases. فيهم مؤثرات إخراج وكل شيء. فإحنا I think وقت الصلاة is أزف. We will delay them to the afternoon session. Dr. Faisal, Dr. Abdullah, and Dr. Rahman, please be here to give your cases. And there will be further discussion on them, inshallah. We'll see you at what time, Dr.?
1:30.
1:30, inshallah.
There will be lunch, okay? So we'll have a prayer and lunch. So if the Saudi and Libyan colleagues, after you finish your short prayer, you can go to lunch. Then we'll join us here 1:30.
العالمين الرحمن
ايوه.
Bismillah ar-Rahman ar-Rahim. Now we start we will continue actually the session that we'll cut because of the prayer. It's my pleasure to introduce Dr. Faisal Al-Daiz. Dr. Faisal is a pulmonary fellow, King Faisal Specialized Hospital and Research Center, Riyadh. He's going to give us a case now.
Assalamu alaikum jami'an, and good afternoon. I'll present another case today, mainly about vasoresponsive pulmonary arterial hypertension. But what I'm going to go through is actually two cases rather than one. And both had different course of disease, and hopefully we'll find it as interesting as we did. So we'll start with the first case. So this is a 28-year-old lady from APHA, which is from the southern region. She's married and has no children. So initially, she presented to us with gradually progressive exertional dyspnea for the past 2 years. She had the WHO function class of 3, which has affected her daily life activities. She had no other symptoms. And looking back at her background, she had no history of connective tissue disease, cardiac lung disease, hematological disease, VTEs, or listed drugs previously, and no history of miscarriages or no family history of pulmonary hypertension. On exam, she had an oxygen saturation of 97%, breathing ambient air. She had a distended jugular venous pulse, loud P2, but the rest of the cardiovascular examination was normal. Chest examination was normal, and she had no clear signs of right-sided heart failure and no lower lymphedema. Further working up to find the cause of her exertional dyspnea, 12-lead EKG was done. It was normal sinus rhythm, but showed some right heart strain, mainly with right axis deviation. Labs did not reveal any anemia. Rest of the labs were normal, apart from an elevated pro-BNP of 650. Looking at her echo, she had an ejection fraction more than 55%, RVSP of 45 to 50. Right ventricular size was mildly dilated. Her right ventricular function was reduced as well, but mildly. Right atrium was dilated as well, but she had mild tricuspid regurg and a peak TR velocity of 3.3. So overall, clinically and based on echo, findings are clearly suggestive of pulmonary hypertension. So further workup to find secondary cause of pulmonary hypertension was sought with negative hepatitis screen, negative HIV and schistosomiasis, a negative autoimmune workup, and normal TSH. We did further workup with pulmonary function test. It showed normal spirometry and lung volume, but isolated reduction in DLCO. Her 6-minute walk test, she was able to walk only for around 660 meters, and her saturation dropped during the exercise up to 89%. Further workup with imaging showed a normal chest X-ray apart from a prominent main pulmonary artery. Her CT chest, again, confirmed the presence of finding of pulmonary hypertension with prominent central pulmonary arteries, but this time around, she did not have any mediastinal lymphadenopathy or any pulmonary embolism or any lung changes suggestive of lung disease. A VQ scan ruled out CTEPH, and abdominal ultrasound did not reveal any findings of liver cirrhosis or portal hypertension. Now, to confirm the diagnosis, we went for right heart cath. So the mean pulmonary artery pressure was elevated, severe, actually 58 millimeter mercury. Her mean right atrial pressure was normal. Capillary wedge pressure was normal. The PVR was very high, about 20 Woods unit. Cardiac index and cardiac output at that time was normal. And unfortunately, for some reason, at that time, when she presented to us, vasoreactive testing was not done. So what we have right now is only precapillary severe pulmonary hypertension. So initial impression at that time was most likely patient has idiopathic pulmonary arterial hypertension after you ruled out secondary causes. And we're trying to fit the patient whether the patient is low, intermediate, or high risk. So the patient did not have any signs of right-sided heart failure. Her symptoms were slowly progressive. She did not have any syncope. Franklin class was 3. She walked around 660, so this is intermediate. The pro-BNP was around 5 to 600. Imaging, there was no pericardial effusion. And the right atrial pressure was less than 8, and cardiac index was 2.5. So overall, most likely she's leaning toward being an intermediate risk patient. So the overall diagnosis at that time was patient has severe idiopathic pulmonary arterial hypertension with intermediate risk and a functional class of 3. So since the patient presented with the WHO functional class 3, we decided to start upfront combination therapy with sildenafil and bosentan. We, of course, as any patient with pulmonary hypertension, educated them on avoidance of pregnancy, although she declined to have any form of contraception. And we gave her vaccination, annual influenza vaccine and pneumococcal vaccination. Now, after we diagnosed and started treatment, we followed her up. During the first year, she had significant clinical improvement. By that, I mean exertion dyspnea improved, a 6-minute walk test improved from 260 to 350. Her ProPNP significantly improved as well from 650 and 380. Her functional class is 2 from 3. And overall, still, risk assessment is intermediate. Now, looking at everything, 6-minute walk test is not as good as we wanted, which is more than 440. ProPNP is not less than 300. Function class still 2. So she's still in the intermediate risk segment. So we've decided to give her a third vasodilator therapy. So we started an iloprost, 2.5 mics every 4 to 6 hours, hoping that this will improve her risk from intermediate to low risk. So upon follow-up during her second year, her symptoms still remained, for some reason, functional class 2 with intermediate risk. She did not reveal any improvement. So when we dig deeper further into history, we found out that the patient is actually not adherent to medications. She misses a few doses from sildenafil and iloprost. And even this is clearly present in the ProPNP, fluctuates between 500 and sometimes 1,500. And 6-minute walk tests fluctuates between 300 and 400. And unfortunately, she got pregnant. But after we explained to her, and especially after my colleague, Dr. Abdel Faris, presented about the deleterious effects of pregnancy in pulmonary hypertension, she agreed to undergo medical termination of pregnancy. Now, the main issues right now we're having is first, medication non-adherence, which is something we have to tackle to improve the patient risk and outcome. And the second issue is her pulmonary arterial hypertension is still in the intermediate risk. So I just want to raise a question and discussion in the audience. And at this stage, since she's already on 3 vasodilator therapies, she's still in the intermediate risk. Any suggestions on any thing you would like to add, or any further testing should be done at this point?
Mics, who has the mics so can handle it to the doctor there, please. مسموح لك بس سؤال واحد دكتورة، انت سألتي كثير. امزح معك، تفضل. هي مسكاها عليك يا فيصل. Where is vasoreactivity?
أيوة ممتاز. This is what I'm trying to get at. So one of the things that is incomplete in our workup is actually an incomplete hemodynamic assessment. So we decided to. So the first question we have to ask.
تسمح لي هو سؤالك الحقيقة وجيه في اللحظة دي. Whenever we have a question that we cannot answer, we have a problem, we have to go to the hemodynamics. So I think the answer is to go to the right heart case, and after we go to the right heart case, we do it properly. عشان أبقى جاوبت على.
So before we proceed with any vasoreactive testing, we have to ask ourselves, is it indicated or not? So we have to know the indication, which is the group 1 pulmonary arterial hypertension, mainly idiopathic, heritable, and drug-induced. And keep in mind that of all pulmonary arterial hypertensions, 10 to 20% may be responsive. And we have to know also the contraindication and whether is it safe to proceed with vasoreactivity testing. So those who should not proceed with vasoreactive testing, those who are hypotensive, very low cardiac index, or WHO function class 4. So first proceed with echo to see if there is any changes, given that she's been on treatment for almost 2 years. So her ejection fraction remained unchanged. RVSP has increased, so pulmonary hypertension is getting worse, most likely. Right ventricular size is becoming more dilated, the function is becoming more reduced, and the right atrium is more dilated now. Tricuspid regurg is worse, and she began to develop very small pericardial effusion. So definitely the patient is getting worse looking at the echo. So now let's go to the right heart cath. So the mean pulmonary arterial pressure has gotten worse over 2 years, from 58 to 81. The mean right atrial pressure has increased, but is still within borderline normal. Which pressure has remained normal. PVR has gotten worse from 20 to 30. The cardiac index was around 1.5 liters and the cardiac output of 2.3. So definitely patient getting worse clinically and hemodynamically. Now the vasoreactivity testing was significant. It dropped from 81 to 40. And the cardiac output increased from 2.33 to 2.91. So this is a positive vasoreactive testing. So define a positive reactive vasoreactive testing is a reduction of mean pulmonary arterial pressure of 10 or more to reach an absolute mean pulmonary arterial pressure of 40 or less. And there is an unchanged or increase in cardiac output. So our patient definitely had a positive vasoreactive testing. So the final diagnosis was a vasoreactive idiopathic pulmonary arterial hypertension. Now, since the patient is already on triple vasodilator therapy, and we found out the patient is vasoreactive. So the question we ask ourselves whether how beneficial is calcium channel blocker in such cases. So let's look at the evidence. So we know that 50% of almost vasoreactive patients will respond to calcium channel blockers. And the choices usually we have is nifedipine, diltiazem, and amlodipine. And nifedipine is actually the most studied one and to require very high doses. Usually in hypertension, we require up to 90, and pulmonary hypertension could reach up to 240 per day. So let's look at the evidence, whether it improves survival and how does it affect the functional class. Unfortunately, data are lacking in terms of randomized controlled trials. So everything we depend on right now is cohorts and observational studies. So this one study in 1992, published in New England Journal of Medicine, looked at the survival rate between the patients who are on calcium channel blocker and non-vasoreactive patients. And it actually did show that there is an improvement in survival up to 5 years. So the survival in vasoreactive patients is better than non-vasoreactive patients. Another study published in 2005 looked at the outcome of those patients, and it revealed that the functional class improves at least over 1 year, but they tend to lose vasoreactivity after 1 year. So now we know calcium channel blocker works, and it actually might improve this patient's survival. So I think one of the questions I would like to add the audience as well, at this point, how would you introduce a calcium channel blocker? Would you stop all vasodilator therapy and start calcium channel blocker, or would you? How would you deal with such a dilemma? I think before I proceed, because we proceed with the controversial.
Anybody has bright ideas how to do that? It's, by the way, there is nothing in literature how to suggest what to do for these patients, but maybe it's just a clinical experience of anybody. So now the patient, and by the way, just to make it more clear because it's confusing, we recommended the vasoreactive complete diagnostic workup, and now we are presenting a case without vasoreactive test. So this patient was actually referred initially 2005 or 6 to colleagues of ours in the pulmonary section, but at that time there was no pulmonary hypertension program. So we inherited this patient from that surface. And then we saw her living for many years. Yes, she was progressing, but she lived more than what is expected from severe idiopathic pulmonary arterial hypertension. And then we did not like the way she was worked up in the past, so we repeated the cardiac cath, and to our surprise, it came positive for vasoreactivity. There was a small story about this, by the way. Going back in the chart of that patient, and then talking to one of our colleagues, Dr. Baha Fadil, cardiologist, he said one day, he was doing an echo for this lady in the older days when she first presented to King Faisal. And he said he was doing the echo and her RV is very dilated, RA is dilated, her numbers are very high, the PA pressure. Maybe I didn't tell you this story. No. Yes. And then he had somebody called him and he went to answer his mobile and came back while she was on the bed. And then he looked again, he put the sonar to look at her. And all of a sudden, her RV is shrunken, her RA is good, her PA pressure is much less. So he was shocked. And he was talking to himself, basically, what's happening, what's wrong. And apparently, the patient was non-compliant, as you mentioned, Faisal. And her iloprost was in her pocket. So when he went to answer his phone, she took her iloprost, and she took her iloprost. And then when he came back, the effect of iloprost was already there. So, and that was when he mentioned that story to us, in retrospect, that was an indication that this patient was highly reactive to vasodilators from that time. So when we inherited this patient years later, and now we are repeating her right heart cath, and her vasoreactivity is very impressive. By the way, the mean should come more than 10 millimeter mercury to less than 40. But this patient was 40, right? But came from 80. So she dropped 40 millimeter mercury. So medicine is not like black and white. It's not like these numbers are not magic. So you cannot ignore this response. So significant response with significant increase in her cardiac index from 1.5 liters to 2.6 liters, I think, and her PVR was also down. So, so the question of Faisal now, this is a patient who seems to be very highly reactive, pulmonary hypertension, but she was already on treatment. So we did what we did with the other pregnant lady this morning. So I think we should proceed.
The answer is I would stop. I would stop the drugs.
Yes, he knows the story. Several times I told him the story.
I have a similar case.
So this is exactly what we did. So we directly admitted the patient and we gradually started to withdraw the vasodilator therapy and introduce calcium channel blocker to make sure the patient does not have rebound pulmonary hypertension. So after we started calcium channel blocker with nifedipine up to 120 milligram per day, we started to follow her up over the next 2 to 3 years. So you can see initially when we started calcium channel blocker, her proPNP improved significantly to the point it reached up to 200. Her 6-minute walk test as well improved up to, and she reached more than 400. And you can see the trend here. After we reached 1 year, proPNP started to increase and the 6-minute walk test as well started to go down. So after 6 months of calcium channel blocker, we reviewed her echo. You can see her RVSP slightly improved. However, other findings of right ventricular size and function improved significantly with less dilation, improved function, and improved tricuspid valve as well. And there is no more pericardial effusion. So 2 years after starting calcium channel blocker, she began to have a progressive exertion dyspnea. The function class worsened from 1 to 2. And on examination, she had elevated GAP, JVP, and mild lower limb edema. So what we did at that time, we wanted to look where are we in the hemodynamic side. So we repeated the right heart cath after 2 years of being calcium channel blocker. So the mean arterial pressure is slightly better than it was before while she's on calcium channel blocker. Right atrial pressure remained the same. PVR has improved from 30 to 22. Cardiac index slightly improved. Vasoreactivity testing, on the other hand, this time around actually did not improve significantly. It's not fitting the criteria we've mentioned. Mean pulmonary arterial pressure dropped from 72 to 57, and the cardiac output has improved. So still, it seems the patient has some vasoreactivity, but it's not significant enough to call this as a positive vasoreactive testing. But looking at how the patient now presented with the WHO function class 2, worsening clinical findings and some of the hemodynamics. Now, question we asked ourselves, why did she lose the vasoreactivity testing? And would you stop calcium channel blocker or add an additional vasodilator therapy? So to answer this, we have to know about loss of vasoreactivity. So the pathophysiology, why vasoreactivity get lost with time is unknown. But we do know that the response is generally short-lived and up to 5% will have long-term response only. And there's an observational study in 2016 showed that 63% of vasoreactive patients lose vasoreactivity within less than 1 year. And 91% of these patients who lose the vasoreactivity require escalation within 1 year. So our patient fits in that criteria. So the final findings is diagnosis is that now she has an idiopathic pulmonary arterial hypertension with loss of vasoreactivity, still in the intermediate risk group with a functional class 2. And we ruled out some emergent secondary causes such as pulmonary embolism and anemia to try to explain why she has worsened exertional dyspnea. So we've decided to continue on calcium channel blocker for now because she still has some response to nifedipine, but we added an additional vasodilator therapy with macitentan, 10 milligram orally daily, and the addition of furosemide. And we continue to tell her about avoidance of pregnancy, given that she got pregnant at some point. So now we continue to follow up. She still continued to gradually have progressive exertional dyspnea with functional class of 3 now. So she's progressing on calcium channel blocker and macitentan. So we decided to add sildenafil at this point. We offered prostacyclin therapy, but the patient declined. So let's look at how the trend of her proPNP 6-minute walk test fared. So you can see here when we started calcium channel blocker. So after 2 years, we've started macitentan, and you can see the improvement in the proPNP 6-minute walk test, and later on added sildenafil. But despite that, pulmonary hypertension is a progressive disease, so she continued to progress despite the therapy. So this concludes the second case, the first case. So I'll proceed with this second case with a bit of a different approach. Do you want questions first?
Yes, please. Okay, sure. We'll discuss this because there are many messages here, and this is the aim of this meeting. Dr. Ahmed, تفضل.
يعني انا من ضمن الحاجات اللي انا ما بقدرش استوعبها، بقعد افكر فيها كتير، ان انا بعمل تيست بدراج وبدي انذر دراج. من ضمن الدراجز اللي انا بعمل بيها تيست، one of the drugs treats pulmonary hypertension للإليوبروست. الإليوبروست بعمل بيه irreversibility، بس لما ادي للعيان الإليوبروست ما بيتحسنش، واضطر اديله كالسيوم شان بلوكر another thing. السؤال بقى اللي انا عايز اساله لحضرتك هو كون ان العيان على تارجت ميديكال ثيرابي تريبل ثيرابي since more than 2 years، ده هيأثر بالبوزيتيف او بالنيجاتيف على الفازو رياكتيفيتي تيست ولا لا؟ ده سؤالي.
Very good question. Thank you so much. There is no clear answer for this, but interpreting the data, the vasoreactivity test while the patient on vasodilator therapy, you have to interpret this with caution. If it's very clear, impressive, dramatic improvement, you take it as vasoreactivity. If it's partial improvement, even if it sometimes fits the criteria of responsiveness, but not really, yani, for instance, the PA pressure came down to 39, 38. We have cases like this in our practice. Maybe it's not a good idea to consider this as a vasoreactive. So if patient is treatment naive and you did the vasoreactivity, you take it by the criteria. If patient is on treatment, you really judge. It depends on the clinical case scenario. If it's very impressive, dramatic improvement, the cardiac output improved significantly, the PA pressure came down significantly to less than 35 or so, not close to 40, you could consider it positive. If it's clear, sorry, not clear and close to 40, maybe it's a good idea not to consider it vasoreactive. So this patient, I think, fits this clinical scenario, doctor. It's very confusing, but this is also what you see in the practice. You see a patient who was initially vasoreactive, considering, of course, she had the first time the vasoreactivity tests, ignoring the previous history. And then with time, nearly 50% of these patients, they lose their vasoreactivity. In some studies, 63%, but I think the average is 50%. So I think the clear message from this is when you have a patient who is clearly vasoreactive and they respond initially to treatment, this is not the end of the story. You have to keep following these patients up because good number of these patients, with time, they lose their vasoreactivity. So clinical assessment is very important, and then hemodynamic assessment is very important. That's number one. That's message number one. It's very important. Number two, when patients already on calcium channel blocker and they are clinically worsening, and then you did the hemodynamics, and they still have some partial response, you add the target therapy, you keep the calcium channel blocker, but you have to be very careful because if they progress further and their disease becomes severe, the calcium channel blocker can cause peripheral vasodilatation while they're having fixed high pulmonary pressure. So they can actually lead to syncope and worsen the situation. So in this situation, it's better to drop the calcium channel blocker if the patient progressed that far. Obviously, such a patient, very interesting patient. This is also a difficult patient. Her compliance was not very good and all these things. But now she needs triple, including IV, because she's already progressing that far, and she should be off calcium channel blocker. But she's very difficult to convince. Last year, by the way, 2 years ago, during the pandemic, she got pregnant.
Yes, she did.
Yes, and despite all of this, so you know, social in our countries, you know, when it comes to pregnancy, is very hard issue.
Dr. Karim. Thank you, Faisal. It was a marvelous presentation. I got puzzled by two things that we don't do usually as a cardiologist, which is the vasoreactivity. Why the patient was vasoreactive over these all years, and despite the progression, she's still vasoreactive. Does this mean that the vasoreactivity persists for a very long period before converting into a non-vasoreactive patient? This is the first thing. The second question regarding the calcium channel blocker. The responder is about 10% or less than 10%. So what is unique with the calcium channel blocker in such patients as compared to other drugs?
The first question is, in fact, it is variable. The long-term response to calcium blocker is variable. And now in the last classification of pulmonary hypertension, they put actually the long-term calcium channel blocker responders as an entity by itself. So there are patients who actually continue to have a calcium channel response, and they can live nearly normal survival rate. There are patients, however, maybe 50% or more, they lose it with time. Now, how much that time is different from patient to patient. For example, this patient took several years to go, but I think another patient, I don't know if you're presenting another patient.
There's another patient, yes,
who lost it in 2 years, I guess, or so.
More.
So there are patients who lost it in 1 year. You could see them progressive. So you cannot really predict this one. Now, the second question, why calcium channel blockers? Because the main mechanism of the pulmonary hypertension, this patient is actually vasoconstriction, not remodeling of the pulmonary vascular bed. And a calcium channel blocker basically relaxes smooth muscles and relieve this vasoconstriction. And the long responders, they live normal life, nearly normal life. Now, with that being said, there are patients who have not only vasoconstriction, but the process of this remodeling have already been taking place, but it's not clinically overt. With time, 1 year, 2 years, 5 years, it depends differs from patient to another. They actually start developing this remodeling thing because of this indolent, subclinical, very slow remodeling inflammatory response. I think that's the summary of this.
Well, I think I will tell you in short my experience. I have a case who was have been treated with bosentan and sildenafil for 2 years. Marwa knows this patient very well. He's very famous to us. He came to us 7 years ago. And when we do the right heart cath, he took it empirically, by the way. He took it empirically. There were no right heart cath at all. When we failed this patient, we put him in the right heart cath. We do vasoreactivity, and he was totally vasoreactive. I mean, when we put the nitric oxide, his pressure dropped up to, it was 27, something like this. So we shifted all the drugs to calcium channel blockers, nifedipine, and up till now, this patient is function class 1. He go to exercise and he's doing very well. So I started to look for this. We have 2 mechanisms for recruitment of the pulmonary circulation: capillary dilatation and capillary recruitment. There are some people who are called partial responders, partial vasoreactive. So these people are just recruiting some vessels, but they cannot dilate it. They do not dilate the vessels. The capillaries that are blocked, they cannot dilate it. So they have vessels or capillaries obstructed already, and they have some capillaries that are recruited. That's the cause for partial vasoreactivity. But the true vasoreactive, they don't have obstruction. They are going to dilate and become normal. Actually, this is in literature, and I think I have prepared some slides for this in SAPH in the future. So they now tell that the vasoreactive is a different phenotype. It's something else. That's why they put it in a separate class. But you have to be sure he is pure vasoreactive for 1 year, and this is by definition now. So you have to follow him up for 1 year in order to remain vasoreactive and to consider him as belonging to this. This is the explanation: the capillary dilatation and the capillary recruitment. This is the mechanism why some people are partially and why some people are fully vasoreactive.
But one more, Dr. Karim, that the last echo, the last cath, she's not responder. There is nothing called, by the way, you can clinically or hemodynamically define as partial responder, but there has no clinical use of this. This is considered non-responder the last time. And she was advised to have her IV prostacyclin because her prognosis now is like any idiopathic pulmonary hypertension who is not responder. Yes.
So we'll move on to the second case. I'll make it just, it's a bit more straightforward. So this is a 32-year-old lady from Dammam, which is the eastern province of Saudi Arabia, and she's married and has no children. So the history was the same. She had exertional dyspnea for up to 6 months. from her local hospital, and they did work up with echo, which showed finding pulmonary hypertension. So she was referred to us based on that. She had the WHO functional class of 3 upon presentation, and no other history and no background history to suggest a secondary cause. On examination, she had a saturation of 95% on room air. She had only loud P2. Apart from that, the cardiovascular examination was normal, chest exam was normal, and she has no signs of right-sided heart failure. 12-lead EKG only revealed right axis deviation. Labs ruled out other causes such as anemia with the elevated proBNP. Now, her echo upon arrival in her initial presentation showed an RVSP, elevated RVSP, mildly dilated right ventricle, mildly dilated right atrium, normal right ventricle function, and only trace tricuspid regurg. And the peak TR velocity was 3.2. So the findings are suggestive of pulmonary hypertension, particularly in a clinical setting. So we did further workup again, same workup as we did before, which was negative. A pulmonary function test was normal. 6-minute walk test, she walked around 340 meters with a saturation of 92% at the end of the exercise. So further imaging, so the chest X-ray was normal apart from the prominent main pulmonary artery. CT chest was negative for any lung diseases and only revealed a prominent central pulmonary artery and mosaic perfusion pattern with pulmonary hypertension. Her VQ scan ruled out CTEPH and abdominal ultrasound ruled out levocerosol and portal hypertension. Now this is her right heart cath. It revealed the mean pulmonary artery pressure of 71, so severe pulmonary hypertension. The mean right atrial pressure was elevated of 10, which pressure was normal. The PVR was elevated around 17. The cardiac index was around 2.34. And you can see her vasoreactive testing. It dropped from 71 to 34. And the cardiac output improved from 3.44 to 4.31. So this is definitely a positive vasoreactive testing, as we've shown before. So the final diagnosis was vasoreactive idiopathic pulmonary arterial hypertension. And the patient at that time was classified as intermediate based on the parameters we had. So she was intermediate risk with a functional class of 3 upon presentation. We started calcium channel blocker with nifedipine up to 120 milligram per day. Again, we educated her on avoiding pregnancy and receiving recommended vaccination. So after follow-up within the first year, 3 months after diagnosis, her functional class dropped from 3 to 2. A 6-minute walk test improved up to 400, and proBNP dropped to 388. But when you look at her after 1 year, functional class is now 1. 6-minute walk test is around 460, and proBNP is 42. So she's definitely in the low intermediate, low risk stratification. So when you look at the parameters and the trend over the next 3 years, you can see upon diagnosis how the proBNP dropped after starting calcium channel blocker, normalized at 1 year, and continued to be normal for at least 3 years looking at these parameters. And this is also evident in her 6-minute walk test. So let's look at her echo 3 years after. What happened to the findings she had? So you can clearly see that RVSP is now normalized. Right ventricle is completely normal in terms of size and function. Right atrium is normal, and tricuspid valve is normal. So the patient is now back to a normal patient, both radiologically and clinically. So this is the interesting part is the right heart cath 3 years after. Now, when we did the right heart cath, she was already on calcium channel blocker 120. You can see mean pulmonary artery pressure right now is 34. Mean right atrial pressure was 10 and now normalized to 4. The wedge pressure remained normal. The PVR dropped from 17 to 8.7, and her cardiac output was around 3.01. However, vasoreactivity at that time was not done while she's on calcium channel blocker. But you can see while on calcium channel blocker, she improved significantly, even hemodynamically, after 3 years of being on calcium channel blocker. So now we followed her up 5 years after, still on nifedipine 120 milligram day. She is completely asymptomatic with a WHO functional class 1. proBNP is still less than 300, around 58, and 6-minute walk test is 442. So still after 5 years of being a calcium channel blocker, she's completely normal. So something to note about this is the type of responses we have calcium channel blocker, either short term, which I have shown in the first case, which lasts around 1 to 2 years, or a long-term responder, which is defined as improvement after at least 1 year, with clinical improvement to reach function class 1 to 2, and sustained hemodynamic improvement. Either it's the same or better than achieved from the previous reactivity testing. So let's talk briefly about the long-term responders. So the pathophysiology is largely unknown, but some say that there are some genetic variants or specific blood signatures, such as a cultured lymphocyte, that would lead to long-term response. The the current ERC has considered this a different entity and is now part of the pulmonary arterial hypertension because it portends to significantly better prognosis in the end. So to summarize, any patient with pulmonary arterial hypertension always consider vasoreactivity testing. So we wouldn't be the same as the first patient we had. And always do it for those who has idiopathic, heritable, or drug-induced. So when you're starting any calcium channel blocker may improve based on cohort studies, 5-year survival, and maintain functional improvement for at least 1 year. And at that time, most likely the majority will lose vasoreactivity and will require further escalation. And that's the end of my talk. Thank you.
Thank you very much. Actually, Faisal, it was very interesting and actually stimulating talk and 2 cases. Any further question for Dr. Faisal? Okay, I think it's time to call for Dr. Ahmed Abdelaziz. Professor Ahmed Abdelaziz is Professor of Cardiology in National Heart Institute. And actually, he is one of the pioneer cardiologists among the team of pulmonary hypertension and one of the facing the issue of PPA. So I think he is one of the adding cardiologists to our armamentarium of pulmonary hypertension.
شكرا جزيلا دكتور ايمن على هذه التقديمه اللي انا ما استاهلش نصها. الكيس دي I was not preparing to participate with. انا جيت مكان الاستاذ دكتور مصطفى الشاذلي. احنا الحاله اللي احنا هنتكلم عليها دي انا اخترت لها عنوان rare of the rare. هي actually rare of the rare of the rare. And we will see why.
استخدم الثاني دكتور، هذا الاحمر.
ده البوينتر. Okay. This patient was 57 years old, female, born in rural area, non-smoker. She has history of rising PERDs, biomass fuel exposure 35 years ago, diagnosed as bilharziosis and received tartar-emetic during her adolescence. ده كان واحد من الادويه يعني عارف ان يمكن حضراتكم يعني مش فاميليار مع البلهارزيزس، بس احنا البلهارزيزس في وقت من الاوقات كانت حاجه انديميك عندنا في مصر من وقت طويل، وكان من ضمن التريتمنت بتاعها التارتاريماتيك. وخدت كمان برازيكوانتال في عند age of 47. When she was found positive with HCV also. We received the interferon treatment. Presented with dyspnea, moderate exertion, gradual onset and progressive course, 9-year duration, dry cough and chest pain. Hemodynamically stable, PMI with 30, mild bilateral lower limb edema, auscultation, just accentuated pulmonary component. Her 6-minute walk test with 180 meters. Pre-test oxygenation was 96 and post-test dropped to 93. And this is a classic chest X-ray of the bilharziosis, dumbbell-shaped pulmonary artery. Her echo, normal left side, just dilated left atrium only. Grade 3 tricuspid regurg with estimated pulmonary arterial systolic pressure with 110. Markedly dilated RV and dilated pulmonary artery, as you see here. Marked dilatation of the main pulmonary artery and both left and right pulmonary arteries. This was her HRCT. There was nothing to mention. VQ scan was negative, and this is the CTPA. As you see, we have a huge pulmonary artery as compared to the aorta. See the 2 circles of the aorta. لو احنا حطيناهم الاثنين على بعض مش هيجيبوا حتى برانش من البرانشز بتاعت البلمونري. This is one of the characteristic features of the bilharzial core pulmonary. Abdominal ultrasonography, enlarged liver, but no focal lesions. Right heart cath, mean pulmonary artery pressure with 53. Capillary wedge pressure failed, and this is one of the common thing that we face with the bilharziasis. It's markedly dilated, so even the balloon can't wedge. Okay, so in these cases we do regularly left end diastolic pressure. It was 9, so it's a clear case of group 1 pulmonary artery pressure by pulmonary hypertension. As a routine for these cases, we do multi-slice coronary and bilharzia cor pulmonale, because it's very common. It's very common in these cases with this huge pulmonary artery to have a compression on the left main. Okay, so at that time it was okay. So started upfront dual combination therapy, followed up 3 months, 6-minute walk test improved to 320, no desaturation. Pre-heart rate was 84, and post with 107, which is acceptable. Functional class dropped to 1 after the specific treatment. So this patient disappeared, came again in 2020. Reassessment: patient has severe dyspnea, recurrent palpitation, functional class 3, 6-minute walk test dropped to 100 meters, but again without desaturation. This was one of the ECGs with one of the presentation of palpitations, clear atrial flutter. Okay. The echo, and these are the 2 comparable echo with between the 2017 and 2020. We have marked dilatation of the pulmonary artery diameter. It was 6.9, increased to 9 centimeters. Okay, but again the left side is okay, the same left side, and the pulmonary artery systolic pressure dropped to 74. It has no significance, but this was the finding at the time. Okay, this was the echo. مش عارف. سواء ده البلمونري ارتري، ودي big thrombus in the left pulmonary artery, and the main pulmonary artery. This is the main pulmonary artery, huge pulmonary artery. Right heart cath. We did the right heart cath, but we faced a very strange thing. The left end diastolic pressure. End diastolic pressure was 9 in the first cath. The second cath was 23. So we have a post-capillary component. We have severe dyspnea. We have palpitation with recurrent atrial flutter. So what do you think? What do you think happened to this patient? Yes? What?
She had dilated left atrium, and
Yes.
she was old age. She should have fluid challenge during the catheter.
Okay, we do fluid challenge. We do fluid challenge when we are suspected the end diastolic pressure in the mid range. In the mid range between the pre-capillary and post-capillary, we do such things. You are right. You are right to have to suspect a HFpEF component, but with the end diastolic pressure 9, it's rather low probability. Trauma.
Pulmonary artery.
Yes. In this patient, we did it on fluoroscopy. We did the heart cath on fluoroscopy. This is the first thing. The second thing, this is mostly an adherent thrombus, and this is one of the criteria of the bilharzial cor pulmonale. They tend to have big thrombi, but mostly stable and adherent to the wall. وده برضه it will raise a question العيانين دول ياخدوا انتي كواجوليشن ولا ما ياخدوش انتي كواجوليشن؟
طب السكند بوينت ما كانش في concomitant arrhythmia at that time؟
في انهي وقت؟
Second time when we go with right heart cath and find the left ventricle end systolic pressure is elevated, there concurrent arrhythmia or
لا وقت القسطره ما كانش فيه، بس هي كان بيجي لها attacks of atrial flutter documented.
I think now it's combined, maybe combined pre-capillary and post-capillary.
كويس. ايه سبب الكومباينيشن؟ يعني ايه بقى اللي جد على العيانه دي في خلال 3 سنين اللي ممكن يعمل لنا حاجه زي دي؟
I think you have to study the coronaries again. The issue of HFpEF is still there because the left atrium is dilating and she has a phenotype. And I don't know if the ventricular interdependence the impingement of the right or the left can lead to this, but I think the other possibilities is more valid. So if I am you, I would restudy the coronaries again and see what's happening. As you did in the first time.
And this is what we did actually. احنا عندنا زياده كبيره جدا حصلت في خلال 3 سنين في البلمونري artery diameter. Pulmonary artery diameter increased from 6.9 to 9, which is it's marked dilatation. So again, we did a CT coronary angio for this patient. As you see here, the pulmonary is huge, okay? And we had this. We had significant compression of the left main ostium, the ostium of the left main. So that's why I told you in the first place, this is rare of the rare of the rare. It's rare, it's PH, it's group 1, which is rare. Bilharzial of the group 1 is rare, and compression of the left main in the bilharzial of the group 1 is rare. So it's rare of the rare of the rare, okay? And we did coronary angiography for this patient, and this is what we see. You have significant compression of the ostium of the left main with other normal coronaries. All coronaries are normal, completely normal, just significant compression on the ostium of the left main. So we fixed this. We fixed this with the stenting. It's post-stent dilatation, and the compression nearly disappeared. Okay, we don't know. We don't know in the future whether it will be compressed again or no. We don't know. This is something to be discussed in the future and to be followed up. But the follow-up of this patient's 1 year, no new arrhythmia, functional class became 2, 6-minute walk test. It improved to 240. Not in like the first. في الأول مرة خالص كانت وصلت ل 340 أو 360. المرة دي كانت midway، حاجة ما بين بدايتها انها تاخد السبيسيفيك تريتمنت وما بين دلوقتي. but the end diastolic pressure became 14. هنا يا دكتورة ده يعني جواب. لو كان ضغط، لو انا هتكلم على هيف بيف فانا لازم على كوز برضو يعمل لي الهيف بيف. ايه اللي يعمل لي هيف بيف في عيانه زي دي؟ اوكي، that's it. Thank you.
Outstanding diagnosis and case presentation, and this is really, it fits the whole scenario of this, the theme of our case discussions, messages after messages after messages. So it's open now for discussion, but this is a very rare complication of severe pulmonary hypertension, particularly bilharzia pulmonary hypertension. It can happen in 20.
Large pulmonary aneurysm. The patient didn't have chest pain at all.
No, dyspnea, just dyspnea.
Dyspnea and palpitation.
Just dyspnea and palpitation.
Yes.
Only dyspnea and palpitation.
So I think the patient was lucky to have such wonderful doctors as you to think about that. The other thing to mention is atrial tachyarrhythmia. It's a major contribution of the patient's symptoms at this situation, and I think it's what is responsible, in addition to the coronary artery disease, on the elevation of left ventricular end diastolic pressure.
Yes.
So the prevention of recurrence of atrial tachyarrhythmia is paramount in this patient. The last thing is about the antithrombotic in this patient. This patient received a left main stent, and she needs a dual antiplatelet for duration of time, let's say about from 6 to 1 year, 6 months to 1 year. In addition, the dilemma of antithrombotic because the patient had a recurrent atrial tachyarrhythmia that can be recurrent, and actually also we have a thrombus in the pulmonary artery. So how would you manage the antithrombotic in this patient?
This is a big dilemma. Just we can imagine it from the left side. احنا عندنا لو احنا متخيلين ان احنا عندنا severe aortic aneurysm, huge aortic aneurysm, okay, and we have a thrombus. Risk, what's more risky? The risk of hemorrhage ولا risk of thrombosis? We have both risk. We عندنا thrombosis and we have risk of hemorrhage. But the risk of thrombosis may cause morbidity, but it will not cause mortality. Risk of hemorrhage, it's immediate mortality. دي كأنها aortic aneurysm بالظبط. يعني عيانة pulmonary artery pressure بتاعها السيستوليك بريشر بتاعها معدي ال 110، يعني زي السيستميك بريشر، وكمان market dilatation of the pulmonary artery. فاحنا اخترنا ان احنا ندي just dual antiplatelet بس for the sake of the left main stenting. واحنا كمان اضطرينا ان احنا نستخدم ستنت الراديال فورس بتاعتها عاليه والثيكنس سترات ثيكنس بتاعها اعلى علشان احتماليات الكمبريشن تكون اقل، فعلشان كده الديوال انتي بليتلت اكستندد شويه كمان عن الطبيعي من الثيرد جنريشنز.
Any further comments or questions? Victoria?
Hypertrophic cardiomyopathy. There is asymmetric septal hypertrophy.
لا هو مش hypertrophic cardiomyopathy، هو just
it is not fulfill the
هو الكompression اللي عامله الماركت دايلاتيشن للار في على ال في سيبتم، على الانترفنتريكولار سيبتم، هو اللي مدي الامبريشن ده. انما هي actually she is not hypertensive. ما فيش اي ايكو كرايتيريا اوف
anterior motion. Systolic anterior motion is not present.
فندم؟
سام systolic.
No.
المنظر
اللي حضرتك شايفاه ده يعني اللي انا مش عارف، احنا ما جبتش انا صوره شورت اكسس، ما كانش في شورت اكسس ولا باراستيرن لونج اكسس، انا جبتهم كلها كانت شورت اكسس على مستوى البلمونري والاورطه. انما لا في الايكو العادي ما كانش في اي ليفت فنتريكولار هايبرتروفي خالص.
And I observed from the parameter of the echo, the dimension.
No, it was not Hawkins, sure.
Okay, thank you.
يعني حرام يبقى هوكم وبالهرزه الكوربالمونال وليفت مين تاخد رصاص احسن.
If there is no question, I like to wrap it with message. So yes, PAH is a progressive disease. Patient can come to you with the progression of symptoms, but sometimes there are reversible causes of this symptoms, worsening of symptoms. So don't think always that is a progression of the disease and you need to add another medication. Look also for secondary reversible causes, pulmonary embolism, for instance, or a rare complication like this. I had a young patient, Dr. Abdulaziz, who actually, she was vacationing in London. She was a 20-plus-year-old, severe idiopathic pulmonary hypertension, refusing IV. She was a mutual patient between me and Galie. She was on dual anticoagulation. She was walking in the streets of London and she fell. And they took her to the hospital. She was in arrhythmia, like your patient. And then immediately the father trusted Bologna, so he sent her to Nazareno Gali. He did the cardiac cath, and there was actually anterior ischemia, induced arrhythmia, and she collapsed basically. And because it was a compression. He put a stent, she lived 3 years later and died after that. So reversible causes of worsening of symptoms should be ruled out. If they are ruled out, then think it's a progression of the disease. Thank you so much for your great case. Thank you.
I think the session was marvelous, and thanks to every distinguished speaker, and thanks to Dr. Abdullah for enriching the discussion. Actually, it was very nice company in the co-chairing this session. And I think we will end the session and call for the next chairpersons, Professor Karim Mahmoud, one of the eminent cardiologists, and actually he's contributing a lot to the education for pulmonary hypertension as a cardiologist, and Professor Marwa Abdelradi. Please co-chair Dr. Karim.
Thank you, Professor Dr. Ayman, for the kind word. This is another session of a challenging pulmonary arterial hypertension. We'd like to start again with Professor Dr. Ahmed Abdelaziz. Sorry, حضرتك هتبدأ السلايد؟ Symposium. Okay. لا هي symposium. So we are going with the Janssen Symposium with pulmonary arterial hypertension treatment updates with Professor Dr. Ayman Farghali.
Well, please, everybody, calm down, okay? the sessions that passed, it was so hot. So now we are going to back to the actual life, and let's go through some patient stories. Actually, this is a Johnson Symposium. So let me go through actual patient stories and let us listen to this patient and how she struggled during diagnosis and treatment. صوت هيطلع؟ أنا عايز صوت يا جماعة. تجيب الصوت من عندك ولا من عندي؟ Okay. Now it's working, yeah? I need the sound. Actually, this case describes how we can switch our treatment and how we escalate the treatment.
أنا سني 35. بدأ الأعراض المرض معايا من حوالي 7 سنين بعد ما خلفت بنتي التانية. الأعراض كانت أول حاجة إن أنا كنت بطلع السلالم حتى لو قليلة جدا كنت بتعب جدا، ومع إني كنت بطلع الأول عادي. يعني أنا ساكنة في الدور التاني، كنت عقبال ما بوصل الشقة كنت ببقى مش قادرة أخد نفسي، بحس بدوخة جامدة. بعد كده الموضوع تطور بقى إن أنا بقت حالات إغماء وممكن تقعد ل5 دقايق أو أكتر. فساعتها رحت للدكتور، كنت بتابع معاه بس كان دكتور باطني، لان كنت شاكه مثلا انها ممكن تبقى انيميا حاجه كده. فاول ما شرحت له الاعراض قال لي لا انت تطلعي تعملي ايكو حالا، واطمن بس ان الدنيا تمام ونشوف ايه الموضوع. ففعلا طلعت ساعتها عملت ايكو في نفس الوقت وخدت النتيجة على طول ونزلت له. فقال لي بص انت عندك حاجة اسمها ارتفاع ضغط الشريان الرئوي، وكان ساعتها الضغط حوالي 85. فقال لي بس ما شرحليش ساعتها المرض ده يعني عبارة عن ايه، مدى خطورته، خطير ولا عادي ولا علاجه. هو بسط لي الموضوع ده ان انا بقيت حاسه ان قلت ممكن يكون حاجه موضوع عادي. لقيت ان في يعني قالوا يعني كانوا كاتبين ان من احسن الدكاتره اللي موجودين ساعتها كان دكتور ايمن عبد الحميد فرغلي. فساعتها عملت سيرش على الاسم بتاعه وشفت عيادته فين ورحت له الحمد لله، وابتديت احس ان مجهودي رجع تاني زي الاول وبتاع. بس طبعا عرفت ان المرض ده فيه نسبة خطورة طبعا، وللاسف هو ملوش علاج يعني نهائي. بس هو في علاجات دي بتحاول ايه ان المرض ما يتطورش يعني الحاجات اوحش او كده. في ادوية للاسف مع انها فادتني كتير بس للاسف ضرت حاجات تانية وكان ليها اثار جانبية جامدة بالذات على الكبد والحاجات دي. فبقيت باخد ادويه برضو مناعيه بتحاول ما تعملش هجمات عشان ما تضرش الرئه او الحاجات دي. فباخد الادويه دي كلها مع بعض والحمد لله كنت ماشيه عليها تمام. بس من حوالي سنه حصل زي انتكاسه ورجع ضغط الشريان يعلى تاني، وصل لحاجه و80 85 تقريبا. وابتديت يحصل لي حالات الاغماء دي تاني وان مجهودي يقل تاني جامد. فلما رحت لدكتور ايمن قال لي انه هيفضل ان هو يزود لي الدواء اللي هو ابترافي مع الادويه التانية اللي باخدها. وفعلا بعديها بشويه حوالي شهر كده ابتديت اخده. وفي الاول عمل لي اثار جانبيه شويه زي الصداع والام في الفك جامده. بس يعني الاعراض دي حوالي قعدت شهر، وبعد كده الحمد لله الجسم تقريبا اتعود خلاص عليه والاعراض دي اختفت. والحمد لله الحالة اتحسنت كتير. يعني دلوقتي انا عملت اخر ايكو من حوالي شهر النسبة كانت وصلت حوالي 60 65، وحالات الاغماء دي الحمد لله اختفت خالص. بس والمجهود الحمد لله رجع تاني زي الاول والحمد لله يعني الدواء فعلا فرق معايا جامد في خلال السنة دي.
طبعا كلكم بتقولوا ان دي دعايه. طبعا هي she knows nobody except me، فعشان كده هي بتقول يعني هذا الكلام. لكن anyhow actually this is what happens with our patient. They travel until we reach the proper diagnosis, and then when we reach the diagnosis we need to follow up them. And actually this is one of our patients that came with shortness of breath and syncope with function class 3, edema, floor limbs, parasternal heave, loud second sound, engorged neck veins, and arthralgia. This was in 2015. Her lab, CBC, liver function, renal, and serology also was negative. And I used to send her to rheumatologist in order to exclude any collagen vascular. And the comment came to me that she has a mixed connective tissue disease. It was Dalia, Dr. Dalia. Her X-ray was fine. And this is data for the echo. And again, she has a normal left ventricular function, left side, but she has some data about the right ventricular pressure, which was 80. We didn't get a comment on the tricuspid valve regurg velocity. Again, one of the common problems that we face when we have an echo. However, this directed our attention that this patient need to be investigated and be prepared for further discriminative diagnosis. On pulmonary function test, it was fine. Then we have the CT, and you can see the dilated pulmonary artery, and it was clear. Then we have the 6-minute walk test, and at that time, she can get 346 meters. The angiogram, the VQ scan was normal. Right heart cath revealed. Right atrial pressure was 13. The pulmonary artery was 51. So the pulmonary capillary pressure was 13. So it was clear that we have a precapillary pulmonary hypertension. We didn't do the vasoreactivity. She is a mixed connective tissue disease, and the diagnosis actually was clear. So we started the treatment, and we gave her the diuretics, Bosentan. I usually have to talk about diuretics because many people talk about the targeted drug and forget the diuretics, which I believe is one of the very important treatment in the general treatment that we give for these patients. And we have to target the patient who is being dry in order to bring them to be asymptomatic. So we give her the diuretics, Bosentan, started sildenafil, plaquenil, Solipred for it's a prednisolone, and omeprazole to protect her stomach, and for follow-up after 2 weeks. After 2 weeks, followed her up. Bosentan was stopped for 2 weeks. When liver function test become fine, then I restarted again. This is my approach when I face liver dysfunction with ERA. And after 1 month of restarting the drug, I found the liver functions are getting worse, so we have to stop it. And ambrisentan, actually 10 milligram per day was added instead of Bosentan. Patient went well for follow-up in 3 months. And the liver function monthly was fine. 3 months later, she came with, this is how we calculate our patient in follow-up. So she was in the green area. I didn't do right heart cath at that time. Then 5 years after, from the start of symptoms, Ruwaida experienced increased dyspnea with occasional syncopes, and she was not happy with her quality of life. She came in function class 3. Echo revealed right atrium 19, no pericardial effusion. Her propNP was high. We convinced her to do the right heart cath, and in the right heart cath, the right atrial pressure was 14. This is a number I would look for, and also although the SVO2 was 67. Then when we risk assessed her, there were some data denoting that she is an intermediate, and actually the repeated syncope was the only high risk criteria. So Selexibag, actually, this is what I have, and I started with her, and we added Selexibag in the dose of 200 milligram twice daily, and we increased the dose after 1 week to 400 with better acceptance. Increasing the dose above this was not tolerated by her. She could understand and tolerate the side effects she got from the drug, and she is doing well now for almost a year. Planning her for right heart cath maybe the next month. Actually, this is a straightforward story for how we proceeded with this patient. And actually, if I have the IV, I don't know if this would be the proper treatment for such patient, but I didn't have it at that time. Anyhow, she's doing well now, and this is the follow-up. I only have the propNP in the intermediate zone. However, she is doing well with the other criteria. So this is just an introduction to the Selexibag and its role, which I think many studies are now tackling, and there were some discussion about the Triton yesterday. However, in the Greyhound study, Uptravi or Selexibag have been studied, and actually the study design included, it was a study designed with screening for 28 days, and the Uptravi 200 to up to 116 milligram was compared to placebo. Placebo was twice drugs, 2 drugs in the same time. So we give the 3 drugs again is the 2 drugs, and we can see the endpoints. The primary endpoints was disease progression, hospitalization. So it was a morbidity-driven endpoints. I will go through. Most patients were on background therapy. However, nearly half of them were on in function class 2, and a range of disease subgroups have been included. So idiopathic and associated and hereditary types were included. 40% reduction, risk reduction actually was achieved when Uptravi was added to the double combination, the same like we do with this patient. Again, 37% reduction, risk reduction in the triple combination when it is used and compared with morbidity, mortality compared with the other two drugs. 65 reduction also when we look at the functional class. And this is the 5-year survival benefit that we get, it is 75%. So we could move the patient and as we did with this female, and we could bring her to a better class of classification. So management of the patient and the starting the dose, actually in our experience with, we have maybe 12 patients and my colleagues have other number of patients. We could not, patient could not tolerate more than 400 twice, and we are looking for this actually dose, and we are looking how we can titrate the drug. We titrate the drug up till we have complication and the patient can tolerate. So we need to explain for each patient that we have some benefits against the side effects. And when we talk about this, the patient can tolerate it. And this is actually what we did with the patient, with Ruwaida. The side effects include headache, diarrhea, nausea, and the headache actually is the most important. Diarrhea sometimes with less frequency, although nausea and jaw pain, as she described, was very annoying for her. That's actually the cause that we stop the titration of the drug. So if we explain for her before we go forward with the drugs, actually she can accept and she can do better because she has much feeling and much more quality of life. So this is my question for my colleagues, actually, when I talk about this. And as the diagnostic algorithm tell us, we need to be prepared for the next steps. And actually, when we have the patient, we titrate the treatment. So this is a patient who is already on treatment and he has started to be in the intermediate risk. So triple sequential combination is our next step. If the patient is not doing well, and this is a problem with this patient, the next time when I have deterioration, I have to be prepared with the IV therapy. And after that, all of these are going to be a bridge toward lung transplantation. And that's why we are going to talk about lung transplantation, and we are in a hurry in order to have our lung transplantation program in order to achieve, like Dr. Abdullah and his colleagues has showed to us, how the lung transplantation can save lives and can bring patients back to actual steady life. Thank you very much.
Thank you so much, Professor Ayman. Marvelous presentation. I have one comment, and so the first comment is regarding the patient orientation. This was great. Your patient knows everything about her disease, how the disease is chronic, and how she will need a chronic medication for life, and the expectations that she might have some disease progression that would lead to more symptoms, and how to ask for advice at this step. So this was a great message to be addressed. My question is about the triple combination therapy, and we have now the oral prostacyclin analog, the selexipag. So do we have a disease phenotype that we might or we may need to give the triple combination either from the start or rapidly up titrating the drugs. Despite this patient might be in intermediate class of risk stratification, you, from your experience, you may know that this patient will need a triple combination therapy or a rapid upgrade of the triple combination therapy.
Well, I'm not going to respond by my experience actually, because there are some trials which is very important. You mean the upfront 3 drugs? Upfront, you mean why we didn't start with the 3 drugs from the start? There is a famous study which is Triton, and actually the Triton came after the endpoints did not come positive. They give 2 drugs when the 3 drugs, and they do it sequential later on, and they found no difference between the 2 groups. So up till now, although there were some improvement in the pulmonary vascular resistance as far as I remember, but they are looking for more time in order to give us in guidelines that we can use upfront 3 drugs, including the oral prostanoid. But the IV prostanoid have been proved to be very effective if the patient is in the high risk group. So up till now, it is not supposed to give initial triple combination, including the oral prostanoid. However, it is in the sequential, and you can get the patient in the early, intermediate. This is, I think, the preferable time, and actually this is a matter of debate when to use the Selexibag. Don't let the patient succumb in the red zone before you give the drug. So I think it's not a matter of phenotype, rather risk stratifying the patient and interfering in the proper timing.
Thank you so much. I think for the sake of the time, I just want to thank the organizing committee for their kind invitation. It's really an honor to be here. So this is the last session. Hopefully, we're going to talk about interesting cases. I want to introduce Dr. Ahmed Aziz, who's an interventional cardiologist. We just saw a fascinating case that he presented, and he's going to tell us about the experience of BPA in Egypt, and looking forward to hear from him.
السلام عليكم جميعا مرة تانية. أرجو إن أنا أكون ضيف خفيف، إحنا محاضرتين ورا بعض، يعني أرجو إن شاء الله تكون محاضرة قصيرة هنتكلم فيها بس على our experience here in Egypt in PPA. أنا حابب بس حابب ان انا ابدا بس ان انا اقول الفكره دي جت منين. هي الفكره انا لسه كنت بتكلم مع دكتور فايز في ساعه الغداء. انا ما كنتش انترستد قبل كده نهائي بالبلمونري هايبرتنشن خالص. اللي جرى رجلي للبلمونري هايبرتنشن كان دكتور يوسف امين ودكتور ريم القرشي، اساتذه الصدر في القصر العيني. في البدايه على احنا نعمل حالات الايكو ونبص على كرايتيريا معينه ونعمل استادي مع بعض. ده كانت البدايه. وبعد كده طيب احنا عندنا دلوقتي عيانين مش عارفين نعمل لهم ايه، عيانين السيتاف. احنا يمكن الدكتوره ريم كانت قالت في الريجستري امبارح احنا عندنا لحد دلوقتي تقريبا 64 عيان سيتاف في الاور ريجستري اللي هي ما بين القصر العيني وما بين معهد القلب. فكان من ضمنهم عيانين مش لاقيين لهم حل، والعيانين دول they are suffering so much ومش عارفين نعمل لهم اي حاجه خالص. واحنا للاسف احنا الاندارتريكتومي بروجرام ما كانش فيه عندنا بروجرام اندارتريكتومي قوي بدا بستبس واضحه، فما كانش فيه حاجه غير الميديكال تريتمنت بس. فدي كانت بدايه الفكره، كانت في 2017 او في اخر 2016. ده معهد القلب القومي، ده البيت الثاني بتاعي اللي اتعلمت فيه من وانا لسه طفل بالبامبرز لحد دلوقتي ما بقى شعري ابيض. اوكي. طيب احنا في 2017 وير وي. ده زي ما حضراتكم عارفين ده الكومبتنس كيرف. احنا عندنا 5 levels of competence: unconscious and incompetent, وconscious incompetent, وconscious competent, وunconscious competence، و competent competent with continuous consciousness. احنا كنا فين؟ احنا كنا طبعا فوق خالص، احنا unconscious and competent، احنا ما كناش دارين باي حاجه ولا عارفين اي حاجه ومش عارفين نمشي ازاي في الموضوع ده. وزي ما كنت بتكلم مع الدكتور فايز I didn't have a proctor. ولو حضراتكم حد فيكم حاول يدور على البي بي اي سواء في الليتريتشر او على اي وسيله من الوسائل العلميه علشان يدور على ازاي ستيب باي ستيب بيتعمل بي بي اي، very difficult. كل الحاجات اللي مكتوبه حاجات اكاديميك فقط. فاحتاجنا ان احنا نقرا بقى من اول وجديد، نقرا الاناتومي تاني، ونقرا الفاسكولار اناتومي بتاع البلمونري تاني، لحد ما اخترنا الحاله الاولانيه في 2017. Our first case done on 2 sessions. والحقيقه ما كانتش يعني ما كانتش مرضيه قوي بالنسبه لي، يعني كنت شويه محبط شويه بعد الحاله. Just symptomatic improvement but no significant hemodynamic improvement. Patient kept on dual combination therapy زي ما كانت قبل البروسيدور، والعيانه دي died after 2 years. الحمد لله انا مش من السيتا فجالها acute MI يعني، بس يعني she died after 2 years of myocardial infarction. Okay, but the second case I consider it the gift of God to this project. She was the main reason ان احنا نكمل في البروجكت ده. دي كانت شابه صغيره يعني I think at 24 years old. والبيشنت دي رجعت بعد ما عملنا لها البي بي اي رجعت كومبليتلي نورمال، وقفت كل السبيسيفيك تريتمنت ومشيت على اورال انتي كواجيليشن. والعيانه دي حملت 3 مرات بعد كده، يعني احنا لسه لحد دلوقتي بنتابعها، يعني اسمها يسريه. فاتحولت حياتها تماما. هي دي اللي يمكن ادتنا امل ان احنا نكمل في البروجرام ده، ان احنا ممكن نفيد عيانين اخرين بنفس الطريقه. ودي كانت حقيقه كانت very interesting كمان، يعني حتى كانت من الحالات اللي انا دورت عليها في الليتريتشر. if we see here we have this is the lateral view. احنا كنا في البدايه كنا بناخد دايما البي اي فيو ولاترال فيو في كل السلكتيف انجيجمنت. انا اخترت بس الحته الانترستنج منها بس. احنا عندنا توتال اوكلوجن هنا في one of the left lobar arteries. هو اللي هنا ده، هو هنا توتالي اوكلودد. هيبقى باين اكتر هنا كمان انه واخد ريتروجريد فيلنج زي الكورونريز بالظبط، واخد ريتروجريد فيلنج من الابر برانش، من البرانش اللي قبله على طول. اوكي، زي الكورونريز بالظبط. we managed to open this artery. واحنا هنا بقى هنا النقطه الاساسيه. احنا البي بي اي الغرض منها مش ان احنا نرجع الارتري لحجمه الطبيعي ولا نخليه زي الارتري اللي جنبه بنفس الدايمنشن بنفس الدايمتر بتاعه. يعني لو كان هو استينوتيك او كومبليتلي اوكلودد مش بنرجعه 1 to 1، احنا ممكن نرجعه اوكي. برضه مش شغال هنا. اوكي، ده بعد ما الارتري اتفتح، يعني ده one of the arteries في الليفت سايد. احنا دي اتعمل ليها اكتر من سيجمنت في نفس في السيشن، وفي الاخر وصلنا ان احنا كومبليت ريفاسكولاريزيشن للليفت سايد، الليفت سايد بالمونري ارتري. العينه دي كانت المفروض ان هي بلان فور انذر سيشن علشان نعمل لها، كان في عندنا other 2 or 3 segments in the right pulmonary artery. بس الحقيقه لما جينا شفنا الهيموداينامكس بتاعتها والفانكشن كلاس، لا احنا لقينا ان احنا في ماركت امبروفمنت على مستوى الفانكشن كلاس، فما كملناش العينه دي، ما كملناش البي بي اي. اوكي، ودي كانت اول عينه، وزي ما قلت لحضراتكم العينه دي شي ديد فيري ويل لحد دلوقتي، ما احتاجتش اي سبيسيفيك تريتمنت لحد لحظتنا اللي احنا فيها. مش ده كان الرول في كل العيانين اللي هنشوف دلوقتي، بس يعني دي كانت زي ما قلت لحضراتكم دي she was the gift of God for this project. اوكي، طيب احنا وصلنا ل 2022، احنا وصلنا لفين؟ احنا عندنا في الريجستري زي ما قلت لحضراتكم عندنا 63 عيان، احنا بلاند اتعمل منهم 33 حاله من ال 63 دول اتعملوا بلاند فور بي بي اي، ولقينا بقى بعض الملاحظات. اول حاجه احنا 13 منهم بس اللي عملنا لهم بي بي اي، 7 لقيناهم نورمال pulmonary angiography نورمال، although ان هو بالكرايتيريا we have significant mismatch في الفي سكان في multiple areas although، واحنا يعني مش عارفين ده بقى فالسس في الفي سكان ولا لا. في اني واي احنا العيانين دول اتعاملوا على ان هم عيانين ايديوباثيك. في عيانين يعني التقسيمه دي مش دي اللي موجوده في البي بي اي، يعني احنا عملنا التقسيمه دي من عندنا، ما نعرفش هي تبقى صح ولا لا بعد كده، بس احنا في عيانين قلنا في منهم 10 عيانين، يعني احنا هم 17 عيان توتال ما لقيناش فيهم حاجه على مستوى البلمونري فيزيتس. احنا بنحقن سيلكتيف، احنا التكنيك اللي احنا بنعمله ان احنا بالاول بنحقن رايت وليفت نون سيلكتيف ببيك تيل، وبعد كده بنخش سيلكتيف على كل سيجمنت وكل ارتيريال سيجمنت لوحده نصوره لوحده. فما لقيناش في ال 17 عيان دول ولا ليجن واحد. اوكي، ولكن ليه فرقناهم الاثنين عن بعض؟ لان دول لقينا فيهم حاجه شويه غريبه، ان البلمونري ارتري بريشر، البلمونري ارتري دايمتر فيهم اكبر من المعتاد. يعني هوري حضراتكم اكزامبل منهم دلوقتي واحنا في البرزنتيشن. فدول اعتبرنا ان هم قدامهم some sort of resistance ممكن تكون على مستوى الكابيلاريز، هي اللي مديه المس ماتش وهي اللي مكبره البلمونري ارتري دايمتر بالمنظر ده. في عندنا ثلاثه بيشنتس لقينا فيهم سمول فيزل ديزيز فيري سمول سيجمنتس، ما تفسرش الاليفيشن ماركت اليفيشن في البلمونري ارتري بريشر، وكمان نوت اكسسبل باي بالون دايليتيشن. طيب من ال 13 دول السيشنز احنا عملنا تقريبا 35 سيشن، الافريج 2.6 سيشنز بير بيشنت. الكومبليكيشنز no intra procedure complications till now، واحنا لحد دلوقتي احنا we were super selective في العيانين، يعني برضو ده مش شطاره مننا او مش competence مننا، ولكن احنا كنا بنختار العيانين شويه with super selection لان ده بروجرام لسه كان في بدايته، فما كناش عايزين نتعرض لشوك بميجر كومبليكيشن للبيشنتس دول. الفيلير اوف intended revascularization we failed in 2 patients. احنا المقصود ان احنا كنا عايزين نوسع 6 segments مثلا. we would not we didn't dilate 2 or 3 segments منهم. ده المقصود ب failed intended revascularization. اوكي، يعني عملنا جزء وما قدرناش نعمل الجزء الثاني، وهوري حضراتكم اكزامبل منه برضه. المورتاليتي 2 patients died 2 and 3 years after procedure، يعني not related to the procedure but بعد في الفولو اب بعد سنتين، وواحده ماتت بعد سنتين وواحده ماتت بعد 3 سنين، سنتين اللي هي كانت اول عينه خلاص عملناها، والثانيه ماتت بعد 3 سنين. الفولو اب 3 patients stopped specific treatment completely who just kept on anticoagulation. 7 patients kept on monotherapy only, and 2 patients were kept on dual combination therapy. One patient upgraded to triple combination therapy. These are examples of our work. هبدأ بالعيان اللي احنا failed فيها. البيشنت دي عندها total occlusion للانفيريور left branch. inferior left branch المفروض ان هو مقفول من اول هنا، من الحته دي. المفروض في هنا ارتري كبير جدا جدا هنا في المكان ده. we failed to access الحقيقه. يعني احنا حاولنا باكتر من واير، وما كانش فيه في الوقت دوت كمان معانا ايفس يقدر يساعدنا عشان نقدر نعرف المكان اللي هنخش منه، الاسطمبه اللي هنخش منها عشان نقدر نفتحه. فدي واحده من العيانين اللي failed to complete the revascularization for them. عندنا بقى different حاجات. يعني انا اخترت لحضراتكم بس يعني شويه حاجات غريبه شويه. عندنا لو حضراتكم بصيتوا هنا، انا هوقفها. ده المين برانش وطالع منه 2 برانشز. عند بدايه البرانشز 2 برانشز الاثنين دول في significant lesions. في significant lesions. هنا في هنا lesion tight lesion وفي هنا tight lesion nearly subtotal lesions. In these patients we dilated both lesions sequentially, and if you will see the flow itself. Sorry. The flow itself improved. الليجن ما رجعش طبيعي، وده اللي احنا بنتكلم عليه. It improved but not normalized. Okay. We have a simple significant lesion, simple but significant lesion. يعني هشوف هنا في عندنا tight lesion هنا, but simple straightforward lesion. This one. اللي هيشوف هنا هيقول طب ما الارتري فاسكولارايزد زي ما انتم شايفين، ما الفلو ماشي في الارتري لحد تحت. لما حضرتك هتشوفوا بعد ما يتعمل له دايلاتيشن هنشوف الفرق بقى عامل ازاي. ده اتعمل له دايلاتيشن برضو not optimized dilatation. نشوف الفرق في الفلو. شايفين حضراتكم الفلو هنا عامل ازاي؟ فرق كبير جدا ما بين قبل مع ان الارتري نفسه ما رجعش للسايز بتاعه الطبيعي. يعني الارتري ده with 3O. Okay, just we dissected the lesion only, and بس الفرق على مستوى الفلو فرق marvelous. Okay, ده اللي انا كنت بقول لحضراتكم عليه الاكزامبل. يعني شايفين هنا البلمونري ارتري دايمتر عامل ازاي؟ tortuous dilated. ده العيانين اللي احنا قلنا عليهم ان هم احتمال ان هم يكون دول عندهم الباثولوجي على مستوى البريفرال سيركيليشن، على مستوى الكابيلاري سيركيليشن، علشان كده حطيناهم في انتيتي لوحدهم. الكلام ده ساينتفكلي صح ولا لا؟ we don't know, we just assume. Okay, so our competency curve became better, but still we need more experience, more cases. We have some patients in the row. كان عندنا مشكله في الاويرنس في الاول، ان احنا اصلا ما كانش في حد عارف ان في ممكن يكون للعيانين دول حل. دلوقتي بدا يبقى في ريفيرال اكتر للعيانين. الريت اوف بيشنتس احنا تقريبا دكتوره فاطمه بقينا بنعمل في الشهر دلوقتي تقريبا حوالي 4 عيانين مثلا، تقريبا اكتر تقريبا. يعني الفلو بيزيد باستمرار. we are expecting more and more and we hope more and more for this patient. دي الصوره اللي انا بعتز بيها جدا، اللي هي دي اول حاله احنا عملناها في الاول خالص. للاسف بقيه التيم ده مش باقي منه غيري دلوقتي، غيري انا والدكتوره ريم والدكتور يوسف، هم الاثنين ليهم الفضل، هم اللي في المقدمه الحقيقه. انضم لينا دلوقتي الرايزنج ستار دكتوره فاطمه محمد. ان شاء الله باذن الله ان شاء الله نتوقع ان احنا يكون عندنا more data, more experience and more solutions and better solutions for the patients. Thank you very much.
Thank you, Dr. Ahmed. Fascinating as usual. I have a small comment and a question for you. As we all know, SAPH is a bilateral disease. It affects the upper lobe, lower lobe, maybe affection at the same time. We have different kinds of lesion, complete obstruction, subtotal obstruction, web spans. My question is, do you have priority selection criteria before starting your intervention?
Yes, يعني لو انا هختار الليجنز اللي ستارت وذ كالاتي التوتال ليجن، ده اول حاجه هبدا بيها، بعديها السب توتال ليجن، بعد كده الويبس او الكونسنتريك ليجنز. دول بالترتيب. يعني واكتر سيجمنتس بقى كمان، لو احنا هنتكلم على السيجمنتس مش على الليجنز، اكتر سيجمنتس هبدا بيها واحب اختارها ان هي اللي بتبقى مور افكتيف اللور ليجنز على مستوى اللور
هيبقى ريجين ده اكتر، وده هيحسن الهيموداينامكس. تمام. والليجنز اللي بتبدا بيها اكتر توتال عشان مور ايزير كومبليكيشنز از less than.
لا هي مش easier، هي more difficult. هي more difficult.
The total obstruction is more difficult than webs or bands.
Yes, more difficult, but better results. يعني لما if we succeed, البيشنت get much benefit. انا كمان الحاله اللي انا قلت ان هي failed total revascularization اخترتها دي ليه؟ لان دي كانت في الانفيريور سيجمنت. واحنا كده انا اعتبرت ان انا ما عملتلهاش successful revascularization، لان احنا في big amount of lung tissue مش vascularized.
Your aim is not complete revascularization. Your aim is improving patient hemodynamics and symptoms.
Yes. Just a comment about the question about what guides which segments. The UC San Diego experience, they usually what guides the therapy in terms of BPA and which segments is VQ scan.
VQ scan, yes.
VQ scan is the critical thing that you use, and then we target. And usually, as you said, the right lung, right lower lobe.
More lower,
we start with that
mostly
more lung tissue and for physiology perspective. But very impressive that the complication rate is. I'm really impressed that there's no complication in those
I told you this is not يعني مش شطاره ولكن super selection actually، يعني هو اكتر super selection.
That's great, and for people just to know, the complication rate in BP is about 2%, and 2% of cases they develop perforation. It depends on which data you're looking at. The Japanese experience is different than the US experience. If you see the first paper that came out from the Boston Children's Group for the BPA experience, the mortality was so high and the complication rate was high. But
بس احنا استفدنا منهم. هو اكتر complications واللي كانت وقفت البروجرام بتاع البي بي اي في امريكا اول دي كان اول ناس عملوها تقريبا كانت في 2002 تقريبا، كانت الريبرفيوجن انجري. الريبرفيوجن انجري والبلمونري ديما بعد البروسيدور دي كانت اكتر كومبليكيشن واكتر فيتال كومبليكيشن. تم تدارك هذا بان يتعمل سيكوينشال ريفاسكولاريزيشن مش على وان سيشن. انما بقيه الكومبليكيشنز الثانيه يعني سواء يعني احنا حتى بنبقى متوقعينها ان ممكن يحصل بيرفوريشن، ممكن يحصل دايسكشن، ممكن يحصل اي حاجه متوقعينها، بس كلها ليها مانجمنت. بس حتى الان لحد دلوقتي الحمد لله لم يحدث معنا.
For the reperfusion injury, we usually focus on 2 segments every session, and if we reach 300 cc's of contrast, usually we stop. And there is also amount of radiation of milligrays that you certainly. And for contrast, we use half and half of saline and half of contrast with injections, which is different than the coronaries. The coronaries you give a full contrast rather than half and half saline and contrast.
During the procedure, لما نبدا البي بي اي بناخد هاف اند هاف، انما في البدايه لما بصور لان ده اللي انا هاخد عليه الديسيجن.
Correct.
فبقى عايز كلير شوت، فباخد 100%
Correct. That's the pulmonary angiogram that he's talking about is full contrast with the BPA.
Okay, we have a question here.
Actually, I have a comment. So as Dr. Ahmed said, so the whole idea from the BPA is to restore the flow. And this shouldn't be happen from the first session. So as you mentioned, you can do it gradually. Even you can discharge the patient and readmit the patient to do more sessions and to avoid the reperfusion injury. So my other comments regarding you had like 17 patients with
17
yeah,
normal.
with abnormal VQ, and when you did the selective angiogram, it was normal.
Yeah.
So sometimes the severe idiopathic pulmonary arterial hypertension can give you a similar picture of mismatch defects. It can cause peripheral stenosis from the severe pressure with tortuosity of the vessel itself. So this is why I believe, one of the reasons why you had abnormal VQ with normal angiogram. As we know, in the old days, angiogram was the gold standard to diagnose CTF and pulmonary embolism, by the way, the acute, even the acute. Yeah.
الدايلاما يا دكتور فايز بقى في العينين دول whether to give anticoagulation or no. This is CTF or no. CTF equals lifelong anticoagulation. So we will consider these patients as the CTF or just idiopathic, and we will stop the anticoagulation. This is a dilemma. We don't have an evidence with the pulmonary angiogram that we have a defect, a clear defect. علشان كده أنا عملت التقسيمه دي تقسيمه تخيليه من عندي اللي هي السسبكتد يكون في كابيلاري او سمول فيزل ديزيز، وان يكون ده عيان زي ما حضرتك قلت من السيفير فورم اوف ايديوباثيك بالمونري هايبرتنشن او فالسس من الفي كيو سكان، لان الديسيجن از ديفيكلت. انا هدي انتي كواجليشن فور لايف اور نو، فعشان كده حاولت اعمل التقسيمه دي. بس
اعتقد اللي هيحكمك هنا اذا كان العيان عنده ريسك فور يعني ري ثرومبوزس في هذا.
ما هي المشكله يا دكتور ايمن، حضرتك عارف ان العيانين دول موستلي العيانين السي تاف ما فيش كلير هيستوري ان جالهم ريكارنت بالمونري امبوليزم قبل كده. لو هو عنده هيستوري اوف ريكارنت بالمونري امبوليزم باي سيلف خلاص this is an indication، خصوصا لو كان non provoked this is an indication for lifelong anticoagulation. المشكله في العيانين اللي هم بيتعمل لهم ورك اب، هو جاي عادي يتشخص على انه عنده significant pulmonary hypertension، ان روتين ورك اب بنلاقي فيه ان ما فيش هيستوري قبل كده of recurrent pulmonary emboli، بنلاقي في الفي كيو سكان مس ماتش، فبيتشخص من هذا على انه هو جروب 4 خلاص من ده، يعني ده اللي بيشخصه. فدول بقى اعمل لهم ايه؟ اديهم انتي كواجليشن ولا ما اديهمش انتي كواجليشن؟
By the way, there is an entity called peripheral pulmonary artery stenosis. So it's a rare entity, but it can mimic the CTF in the VQ scan. So maybe this is the case in your patients, maybe.
دكتور احمد، sorry دكتور عادل، تفضل.
You know, just to make it simple for our audience, if you have a normal VQ scan and a low probability VQ scan, you can safely rule out CTF.
Yeah.
Now, if you have, I don't know about these patients, but if your VQ scan is also operator dependent, and it depends on the timing of giving the material, because remember, if you waited for 3-4 cycles, it may not be a good, or if you take the pictures earlier before the whole radioactive material distributed, is also a problem. So you have to go back and check also how it was done, because generally speaking, you can safely rule out CTF if you have a normal or low VQ scan, low probability VQ scan. Now, in severe idiopathic pulmonary arterial hypertension, you are not supposed to have a mismatch defect, or you do, but very small mismatch defect, not like the CTF changes. Because in that situation, in severe idiopathic, you have a globally hypoperfused periphery, but not mismatch.
Not mismatch.
Yes. However, sometimes, like what Faiz said, you have to, you know, remember the sometimes, and they give you this sense of some mismatch, small mismatch. Can safely rule out CTF. So I think the way your patient, I don't think this patient has a CTF. Now, I don't know about the VQ scan. Maybe
we selected with all high probability. انا قلت لحضرتك احنا بنعمل سوبر سelection. فما احنا ما بناخدش حتى العيان المشكوك فيه، احنا عيان موثوق في الدايجنوزس من الاول. وكنا كمان في بعض الاوقات كنا قبل البروسيدور، بس لما لقينا الريلايبيليتي على السي تي بي اي ما كانتش عاليه قوي، ما بقيناش بنعمله خالص.
Now, what about the 17? How were their VQ scans?
High probability, all high probability. 33 كل ال 33 كلهم كانوا high probability، كلهم كانوا high probability. بس زي ما حضرتك بتقول هو في جزء منهم برضو كان معمول في مكان not reliable، يعني not fully reliable. ولكن برضو كان في من ضمنهم كان معمولين في اماكن highly reliable، وبرضو لقينا فيهم الفايندنجز.
I'd like to confirm what Ahmed have said. Sometimes we have high intermediate to high probability of CTEPH with VQ scan. However, doing pulmonary angiography, we have almost a normal perfusion of the lung. So it might be a problem with the VQ scan here, but what Ahmed have said, we see it also in our center doing pulmonary angiography. However, we're doing pulmonary angiography using the side hole catheter and using the pump to have a global visualization of the pulmonary angiography rather than
this is what I do in the first non-selective with the injector, non-selective, the big tail and the injector for both right and left, then selective for the balloon. Yes.
Ahmed, just one more question. Do you do hemodynamic evaluation, IFR or FFR?
Of course, the hemodynamic before and after.
No, IFR and FFR. No. I mean, for the
no.
It's a good point to be to do a research in such.
I don't know if you have an answer for this. If you have an experience for this, you can tell me. I don't know whether it applies the same values in the coronaries applies.
There was a review article by the Japanese group. They used the cutoff of 0.8 resting FFR. So you could go with more balloon inflations if the point of the FFR resting was less than 0.8. But it's not supported by strong evidence. We use the cutoff of 0.80 like the coronary.
Yes,
we don't have that's why I'm asking. There is the cut point. What's the cut point? It should be the same or no?
No, what we're using is 0.80.
The same. FFR, not an IFR.
FFR.
Yeah. Okay.
By the way, thank you, Dr. Badr, hearing me about things. So this procedure actually has evolved, as you know, since years, has evolved dramatically. The other way, actually, they used to use a pressure-guided wire. So it's not unusual to see normal angiogram. However, I mean selective angiogram. However, when you use the pressure-guided wire, and you measure the pressure in the distal segmental pulmonary artery, it will be different from the proximal segmental artery. So that means there is a lesion that you cannot see by the angiogram. So it takes time for sure, but this is one of the modality to know that there is a lesion in the distal part. The pressure guided wire technique.
مين قال ان الكات بوينت هنا ما دي should be studied before؟ يعني هو زي ما الدكتور قال ان احنا استخدمنا لو هم استخدموا نفس الكات بوينت بتاعت الكورونرز مع اختلاف الدايمتر، مع اختلاف الوول كونتنت، مع اختلاف الفازو رياكتيفيتي. المفروض ده يعني دول انتيتي وده انتي تاني خالص. الكورونرز مختلفه تماما عن البلمونرز. علشان كده في الكورونرز بتحط ستنت، في البلمونري we don't put stents, just ballooning. فمين قال ان الكات بوينت دي هتبقى صح؟ ما يمكن تبقى اقل من كده، ممكن تبقى اكتر من كده. As far as I know, I didn't see any study to verify the cut point in the beginning, then to apply in the practice.
It is lacking actually, definitely. But and the interesting thing about the FFR also, it's different in inspiration than an
ازي حضراتكم؟ السلام عليكم. شرف لي اكون معاكم النهارده وشكرا على الدعوه الكريمه. انا عبد الرحمن، مدرس في قلب عين شمس وعضو في مجموعه الكونجينيتال. هقول كيس صغيره خالص على الكونجينيتال هارت ديزيز عشان انتيتي معينه كمان. We have a 15-year-old female patient born and living in Sharqiya. She was a student with no special habits of medical importance. The patient complained of shortness of breath of 3 weeks duration of gradual onset and progressive course. The condition started at the age of 10 years when the patient started to suffer from exertional dyspnea, NIA classification class 2 to 3. She sought medical advice and was diagnosed to have a defect in her heart. She was prescribed a medical treatment with no improvement. She thought another medical advice and she did an echo and she was diagnosed to have an atrial septal defect. Her old echocardiography showed a large secundum ASD measuring 24 millimeters, shunting from left to right with query deficient trims, maybe not fit for percutaneous closure. She had a dilated right ventricle with preserved systolic function, severe tricuspid regurgitation. Her right ventricular systolic pressure was 56, mild pulmonary regurgitation. Her main pulmonary artery pressure was 33 with no pericardial effusion. So we have a patient with non-invasive signs of pulmonary artery pressure elevation. So she underwent an invasive measurement of pulmonary vascular resistance. We have a patient with pulmonary hypertension, mostly type 2, the one was associated with prevalent systemic to pulmonary shunts. We still need the right heart catheterization to decide whether it's correctable or non-correctable. She underwent right heart catheterization and transesophageal echo and was referred for surgical closure after deemed fit. So again, we have a young female with ASD, signs of volume overload and pulmonary hypertension. What do you think about the old decision? Do we need any more workup? Anything was strange regarding this scenario? هو يعني بصراحة في اللحظة ديت كانت الحاجة الوحيدة الغريبة في الحالة ديت الايدج. البيشنت ديت كانت عندها 10 سنين ويوجوالي الاي اس دي to be complicated by pulmonary hypertension بيبقى على 30 decades. She is younger than this. كان ساعتها ممكن ندي medical treatment. Actually يعني ما كانش في evidence بصراحة لكده. Exercise testing برضو مفيش أي available data to suggest exercise testing benefit in such age.
هو البلمونري فاسكولار ريزيستنس كانت قليله في الرايت هارت كيس دكتور عبد الرحمن؟
ما عندناش اي معلومه عن ديت. دي كانت ده الاولد هيستوري بتاعها، احنا ما شفناهاش في المرحله ديت. بس هي لما عملت القسطره كانت ريفيرد فور سيرجري، فوي اسومد ان هي البالمونري فاسكولار ريزيستنس بتاعتها كانت within ranges.
We should know a data about the pulmonary vascular resistance before.
Yes. صح. So we have evidence of RV volume overload and we assumed that the pulmonary vascular resistance was less than 3. So the patient underwent surgical closure. Marked improvement in symptoms. She did follow-up echo after 1 month with intact interatrial septum with no residual flow across. Still have dilated RV with normal functions, severe tricuspid regurgitation. Right ventricular systolic pressure was 60 millimeter mercury with no pericardial effusion. They thought it was over. So what do you think? دي أول مشكلة وأكبر مشكلة في الايدج جروب ده، في البلمونري هايبرتنشن، في الكونجنتال هارت ديزيز especially in those with correctable shunt lesions. After correction, they are lost to their follow-up. 4 years later, the patient started to complain again of shortness of breath, of progressive course and the gradual onset. There was no syncope. She had mild bilateral lower limb edema below. Her echocardiography. This is an apical 4-chamber view showing a dilated right atrium. We can يعني احنا بنحكم هنا على dilated RV simply كده ان ال RV basal diameter بيبقى اكبر من ال LV basal diameter وال RV apex started to share في ال apex مكان ال LV. Parasternal short axis view ده الكلاسيك دي shaped septum. The echo showed intact interatrial septum with no residual flow, dilated right ventricle with impaired systolic function. Her TAPSE was 16 millimeters. S prime was 9. Fractional area change was 30%. Severe tricuspid regurgitation, RVSB 65. Mild pulmonary regurgitation. Her mean pulmonary artery pressure was 43, and her right atrial area 20 centimeters square with mild pericardial effusion. So we decided to go for right heart catheterization again for this patient, revealing mean pulmonary artery pressure of 40, right atrial pressure was 12 millimeter mercury, LV end diastolic pressure 8, pulmonary vascular resistance 8, cardiac index 2.8, and systemic venous saturation 65%. So if you want to risk stratify this patient, she had signs of heart failure with rapid progression of her symptoms, which lie in the high risk category, no syncope, functional classification of functional class 3, 6-minute walk test. Actually, we don't have reference values, but we can simply use it for comparison and for follow-up, but we don't have a cutoff values. Her 6-minute walk test was around 180 meters. We didn't do cardiopulmonary exercise testing. Her right atrial area was in the intermediate risk group, and her hemodynamics also lie in the same category. So, what do you think what happened? Was it a miscalculations of her peripheral pulmonary vascular resistance? Was it above or equal to 5? Or the new entity, which is post-operative pulmonary hypertension? Type 4. Pulmonary arterial hypertension after defect correction, which is a congenital heart disease is repaired, but pulmonary arterial hypertension either persists immediately or after correction or recurs, develops months or years after correction in the absence of significant post-operative hemodynamic lesions. هو ده الوضع بتاعنا exactly يعني. We decided to go for medications. والميديكيشنز بقى هي المشكله الكبرى في الكونجنتال هارت ديزيز او الكوميونتي ده كله. We started a small dose diuretics, phosphodiesterase inhibitors started والسيلدينافيل 20 ملغ twice per day. السيلدينافيل في الكونجنتال هارت ديزيز كان في ريبورتس كتيره قوي بتقول مع الهاي دوزز بيبقى في incidence of mortality. So we usually use small doses. Usually for infants and small children, we use 1 milli per kg. We didn't use any larger doses. After 1 month, patient is still in intermediate risk group, so we started the combination therapy على طول. احنا مختلفين شويه عن الادلت patients ان احنا مش بنبدا الكومباينيشن ثيرابي على طول. هو still lacking evidence بقوه، ومعظم الترايلز بتاعه الكومباينيشن ثيرابي كانت الايدج جروبس بتاعتهم من 18 سنه فيما فوق، ما كانوش قوي واخدين الكونجنتال ايدج جروب. معظم الريجستريز بتاعه البالمونري هايبرتنشن في الكونجنتال ايدج جروب كانت نسبه العيانين اللي ماشيين على كومباينيشن ثيرابي فروم ذا ستارت فيري لو، اقل من 20%. لكن اللي احنا بنحاول نعمله ان احنا we don't wait too long to initiate combination therapy. احنا بنبدا الاول بسنجل ثيرابي، لكن بكومباينيشن ثيرابي يعني within 1 month لو البيشنت didn't show any improvement وبروسيد على طول للكومباينيشن ثيرابي. So we start combination therapy with addition of bosentan half tablet twice. هو القرص مش سكورد، بس احنا بنستخدم ده في الكونجنتال ايج جروب. البيشنت moved to low risk group with absence of signs of right-sided heart failure, with slow progression of her symptoms, still no syncope, functional classification became 2. The 6-minute walk test rises to around 230 meters. The right atrial area became 17 centimeters square with no pericardial effusion. العينة لحد دلوقتي كويس، لحد دلوقتي بتيجي فولو اب كويس. السؤال بقى what is next لو البيشنت دي became symptomatic again or deteriorated or moved to the intermediate risk group or the high risk group. If we decided to go for sequential therapy or add another medication, we thought about macitentan and ambrisentan. Ambrisentan no specific doses خالص لحد دلوقتي. احنا لسه الايفيدنس lacking جدا regarding الموربيديتي والمورتاليتي. الماسيتنتان لحد دلوقتي برضو ما فيش اي موربيديتي او مورتاليتي بينفيت regarding ليه. السيليكسيباج الوحيد اللي بدا يبقى فيه سمول ترايلز دلوقتي بتسجست ان هو maybe beneficial وبي result in improved في الفانكشنال كاباسيتي للبيشنتس especially الافتر كوركشن especially البيشنتس with simple shunt lesions after correction اللي هم الجروب 4 اللي هم البالمونري artery hypertension after correction. Can we think also about RV decompression strategies? usually يعني في الكيس ديت احنا محتاجين عشان نعمل RV decompression strategies اللي هم هيبقى اشهرهم في حاله زي ديت الاتريال سيبتوستومي. محتاجين يبقى فيه هيمودايناميك كومبرومايز اكتر من كده persistent low blood pressure او severely symptomatic patients وبيبقى done يعني in a very يعني special circumstances كده ان احنا ممكن نفكر في RV decompression strategies. الميسنج في العيانه ديت او الحاجه المهمه قوي فيها ان هي العيانه ديت هل هي في الجروب 4 ده اللي هو البيشنت ديفلوب بالمونري ارتري هايبرتنشن البوست اوبراتيف ما كانش في حاجه ممكن تتعمل لها من الاول ولا هو من الاول خالص العيانه ديت كانت ميس دايجنوزد وريفيرد فور سيرجري اند شي واز نوت انديكيتد.
بالتالي as you mentioned from the start ASD at the age of 10 years with measurements of 24 millimeter يعني doesn't cause much progression of pulmonary hypertension. احنا عشان نشوف ال ASD دول بيبقوا يعني في الفورث والفيفث decades اللي هم بيبقوا في عندهم severe elevation of pulmonary hypertension. So I believe the patient had a pulmonary hypertension from the start. يعني هو very young صراحة بس she had a pulmonary maybe a pulmonary arterial hypertension from the start and the ASD is an incidental finding.
بالظبط كده واحنا ده فكرنا لحد هذه اللحظة ان هو it is not that simple يعني هو مش العينه مش البساطه ان هي you have to think about a patient. The patient 10 years old عندها defect ASD اوكي ما كانش معاه اي another anomalies ما كانش معاه anomalous venous drainage ما كانش معاه اي حاجه to suggest ان البالمونري artery pressure يبقى elevated كده في such age group. هل البيشنت كانت البالمونري فاسكولار ريزيستنس بتاعتها اكتر من 5 والكيس في الحاله ديت ان انت you have to start targeted medication and reassess the pulmonary vascular resistance and if it fall below 5 you can proceed for surgical closure or percutaneous closure. Another option if it had pulmonary vascular resistance more than 5 you can ask the surgeon to do fenestrated closure. He can close the ASD but keeping small fenestrations as a ventilation for the RV. بس يعني الكيس ما كانوش هم ما فكروش فيها كده خالص. هي
you mentioned you ruled out other congenital heart disease.
Sorry, أنا آسف.
You mentioned you ruled out other congenital anomalies.
Yes.
Okay. What modality of imaging was used for?
Echo and the CT. We did a CT to exclude the anomalous venous drainage. We did a transesophageal echo and we did a 3D echo. Just الحاجه الثانيه برضو المهمه قوي وهي اهم حاجه في الكيس ديت الانتيتي بتاع البوست اوبراتيف بالمونري هايبرتنشن لان معظم البيشنتس دولت هو احنا مشكلتنا الكبيره في الكونجنتال ايدج جروب الليت بريزنتيشن والفولو اب والميديكال تريتمنت كايفيدنس بيزد بقى. المشكله ان البيشنت كمان بعد الكوركشن سبيشالي الكوركتد البيشنتس اللي مش كوركتد سهل ان انت تو كيب ذيم فولو اب انت ما فيش حاجه اتصلحت لكن البيشنت اللي عمل سيرجيكال كلوجر او بيركوتينيوس كلوجر he thought ان it is over خلاص انا كان عندي ديفكت وقفلته. لكن البيشنتس دولت especially البيشنتس اللي هم كان عندهم سبب سهل للبالمونري هايبرتنشن زي الاي اس دي او الفي اس دي دولت اللي they need follow up. واحنا عملنا ريجستري في عين شمس على الكونجنتال انتيتي دولت. الجروب ده احنا كنا في الاول من 4-5 سنين ما كناش بنشوف الجروب ده خالص. ما كناش بنشوفه عشان هو فعلا بيبقى ما بيجيش الفولو اب. احنا بنعمل عاده follow up echo 1 month 6 months later and that's it. البيشنتس دولت لما بدأنا نعمل longer periods of follow up we started to cover الانتيتي ديت وبدأنا نشوف الانتيتي بتاع البالمونري arterial hypertension after correction اكتر بكتير جدا جدا. عشان كده هو ده اللي بدأ يعمل لنا المشكله الجديده بقى في الميديكال تريتمنت بتاعتنا وفي الفانكشنال اسسمنت كمان. ال 6 minute walk test اللي هو المفترض اسهل حاجه تو اسس البيشنت فانكشنال احنا ما بقيناش عارفين ما عندناش ريفرنس كارد فاليوز ليه. صعب جدا في الايدج جروب ده ما عندناش ريفرنس ليه خالص. ستيل الميديكال تريتمنت لاكينج ايفيدنس. الحاجه الوحيده لحد دلوقتي اللي عندها سترونج ايفيدنت بالنسبه لنا البوزنتان سبيشالي في الايزنمنجر بيشنتس. الباقيين كلهم لاكينج اوف ايفيدنس. السلدينافيل وي كودنت جيف هاير دوزز لانه في incidence of mortality وسيفير hypotension up to mortality مع الهاير doses. الريسنت ميديكيشنز اللي هم could be added as a triple therapy or sequential therapy as الماسيتنتان والسيليكسيباك they are lacking evidence regarding the mortality or morbidity benefit. ال RV decompression strategies يعني very difficult و very risky بصراحة، احنا مش بنلجأ لهم خالص يعني. احنا عملنا ريجستري بتاعتنا كانت في سنتين وكان عندنا 150 cases، كان around 50 cases منهم بوست اوبراتيف، وبوست اوبراتيف افتر ذيس سمبل ليجنز. هو الغريب ان هم سمبل ليجنز، ان هم ASD وفي اس دي وبي دي اي، المفروض فيري سمبل ليجنز والمفروض تو بي diagnosed early كمان.
I'm curious. I'm curious to know from our expertise, how common do you see this, Prof. Prof. Abdullah? I mean, the problem is that it is, retrospective now. Not that but this is a situation that we need.
Allow me.
Yeah, go ahead.
Thank you so much for your great presentation and great case. I think there are three things here we have to discuss. One is the fact that we discussed yesterday with Professor Ayman that, the registry they presented yesterday, the highest number was idiopathic and followed by connective tissue disease here in Egypt. But I was wondering what happened because in Saudi Arabia, it was second group was congenital heart disease associated with hypertension. And the discussion yesterday was, I think these patients are either underdiagnosed or the groups who have them were not included in the registry. So that's to prove the point that these actually, I think there's still a medical problem in our countries. I think the point number two, regardless what happened to this patient or what kind of problem, whether she had the pre-existing pulmonary hypertension and then it was fixed, or the PVR was not correctly measured and it was fixed again, I mean the corrected. Now she is a PAH patient. Yes. So you treat her accordingly. That is including IV prostacyclin if it's ever available. So if this patient progressed, this is a PAH patient, you just treat her accordingly. Down the road, maybe years from now, she might need a lung transplantation. So you never know. So whatever the scenario that happened in the past, it doesn't matter now because she is a PAH who is progressing now. And I think, yes, in this age group, which I'm not really very deep in literature, pediatric literature, but I think she's 15 and above. So I think as of now, you treat her like an adult patient and you give her a combination therapy, whatever available in your situation. Of course, Selexibag, again, was not studied, but maybe there is some data coming. You can always start with this because it's easy. She's now on Bosentan and Sildenafil. Yeah, yes. This is the third option will be Selexibag, and you have no other option, of course. Oh. If the prostacyclin ever available, then this should be, your next step, and then of course the lung transplantation.
We have a question for a comment from.
Ayla, it's about 10 months. Earlier, starting with pulmonary hypertension. And now our colleague, pediatric cardiologist, doing echo and starting even enlarging of right ventricle, I think, and starting increasing pulmonary hypertension again. And there's an evidence of BDA. So what's the role of surgery of BDA for helping this child? Because now she's on sildenafil, and also we are thinking to be add combination therapy for her or going directly to correct the BDA.
First, we have to do right heart catheterization. We have to calculate the pulmonary vascular resistance of this patient. First, by echo, simply, if the patient still have left-right shunting, this is a good evidence that it's still operable, not isomegar anymore, not isomegar yet. If we want to be more clear or more accurate, we have to do right heart catheterization and calculate her pulmonary vascular resistance. If it is below 3, she goes strictly total surgery. for closure. 3 to 5, we have to assess individually, every patient individually. More than 5 is contraindicated. It's as a Menger patient for medical treatment, no role for surgical intervention.
Thank you for mentioning this, Abdurrahman. This proves the point because Abdurrahman just mentioned that they have a good number of cases accumulating in your practice post-correction.
Yes.
Right? And that's a proof of the message from this case that, you know, having a congenital heart disease, the reaction is not straightforward, just go and correct. The things that he mentioned should be done for this patient. PVR should be studied first before making any decision. If this patient, for instance, she's only 10 months, right? So maybe she's suffering from persistent pulmonary hypertension of the newborn, not because of the PDA. So closing a PDA at this time may be very dangerous for her. But obviously, we didn't know the answer until you do the right heart cath and see what is her pulmonary vascular resistance. So the message, I think, if anybody goes from this meeting with one single message, that please do not correct the congenital heart disease until you know exactly what the hemodynamic numbers are, that including the BVR. It's not a reflex action.
Thank you so much. أنا بنأكد بس كلامك يعني نحن we don't close any defect if there is pulmonary hypertension. Better to do cath, then start treatment and recath the patient if showing some response. And also we do vasodilator effect by using oxygen inhalation. Usually we give oxygen inhalation 100% and for 15 minutes. If not responding, we give half an hour. If responding to oxygen, we'll close this defect. Otherwise, we'll not close the defect. نحن عندنا حالات واجدة يعني ال ASD بالذات أنا I have 3 patients نفس طريقة صغار وعندهم severe pulmonary hypertension. I think this patient they have class 1 pulmonary hypertension. It's not due to the heart defect, especially ASD. And maybe the cardiac cath will help us. We'll see the wedge pressure, if it's pre-capillary or post-capillary, and this can differentiate the type of pulmonary hypertension in this congenital heart group patient. But I agree, never close any defect if there is any pulmonary hypertension until we do cath and see the effect of oxygen before we close the defect. Thank you so much.
You know, sometimes in cases like not like this case, the what looks like an ASD, it's due to the elevation of pressure and it's almost stretched BFO, not an actual ASD.
هي دي ممكن تبقى ميس دايجنوز باي ايكو كارديوجرافي من الانكريزد رايت اتريال بريشر فعلا يبقى الانتر اتريال سيبتم ثيند اوت وستريتشد فممكن يدي فول سنسيشن ده دروب اوت. عشان كده احنا مش بنعمل ايكو بس، بنعمل ترانسوسوجيال ايكو بيدينا بقى بيتر اسسمنت للانتر اتريال سيبتم. شكرا جزيلا.
Now we want to conclude the last session. It was really a successful conference. Huh? Oh, there is one more. Sorry.
We are now moving to the last session, and may I call for the chairpersons, Professor Khalid Hussein. دكتور خالد تفضل. It's an honor to introduce Professor Janal Asel, role of ambrisentan in pulmonary hypertension. Professor Noha Asim.
طبعا في البداية اسمحوا لي أكرر شكري أكرر شكري للدكتور عبد الله الضلعان ودكتور أيمن على دعوتهم لمشاركتي معاهم في المؤتمر. والحقيقة أنا استمتعت جدا. يمكن أنا مش من الاكسبرتيز في البلمونري هايبرتنشن، ما اشتغلتش معاهم كاسترايزيشن كتير، بس الحقيقة كانوا اليومين مفيدين جدا ليا، وكان فيهم ابديتس لمسجز كتير. زي ما قال الدكتور عبد الله الضلعان كان في كذا مسج مهمة وصلنا لها، متهيألي دول هيبقوا مهمين في البراكتس بتاعنا بعد كده. طبعا بشكر التشير بيرسونز، ويسعدني ويشرفني ان ابقى معاهم، ودكتوره مروه، وخاصه دكتور خالد ودكتوره نهى. النهارده اسمحوا لي معلش، انا عارفه انا اخر محاضره، وانتم طبعا اكيد ساتيسفايد على مدار اليومين من المحاضرات، بس هحاول ابقى يعني ضيفه خفيفه عليكم شويه وبسرعه جدا يا دكتور عبد الله، ما تقلقش. احنا هنتكلم عن الرول اوف الرول اوف امبريزنتان في البلمونري ارتيريال هايبرتنشن. الحقيقه طبعا على مدار الايام اللي فاتت، او اليوم امبارح والنهارده، يعني على مدار المحاضرات اللي فاتت كنا بنتكلم عن المانجمنت بتاع البلمونري ارتيريال هايبرتنشن، اتكلمنا عن الجنرال مانجمنت، عن السبورتيف مانجمنت، واتكلمنا عن الادفانسد ثيرابي، وقلنا ازاي الادفانسد ثيرابي بيبقى دايركتد للبلمونري هايبرتنشن اتسلف، وان هو بينكلود ميني مولكيولز زي البروستانويدز وزي الاندوثيلين ريسبتور انتاجونست والفوسفودايستريز 5 انهبيتورز، ولتو اليس اكستنت الكالسيوم تشانل بلوكرز، وان البيشنت سيلكشن في الادفانسد ثيرابي كونسيدرد فور بيشنت اللي عندهم ايفيدنس بيرزيستنت بالمونري هايبرتنشن في اكوردنج لل WHO فانكشنال كلاس 2 او 3. طبعا الثيرابي تارجتس زي ما عرفنا من المحاضرات المختلفه، عندنا تو مين باثويز، لا اما الانتسولين باثوي او النيتريك اوكسيد باثوي او البروستاسايكلين باثوي. ويمكن طبعا اتكلموا الاساتذتي قبل كده عليهم بالتفصيل. اللي يمكن اللاين اللي هنتكلم عنه هو الانتسولين ريسبتور انتاجونست، وهو ده عباره عن بمنتهى البساطه بوتنت فازوكونستريكتور وسموث ماسل مايتوجين بهاي كونسنتريشن. الانتسولين موجود في اللنجز في العيانين اللي عندهم جروب 1 بالمونري ارتيريال هايبرتنشن، زي العيانين بتوع السكليروديرما او العيانين اللي عندهم كونجنتال كاردياك شنت ليجنز. والحقيقه ابتدى العلاج بالانتسولين ريسبتور انتاجونست يمكن من اواخر التسعينات، وكان في كذا مولكيول فيه زي الامبريزنتان والبوسنتان والماستنتان. يمكن النهارده اخر محاضره هنتكلم عن الامبريزنتان، وده عباره عن اورال اكتيف انتسولين ريسبتور انتاجونست. هو طبعا سبيسيفيك للانتسولين A وبلاي significant role في الباثوفيسيولوجي اوف pulmonary arterial hypertension. الامبريزنتان هو الحقيقه بوتنت وهايلي سيلكتيف على الانتسولين A انتاجونست، وهو 4000 مره سيلكتيف على الانتسولين A in comparison للانتسولين B. وهو الوظيفه بتاعته ان هو بيبلوك الانتسولين A ريسبتور سب تايب، بيعمل لوكالايزد بريدومينانس اون فاسكولار ماسل فاسكولار سموث ماسل سيلز والكاردياك مايوسايتس، وده بيمنع الانتسولين ميديتد اكتيفيشن اوف سكند ماسنجر سيستم، اللي بيؤدي الى الفاسوكونستريكشن للسموث ماسلز والسيل بروفليشن. الحقيقه السلكتيفيتي بالامبريزنتان دي بتعتبر ميزه، ان هو سيلكتيف للانتسولين A عن الانتسولين B، لان زي اكسبكتد ان انا لما بسيب الانتسولين B ما بيبقاش افكتد معايا، دوت بيساعد على البرودكشن للفوسفودايليتورز نيتريك اوكسيد والبروستاسايكلين، ان ممكن تؤدي للتحسن في السيمبتومز بتاعت البلمونري هايبرتنشن. في اكتر من استادي اتعملت على الامبريزنتان في علاج البلمونري هايبرتنشن، يمكن كان في يعني من اشهرهم او اللي هنسلكت نتكلم عنهم هم اريس 3، ودي اتعملت على دايفيرس بوبيوليشن من البيشنتس اللي عندهم بالمونري هايبرتنشن. خدوا عيانين بجروب A جروب 1 بالمونري هايبرتنشن، واكسكلودد اي عيانين تاني بياخدوا اي اذر ثيرابيز. كانت الام بتاعت الاستادي ديت هي كانت عباره عن اوبن ليبل استادي، بتشوف الافيكاسي وبتشوف السيفتي بتاعت الامبريزنتان على البيشنت باسباب مختلفه للبلمونري هايبرتنشن، وبرده الميديكيشنز كانوا على ميديكيشنز مختلفه. الحقيقه العيانين في الجروب في الاستادي دي خدوا الامبريزنتان بكونسنتريشن 5 مللي جرام لمده 24 اسبوع وانس ديلي، وكان البرايمري انتي بوينت عندهم ان احنا هنشوف لو في تشينج حصل في 6 مينيت ووكينج تيست على اخر الاسبوع ال 24. الحقيقه النتائج كانت بروميسنج معاهم، ولقوا ان في تحسن في السيمتومز وتحسن في ال6 minute walking تيست في العيانين دولت ان كومباريزون للعيانين التانيين اللي ما خدوش. ده طبعا كومباريزون للعيانين اللي خدوهم وتحسن في ال6 minute walking تيست، ما كانش في اي ريسك ايفنتس حصلت للعيانين دولت او موربيديتي الزياده نتيجه لاستعمال الدواء. وطلعوا من الاستادي ديت بخلاصه ان هم لما يجوا بيكونفيرم ان الاستادي ديت ان استخدام الامبريزانتان كان ويل توليريتد benefits للعيانين بتوع البلمونري هايبرتنشن، لكن definite conclusion regarding السيفتي والافيكاسي بتاعت الامبريزانتان في السبيسيفيك نون جروب 1 بالمونري هايبرتنشن ايتيولوجي ما كانتش قادرين يحددوها في الاستادي دي، وكانوا بيريكومند ان احنا نبتدي نشوفها على other populations. جت بعد كده اللونج تيرم امبريزانتان ثيرابي، ودي بمنتهى البساطه خدوا العيانين بتوع ارياس ستادي ارياس 1 وارياس 2 وعملوا اللونج تيرم سيفتي، كملوا معاهم في العلاج لمده سنتين واستخدموا اكتر من كونسنتريشن 2.5 مللي واستخدموا ال 5 مللي واستخدموا ال 10 مللي، وبداوا يشوفوا السيفتي والافيكاسي مع اللونج تيرم يوز. وكانت الفتره اللي استعملوها هي زي ما قلنا السنتين. اتقسم العيانين راندومايزلي على 3 جروب زي ما قلنا على حسب الدوزز اللي استعملوها، وكان مشارك في الاستادي دي في الاول 383 عيان اللي هم كانوا اوريدي في سيريس 1 و2، وبعد كده اللي كمل منهم طبعا في النص كان في عيانين حصل لهم ديث وفي عيانين ادفيرس ايفنت او كده، لكن اللي كمل معاهم في اخر 2 years ابتدوا ييفالويت المانجمنت بتاعت العيان الاوتكم بتاعت العيان، لقوا ان 6 minute walking test استمرت في التحسن في اخر السنتين، ولقوا ان الليفر انزيمز او السايد افكتس او الهازردز اللي كان ممكن تحصل قليله مع العيانين في اخر السنتين، وطلعوا بكونكلوجن ان اللونج تيرم يوز في امبريزانتان على مدار سنتين ادى الى سستيند امبروفمنت في الاكسرسايز كاباسيتي الديسنيا وستابلايزيشن للدبليو اتش او فانكشنال كلاس، وان في لو ريسك اوف كلينيكال وورثنينج اند ديث، وكان في اكسبتبل سيفتي بروفايل كان سيميلر للاستخدام على مدار 12 اسبوع بس، يعني كانوا ما بين ال 12 اسبوع والسنتين لقوا ان السيفتي ما فرقتش، وكان سبورتنج طبعا اليوز للعيانين بالامبريزانتان فور لونج تيرم مانجمنت. بعد كده طبعا جت الامبيشن ترايل، ودي كانت الترايل اللي بتتكلم ان احنا لا ده احنا عايزين اكسبلور السيفتي والافيكاسي، ان انا من الاول ابتدي بالانيشال، ان انا ابتدي بالكومباينيشن ثيرابي زي ما كانوا اساتذتنا بيتكلموا النهارده ان احنا نستارت بالكومباينيشن، وفي الدراسه دي استخدموا الامبريزانتان مع التادالافيل، وبداوا يقارنوهم بمجموعتين تانيين، جروب استعملوا فيه التادالافيل لوحده والجروب الثاني استعملوا الامبريزانتان لوحده، ودي سموها الامبيشن ترايل، والحقيقه اتعملت على حوالي 500 عيان على مدار 24 اسبوع. الحقيقه لقوا في المقارنه لما اتعمل وكان في راندومايزيشن للعيانين، على اخر الراندومايزيشن دوت لقوا في المقارنه ان الكومباينيشن ثيرابي كان في المقارنه مع الكل مونو ثيرابي لوحده كان احسن بكتير. يعني هنا البارتيسيبنت هنا ما فيش اي طبعا الافكس او السايد افكس او الموربيديتيز والمشاكل اللي حصلت من الدواء كانت قليله في الكومباينيشن مع بالمقارنه مع المونو ثيرابي. لما قارنوا الكومباينيشن مع كل مونو ثيرابي لوحده كان الاوت كم والافيكاسي اعلى في الكومباينيشن ثيرابي، ودوت خلاهم يطلعوا بالريكومنديشن ان الانيشال كومباينيشن مع الامبريزانتان مع التادالافيل كان فيها significantly low امبريزانتان لوحده اللي طلعت باستخدامه in combination. وصلنا اسرع محاضره بس
محاضرة رائعة وحقيقة محاضرة جميلة وواضحة يعني. اتفضل.
مساء الخير. انا سريعا بس هقول بس حاجه على الجاردوفاز الامبريزانتان. هو فيرست امبريزانتان في الايجيبشن ماركت. هو احنا اوريدي عاملين بيشنت سبورت بروجرام، ممكن ده يكون مفيد للبيشنت. هو عاملين 2 ستريبس عليهم 1 ستريب فور فري، فبيبقى مانثلي كوست للبيشنت 924 جنيه بدل 1300 جنيه. طبعا كومبيرد بالاذر برودكتس الموجوده طبعا ده فرق كبير. كمان لينا الاميونيتيز توتال بورتفوليو للاميونيتي بوسترز اللي ممكن تسبورت في فتره الكوفيد اللي احنا فيها دي. انا بشكر حضراتكم جدا. ميرسي.
كده احنا بنوصل لل end of session والف مبروك للنجاح الرائع لهذا المؤتمر الراقي المتخصص للمجموعه السعوديه لمرض ارتفاع ضغط الشريان الرئوي، ودكتور عبد الله ودكتور ايمن. واتفضل دكتور ايمن طبعا يقول لنا
يعني كلمه اخيره. in fact احنا we have our progress in the pulmonary hypertension. Actually we cannot ignore the role of industries and the pharmaceuticals in order to support our activities. And when I mentioned the international pharmaceuticals that help us to know and interact internationally. But nowadays we have national companies like AOG, Habib, and EVA. Actually, they support our patients and they bring the drugs that we couldn't touch before. And actually, this is a very good service that we can afford to our patients. So we have all the brands, we have all the kind of treatment that we can give to our patients, and we are looking for the IV. You, Dr. Abdullah, for
You are a great representative of your society and your people, Dr. Ayman, and شهادتي فيك مجروحة. You are an old friend of mine for many years now. I think what we intended to do for this for cooperation between our two societies is in fact to get the interest of people, like what we have mentioned, what we have noticed the last few days. People are really interested to learn more about the disease and the diagnosis. And I can tell from, I think 4 years ago, when you invited me to give a talk in your conference, chest conference, I can tell the difference now between those days and these days, how many people are now more interested in taking care of pulmonary hypertension patients, but more than that, how much the knowledge has matured significantly. I think now the people who are taking care of pulmonary hypertension here in this country, as good as anybody else elsewhere in the world. Maybe there are some shortage of medications, but this is also improving dramatically for the last few years. I also have to thank my colleagues who came all the way from Saudi Arabia to participate in this meeting. Some of them, in fact, had a meeting today. So they just came for 12 hours. They gave their speeches and went back to Saudi Arabia to attend their other meeting. I would like to thank the chairs as well and the audience for their participation. I have to thank also the industry for their support, and Congo Group for their great organization as well, and accommodating all the requests from everybody. Thank you so much for that. And I also have to ask the audiovisual people, because I think we have maintained very good audiovisual level. This is the first conference of our cooperation between the two countries, but definitely will not be the last, inshallah. We're planning, as Ayman said, to make a SAPH chapter in the annual CHEST meeting, whether within or around or before or after. So we will discuss it in the future. I have also a plan. I don't know how gonna work, but with having an exchange visiting professors between the two countries, can spend 1 week or 1 month in our centers here and there. Maybe we can even exchange fellows who are under training to be exposed to different experience between the two countries. So the potential for cooperation is unlimited. The intentions are there and the capabilities are there, inshallah, and we will do that. Thank you everybody for sticking to the last minute. It's already late in the day and it's already Friday, but thank you so much for that. And I hope to see you in Jeddah, inshallah, in 2022, SAPH 2022, which is February 17 to 19 in Jeddah. I also have to thank the Libyan group who just came, from Libya and really participated nicely in the discussion. Thank you so much. We have our doctor from cardiology who is asking very good questions, and that really indicates that also the level there is as good as any other place. Thank you so much for everything, Dr. Ayman, and hope to see you in 3 weeks in Jeddah. Thank you.